I know it's the last day, and usually we are a little bit more relaxed, which is a very good thing, but it's for a good purpose. It's for a good cause that we want to start on time, as we said, and finish on time, so that you will have more time today over lunch and after lunch. And then, of course, we want, please remember, for all workshops in the afternoon, we will be on time, so that we also have, everyone will have enough time to prepare for our farewell dinner. So the next presenter, so the first presenter today is a young investigator who is very famous. He's, I think, about 35, 38 years old. And so Eric, but Eric will not be with us today for some very important reasons. So Menno Huisman, the next youngest investigator after him in Leiden, so he was authorized to give his presentation. Menno, I say nothing else.
Good morning. You are unique. This will be now the sentence of the morning shift from the night shift in my hospital from now on. I'm very privileged to replace Eric, and I'll have a short message coming in a minute. So I got the slides from Eric. And of course, that's why the Center for Thrombosis and Hemostasis is on the right panel. And this is important because this is all about Stavros, Eric, and myself. And this is for gin and tonic and tea with rum. But this is crucial for cooperation. You can do everything on your own. This was what Giannakoulas said when I was joining him many years ago. I told you yesterday that Marcel Levy, as a student, at the advice of his father, was a general practitioner and a fantastic man, and a close friend to Jan Wouter ten Kate. Who has ever met Jan Wouter ten Kate? Not many of you, and this is because Jan Wouter is much older, even older than I am, and he died last year, sadly, at the age of 85. And Jan Wouter has been instrumental for cooperation in thrombosis, not only in Europe, but in the world. He was a symbol for us in Amsterdam. And at that moment, I never realized that you should do the same. And that came back at that very moment when Eric joined the Center for Thrombosis and Hemostasis in Mainz. And I won't go further, but the anecdote how Eric landed in Mainz is very nice and had nothing to do with the will of Eric and everything with the will of Stavros and myself. This is how you shape the world. At the same time, here we have the Leiden University. Leiden University is the oldest university of the Netherlands. There's a nice other anecdote. Because it was constrained, because they thought they were the oldest, but in fact they were not, because when they were initiated as a gift by the Prince of Orange, William of Orange, who was a vagabond, he didn't speak Dutch, he only spoke French. He was raised in Brussels, and anyway, it was still Kingdom of Spain. So it's not the oldest university of the Netherlands. Groningen is the oldest university, 1614, because they were coming on when we were separating from the southern part of the Netherlands. Okay, now we go to the subject. Screening for CTPD and for most CTEPH, because the subject of this morning is CTEPH, and this is, of course, a very intriguing disease, and in the natural course of pulmonary embolism, you can't do without them. But they're two excellent speakers, and I'm only giving a sort of trait d'union to this, and I can never replace Eric. Now, these are fresh clocks, not clots. And as I yelled yesterday, because I was so happy, I got the message that Pim Jacob and Joep Frederick were born yesterday in the midday. You could see this as planned, because Eric plans everything, but Maria, his wife, of course, did the job, and she is in very good shape. The boys are in very good shape, and Pim and Joep are looking here like small kittens, as some chair of the spring school said to me this morning, but they are really human, and what a wonder, what a wonder. So let's give a very big applause to I could tell you much more on Eric, Maria, but I won't. The only thing is there's a problem. This morning, just Piotr asked me how well is the family. I said, well, Eric has a serious problem because he can't work. And this is a serious disease for Eric. But and then Stavros said, well, if the babies would have been born last night, that would have been perfect because the sight of the newborn babies, he could write a review paper. Anyhow. I go on. So it was funny because I looked at the disclosure of Eric and they're virtually the same as mine. So I just put in my name there, and we have no conflicts of interest for this lecture, but we have a lot of, not conflicts, but we have agreements with a lot of bodies, and I'll just show you this for a minute. Now, natural cause of PE. You might doubt, but this is a rough estimate, 50% complete recovery. You know, we are busy with a lot of things that bother the patient, but let's not forget PE in general, without the extremes, is a disease that can be treated, and it goes away because of our beautiful fibrinolytic system. And at the same time, that of course means that 50% reports persistent worsening dyspnea after 6 months. And this is, at least was underestimated by internists in my country. In my country, there is always a nice battle who treats the patient with pulmonary embolism. It's either internal medicine or pulmonary medicine, never cardiology. Only cardiology. I said yesterday, when you want an echo at the emergency unit, cardiology is always partying or in the cath lab or partying in the cath lab. They're never there, as an anecdote, you know, in Leiden. They're only there when there's severe pulmonary embolism. And there's another subject that could go on for hours. We have now also, we call it Alert, but PERT Europe team in Leiden, and this is very interesting. And then they're coming back. They're very interested in the severe parts, and that is very logical, and then for most with interventional cardiology. Anyway, we underestimated it. Why? Because we gave vitamin K antagonist, and this was in the Netherlands a bias because it was controlled by the thrombosis service in the Netherlands, a unique system. But they don't only control, but they also control a bit of the management and the patient. And even it's not done by the general physician. So the patient with pulmonary embolism just leave the hospital after hospitalization in the former days when Hestia wasn't present, neither as busy. And, you know, you didn't know about the history. Okay. So it's important that the dyspnea, which is very central, of course, can be PE related, and of course it could be inhibited CTEF developing. The so-called dead space ventilation, I never understand what that is, but then I ask my pulmonologist colleague. And you can have exercise-induced PH, persistent right ventricular dysfunction, and also the buzzword deconditioning. I also never know what that means, so somebody will tell me afterwards. Okay, but they can also be non-PE related, so existing or new cardiopulmonary comorbidity, importantly. And on the back, or on the, you see a lot of contributing authors. I'm not gonna tell them all, but you see it when you see back the slides, and I told you before, all slides of this spring school will be available for every attendance, including faculty. So you don't have to ask them, you don't have to steal them, you just get them afterwards with a short password. Is it correct, Stavros? And you are not allowed to give that password to Joe Biden or Xi Jinping, of course, because then they have to get their points here. Okay. So the post-PE syndrome. Now this is interesting. It's always important, or sometimes important, who is the first who come up with this term? That's interesting. Eric is very modest. I always claim, but this is heavily biased towards Eric, that he came up with the term and also used it, not only conference, but also published. But there is Suzanne Kahn in Canada, who is also a claimer, not too much, but anyway, look it up in the literature. Yesterday, Marcel Levy was hinting on these COVID publications, and it was nice that he thought that Klok was the first to report on thrombosis. Well, that's another story I'm going to tell you at the tea. Anyway, the post-PE syndrome, and this is nice, and it was a bit of obvious and surprising that we didn't talked of post-PE syndrome. In the Netherlands, for the bias I told you before, because we thought PE is treated and then that's it. We had PTS, prothrombotic syndrome, also quite enigmatic for many, many years, but not post-PE syndrome. But now we have it. And we have reasoning, and of course we study it, and these are the features which are important, and this is from Juliette Boon, is a PhD of Eric, and she published this last year in, I think, a very nice journal, by the way, Research Practice in Thrombosis Hemostasis. Look it up at the website, it's an open access journal. It's a bit of a yin-yang with the Journal of Thrombosis Hemostasis. Mary Cushman is inviting you to publish there. It's a nice journal, I think. So it can be CTEPH, CTEPD, and within these breakdowns, chronic right ventricular impairment, functional impairment, pre-existing comorbidity. So this is coming back to what I just showed you before. Read the paper if you have time, and if you don't have time, still read it, because I think it gives a nice overview. This is another, I think, nice picture made by Yvonne Ende, another PhD of Eric, and this was published 4 years ago in the European Respiratory Journal, the flagship journal I read this morning of the European Respiratory Society. And this is intriguing. Let's look at it a bit more careful. So all comers, including patients who died, then it's 0.56% incidence of CTEPH after acute pulmonary embolism. So 1 in 200. But, of course, there are also survivors. And then it is increasing. And then it's very close, this figure, to the Pengo study many, many years ago. And we always thought that Vittorio Pengo, he's a nice colleague, Italian colleague, cardiologist, but he was exaggerating the incidence. But after all, he was quite right. There was a lot of discussion, and it was a seminal paper in the New England. And so it's interesting sometimes to go back in the literature and just compare the literature now with that, for instance, from Vittorio Pengo. I advise you to do it. And then without comorbidities, you know, it's a bit less, 2.79. And the background of my talk is, will we always do echocardiography? Now, this is a bit of a Leiden bias, and Eric came up with the fact that you can evade the echocardiography because it leads to overdiagnosis not only because the specificity for CTEPH for echocardiography is much less than 100%, but it was nearly 10% based on echo. So you have to do a bit more. This is, of course, for discussion. And on the other side, to exclude CTEPH, as you will see in the study we published in Shape 2, you can even evade it. So 3 interesting observations. Pengo was right all along. Thank you, Vittorio. CTEPH occurs in patients with pre-existing comorbidities. It was a second point. And what Eric's opinion is, and I can imagine, but on the other side, you know, and Stavros doing this, you know, echocardiography is not CTPA, it's not MRI, so it's not so difficult. But for sake of the argument, so this is really what is going on for CTEPH in clinical practice. Still nowadays, although we press the button, we inform colleagues. It's also very important, of course, to inform general practitioners who have 8,000 diagnoses around every day. But they also have to think of, yeah, this patient is dyspneic. And we know all about the long stories of patients until they come to the hospital and the diagnosis they've made. And I will show you in a minute. And this is it. So we did a diagnosis of CTEPH patient in clinical practice. And now I'm going to tell you that I show a lot of slides with the close cooperation Eric, but also myself in the background have with the Free University Medical Center and per se the Department of Pulmonology of Anton van Noordergraaf, Anke Boonstra, and Jan Bogaert. And also, of course, Lilian Meijboom, who is here, because she forms the research group from the radiology side, and this is beautiful. And there is, by the way, a typo. You know, Eric is perfect in nearly everything, but he sometimes is a bit word blind. So I like this. I didn't change it per se. No, I just saw it the other minute. Hemostasis. So median diagnostic delay, 24 months, up till 49 months. This is true. We look back, and there was the long journeys up to the psychiatry. Everybody knows this. You know, I'm dyspneic. No, you're not dyspneic. Yes, I am. No, you have psychosis. That's it. Okay, 4 different physicians, 13 consultations before correct diagnosis. And the suggested diagnostic results remain unrecognized, diagnostic workup not in accordance with guideline recommendation. And I will show you another picture of the European Society guidelines. What would we be without it? So, needs improvement. How bad is delayed diagnosis C. diff? Because you might even say, yeah, this is a natural history and it goes on, a patient just works. And no, there's an influence. This is a bit of a complicated graph, but this is PA not performed and PA performed. That doesn't make much of a difference because the flow of the curve is the same. Longer delay is associated with higher mean PEP, 5 milligrams per tertile, higher mortality. So this is an important message. You should not delay the diagnosis C. diff. And they're tricks. And this is another graph just published in ERG Open, the same author, Juliette Bohn. And you know, qualities of life, this is interesting. I'm not a health economist, and who is here? Who is a health economist in this audience? Who calls her or himself? Nobody, no. Happily not. We're doctors, okay? But of course, diagnosis and treatment cost money. It's an open door. That patient is the cheapest patient, you think. But in terms of quality of life, of course not. So if you have a shorter delay, it increases cost, but it much more increases quality of life. Years gained. This is the only slide I didn't understand at all. And you would agree with me, but I remind myself that the impact of treatment on utility, this is a figure you have to remind yourself, 44,653. And this is why we are not health economists, isn't it? I apologize for this. But I will go back to Juliette and she will offend me, of course. Okay, always room for improvement. And this is a typical joke from Eric. He laughs himself out of his mind. And it's a bit funny anyway. Okay, we're too busy. So how to diagnose earlier? Some tricks. Consider, it's a bit open door, but still, be vigilant. Consider C. diff in all patients with post-PE syndrome. And what we do now routinely, patient comes in after 6 to 8 weeks. After that patient has been seen, by the way, by a nurse after 1 week, because we just changed our policy. Patient come at the emergency unit, just for a moment on the side of this talk, with a potentially deadly disease, and then they leave the hospital after being Hestia 0 with a prescription for apixaban. And then it's finished, it's nice. But the patient, of course, is worried. So we follow up after 1 week, telephone call, video call, explain things. If patient is worried, patient comes within 1 week to one of us physicians. Afterwards, 6 to 8 weeks. But after 6 to 8 weeks, of course, one of the burning questions, just simple complaints. Dyspneic. If the patient's still dyspneic, some alert, okay? Focus on the signs, and that's the second message, of C. diff at the moment of a PE diagnosis. And signs, I mean really imaging signs. I'll come back to that in a minute. Again, the cooperation with the Free University Medical Center. Either, of course, then, if there is a suspicion of C. diff, that's another way than screening for C. diff without symptoms, another ballpark, or CTPA evaluation. Now, echocardiographic clues, excuse me, association there is between vascular obstruction and PAP. In acute PE, even very high embolic obstruction doesn't lead to severe PH. It was a bit of challenge, I think, yesterday by Andrew. So, of course, I'm not the expert in this, and it's maybe some question for discussion. And Eric just authoritatively said, but based on literature, a PAP of more than 50 to 60 millimeters of mercury is suggested of C. diff. That's nice work of these authors. The clues, C. diff is frequently misclassified as acute PE. This is a very nice publication from France. It's a group of Olivier Sanchez. Guérin is the first author, published some years ago. A cohort study, and that also of the group of Guy Mayer, to remind him another time. And out of 146, 7 were diagnosed with C. diff, 4.8%, a bit higher, maybe due to patient selection anyway. 5 of 7 of these had PAP of 62 to 102 millimeters at baseline. And all 7 had at least 2 signs of CTEPH as baseline, versus only 90% patients who did not develop. So you can do work at the presentation of acute PE. And of course, there is never time, but a short look back after patient presented at the emergency unit can give you these clues. Okay? So, what about the work we have done with the Vrije University Medical Center? 50 PE patients with baseline right ventricular dysfunction, no CTEPH, and 50 PE patients diagnosed with CTEPH in follow-up. And they all come this Vrije University Medical Center, one of and the foremost center for CTEPH in the Netherlands. There's another one in Nieuwegein, but this is the prominent center. There was blinded reading of index CTPA by 3 expert radiologists, among which is Lilian Meijboom. Signs of acute and chronic PE, signs of PH, and presence of CTEPH. The sensitivity of this, it was not perfect, but it was okay, and the specificity was very high. You can read it in this journal, Journal of Heart and Lung Transplantation. And this is interesting. There are a lot of figures, but the message is in the next slide, but you can see this in the publication. We did baseline imaging reading in patients who later on had not developed CTEPH, and we looked at the change in these imaging signs. And we also did the same for the patients, there was one cohort, who after all developed CTEPH. Now you have one example. This is the web at acute presentation of acute PE, but the web already present, and that did not change at follow-up despite of anticoagulant treatment. And the same is for a tapered artery, did not change acute presentation of PE, but a hidden CTEPH, what it seemed, and this did not change. And this is another example. So I just put in the results here also for reminding myself, and conclusions, central thrombi resolved after anticoagulant treatment. So they are likely to be the fresh clots. Yesterday I had an interesting discussion at dinner with Andrew and Leo Buitelaar, and we were discussing whether you can do better imaging at the moment of acute PE and looking at whether a thrombus is fresh or older. Because if there is for most older thrombi with fibrin, etc., thrombolysis, catheter thrombolysis is less likely to help you in the acute phase. And thrombectomy comes at its place. Get out the old clots. Interesting. Muir thrombia and total thrombus, the conclusion, either resolved or evolved into webs or tapered pulmonary arteries. The natural cause of an acute PE without a pre-existing CTEPH. And only patient with an ultimate diagnosis of CTEPH exhibited webs and tapered pulmonary arteries on the baseline scan. Moreover, such lesions always persisted after follow-up. Of course, it's a limited population. There'll be outliers in your practice, but still. So, as a message, webs and tapered pulmonary arteries at the time of PE diagnosis strongly indicate a state of chronic PE already present. And it seems logical for this educated community here after this spring school, but I'll tell you, in general practice, this is not common knowledge. And I think the key message is here that you train your fellows, but the radiologist should train, and Lydian should commend, and I think she already built it in one of her courses she is holding. She may comment in the discussion. So it should raise awareness for possible CTEPH, particularly a patient with persistent dyspnea, of course. We're talking about the symptomatic patients. Okay? Now, this is only to give you an overview because it was a review of Marion Dacroix from Leuven, and there, I'm not going to read it, of course, but you can read it back. The clues on CTPA for acute PE and CTEPH, and this is merely also reflecting the article I just showed you. And this goes on. Marianne likes long tables, but this was the overview, so this is nice to read back. Now, definitely not all, but there is more. Choose wisely, don't do too much, don't do too less, we know that. Why would we order any diagnostic test? Well, this is already said. to diagnosis per se in a patient with symptomatic possible CTEPH, to rule out CTEPH is of course even more important, and to explain persistent dyspnea or function limitation. Now I'm gonna put this for sake of time. So we have 3 imaging possibilities. Briefly, echocardiography, assess the level of probability of pulmonary hypertension, sensitivity high, specificity high. The VQ scan, you know, it's a bit of coming of age, but still has some a role, I think. Lilian should comment, not me. It can show unmatched perfusion defects. Who routinely does VQ scan still in practice when we are looking for CTEPH? Can you raise your hand? Okay, still some. And who does not use it but uses CTPA? Or angiography, routine angiography? Okay. Echocardiography? Yeah.
It's not one test, it's an algorithm, right?
It's an algorithm, that's the answer. Thank you, Stavros.
There is no one test to
It will come back, it will come back. Sensitivity, good. Specificity, not good. We know this of VQ scan, of course. And then we have this exercise test for looking for ineffective ventilation with elevated alveolar capillary O2, CO2 gradient. Okay. So, the best practice, evaluation presence of pH and screen for heart disease, echocardiography. Like Stavros said, it's an algorithm that will come back. The workup of echocardiographic signs of pH, still with a VQ scan, and rule out the CTEPH and CTPD with great certainty. And then lastly, if you do this test, exercise test, analysis of non-specific dyspnea, we have quite a few patients you cannot work out, and then you say, well, I will put you on the bike, and you will come back afterwards. And that's lovely, because then you can do other things. And assess the presence of dead space ventilation. Now here's the famous algorithm. I'm not gonna put you through, but just read the guidelines. Who has never read the European PE guidelines? Be honest. Who has never seen this? Very good. Okay. So you have time on your flight back.
No, before she can be invited to the dinner.
Well, it's very short. How many pages?
You cannot have the
How many pages do we have? What is, well, anyway. Yeah, okay. Okay. How many times it was cited, the guidelines? 3,000.
So the 2019 guidelines, I can check and tell you, I think it's...
But then it will have been changed. Well, anyway, my advice is be a member of committee guidelines. This is good for your citation index if you think that is important, and that's another discussion. The age factor is overrated, and the citation of the journals are ludicrous. New England is higher than 75. It's like the tulips in the 17th century. Tulip mania. Anyway, so this is a way to go, and you should look carefully for yourself, and this is coming back, what Stavros just said, this is logical. And for a disease which is not very prevalent, because PE every week, every day, you really have to go back to this slide in your computer for most, and just discuss multidisciplinary wise. And that is what you should do. So don't do it on your own, or at least just spar with a colleague. Now, my final slides. This was published in Thorax together with a lot of investigators. They're all here in the audience, I'm going to mention them all. But what we tried to do is to evade echocardiography, really. And we had a prediction score developed by Eric some years ago, and we put that into practice, and that was a breakdown of 6 points or less, or more than 6 points. And we had seen before that if you have less than 6 points with this prediction score, very simple items, the chance of getting a CTEPH is very, very low. So no presence was nearly half of patient. And specific symptom present, 21%, and then we used the rule out criteria And if there were no EKG criteria present and normal anti-proBNP, we had a specific program for looking at the EKG, and we put in the anti-proBNP, and there was another 141. And then if patients had really a suspicion, we put echocardiography and further on right heart catheterization. And that ended up that we only needed echocardiography in 90% of patients. Primary outcome failure rate only 0.29%, so only one patient. And echocardiography avoided in 81%. And we had secondary outcomes, CTEPH incidence 3.1%. Hey, that's a known figure. And CTEPH diagnosed, importantly, less than 4 months in 77% because we were concentrating on these patients. So we think that with this algorithm, if you have low resources, you can accurately execute CTEPH after acute PE, avoiding echocardiography 81%, and substantially early detections of CTEPH. One word about COVID. Is COVID associated with CTEPH? Okay, that's a nice question. A lot of thrombotic events. Marcel Levy has told you this. VT incidence varying on the ICU. Several reasons to expect high CTEPH incidence. It's a bit of a fulfilling prophecy, self-fulfilling prophecy. High numbers VTE, inflammatory condition, missed VTE, and in situ thrombosis. But whether that will be true, it's doubted. Yesterday there was an interesting discussion, is 3 months anticoagulant treatment enough? Yes, because it's such a gross risk factor, the COVID, and when that goes away, you can stop. We don't know for sure. CTEPH can and should be diagnosed earlier. Important echocardiograph CTP clues a diagnosis of PE, targeted education of radiologists is software, but also education of physicians who see the patients at the emergency unit. And afterwards, validated algorithms are available. Look at the ESC guidelines, maybe look at our paper for interest, and really have awareness for post-COVID-19. Whether that will be, we don't know. Thank you very much.
Thank you very much, Menno. And as you can see by the fact that almost only Eric's and the group's work was cited, I mean, how much work has been done on this field, right? From PE to CTEPH, and that's really enormous. I mean, the only comment I want to make, which I think shows that we actually all completely agree, it's about optimizing the use of resources. There is no single test to exclude or to diagnose CTEPH, and this stepwise approach, the algorithm, of course, can be adapted to the needs of the country and a center, but we do need these algorithms. Algorithms may be difficult to remember, but they are logical steps. And here I must ask my favorite question, perhaps those of you who are here, where does the word algorithm come from? It is a Greek word. Is it a Greek word? Does it come from rhythm? Does it come from arithmetics? Or Professor Vico, I think, should not have answered this. He knows it. So where does the word algorithm comes from?
I'm not sure, but probably it's Arabic. Scientist, al-Khwarizmi.
Yes, it is not a Greek word. But do you know why it is called algorithm? So was he called algorithm, this Arab scientist?
Al-Khwarizmi, I believe his name.
So that was indeed a mathematician. Eric, you will be, I think you will agree, one of the most important mathematicians of the 9th century. He had the Arab word Muhammad al-Khwarizmi. He was not Arab. He lived somewhere where is now Iran or Uzbekistan, right? So he was in Central Asia. But he was the first person who really described, he was not a PE scientist, but he was a mathematician, and he described logical steps. So if 1 is right, then do 2, then if 2 is right, do 3. So this is really great. And the other thing is, of course, as you say, you have to optimize the use of resources, but even in Leiden, one should not be afraid of echo. People think that you need cardiologists, you need 1-ton machines. I mean, as you can see in our hands-on workshop, things are getting very simple for basic diagnosis, for basic suspicion, and thanks to Dutch technology, by the way. I mean, that's from Philips. So, questions, comments, please. Professor Giannakoulas has certainly... Oh, the other microphone is...
So thank you, Menno, great lecture, and thank you to Eric as well. So just a couple of comments or points to discuss. The first is, as correctly as you pointed out, it's very important to focus on the index event of acute PE, and maybe echocardiography close to discharge is very, very important. So I should very early diagnose or catch these patients. I partly disagree with the fact that the echocardiogram in all patients may overdiagnose as Eric points, that may overdiagnose the incidence of CTEPH in all patients. I think the main cause that we do not perform echo to all acute PE patients after the episode is cost. So as you correctly point out, it depends on the resources of every country. In Greece, for instance, echo is very cheap. It's very easy to do an echo. It's like, you know, going to buy to the groceries shop. It's very easy for the patient. But in some countries, I did my practice in UK, where echo is very expensive. It's difficult to have it as an outpatient. So I think this is why we should focus on the index event when we have the patient inside the hospital, and close to the discharge, we should perform an echo maybe to all patients. I think this may be an early catch the points that you pointed out from the echo point of view. Yeah. And the other thing that you correctly said is COVID. Post-COVID CTEPH is, you know, we really don't know now the exact incidence. But the majority of the patients that are symptomatic are not due to the CTEPH, are due to the long COVID, which is mainly lung-induced and not thrombosis-induced. This is what I believe. Thank you.
Thank you. Thank you for your comments.
And exactly, and as Professor Huysman also said, and as Eric says, though, it is absolutely clear, echo cannot diagnose CTEPH, right? I mean, echo is only here to say if there is some probability and then search further. But as you say, Menno, if you do, as for any method, if you overuse it, of course, it's not as bad as with CTPA, but nevertheless, it can also lead to too much actionism. Further questions, comments? We may discuss further also during the following presentations, and I think this is also the best opportunity first to thank Professor Huysman, who will say that this evening, for all that he has done, not only for PE but also for these spring schools, and also to particularly congratulate Eric, who is really one of the leading younger scientists in the field, if not the leading. Has done an enormous amount of work, and he really shows, I mean, he has also supervised and still supervises so many younger colleagues, I mean, to really try to find out the mechanisms of disease and how to proceed logically and try to diagnose or exclude disease. Menno, please.
Yeah, he is still young, but next year he will not be young anymore, and this is very pertinent. If you come to the next decade, then your youth is gone. So he's still a young, promising scientist.
If you're over 50, it comes again. That's a good thing.
Yeah, then that's another ballpark. Then I will say this in my summer house and behind the flowers. Okay, thank you very much.
Thank you, Menno. Thank you so much. So we continue immediately. George Giannakoulas from the University of Thessaloniki. He's a cardiologist. Sorry, man, we have some cardiologists here. So George is together with Piotr Pruszczyk, who will be speaking immediately after him, and with Eric and with Stefano in the nucleus. I mean, Piotr and George are the leadership of the work group on pulmonary circulation and right ventricular function at the European Society of Cardiology, with strong participation of the European Respiratory Society. So George will not speak us about CTEPH, but about something which is complementary and is closely related. How do I follow after PE?
So thank you very much, Stavros, for the invitation first. And this is a great young team here, great audience, great venue in Crete. So congratulations for the spring school. Actually, as Stavros said, I'm an associate professor in cardiology. I'm based in Thessaloniki, Greece, which is a 1-hour flight from here, in northern Greece. And I run the pulmonary hypertension clinic. So actually, we made a discussion with Eric. He presented the CTEPH. I present the thrombosis part. So maybe the correct thing was I could present the CTEPH, Menno could present the thrombosis, but then it's becoming somewhat complicated. So
you
Yeah. So I'll focus on the thrombosis and the anticoagulation issue, and then present some slides about CTEF. This is my disclosures. So first of all, we'll try to answer this question. Is the VT or P recurrence really a problem? Maybe you've seen this slide before. As you see here from this image, the closer you are from the index event, the bigger the probability of the recurrence. So this is a meta-analysis of 18 studies. You see that 1 year after the event, the recurrence rate is high, almost 10%. Then it goes down second year to 6.3%, and then it goes lower and lower. So the cumulative incidence after 10 years of recurrent VT is 36%. So 1 out of 3 patients after acute PE or DVT will have a recurrent event. This is not a small number, as you can imagine. So after knowing the incidence, we can reply this question. Can we identify higher risk patients for VT recurrence? This is, again, a very important issue because not all patients are the same. The modern way of medicine is individualizing. So identifying higher risk patients in all cardiovascular diseases. So let's talk about VT. So this is 3 risk assessment tools for VT recurrence. I don't know if you are fond of scores. You have easy access, iPhone or your PC. You can easily calculate the recurrence. But you know, this was a trend towards, or enthusiasm towards using these scores in all cardiovascular diseases maybe 10 years ago. I think it has faded lately because not all patients are the same. These scores, all scores, even in coronary artery disease and acute coronary syndromes, these scores were over-exaggerated some years ago, but if you see the latest guidelines, very few of these risk scores are implemented in clinical practice. The reason is because we don't have strong validation. We cannot apply all these scores to all populations. So, for example, you see this HER2, for example, this HER2 2 score includes D-dimers, you see here. But then we had this paper from the New England almost 15 years ago, which focused on the use of D-dimer testing to determine the duration of anticoagulation therapy. And even in patients who had a negative D-dimer after the PE event, VT recurred in 6.2% of the patients, which is a significant number. So this, of course, we cannot use D-dimers to all patients to determine the risk of VT recurrence. So this is very important to remember. So another question is extended anticoagulation with a VKA a solution? Of course, we don't use VKAs in 2021 in the majority of the patients, only in a minority, but let's go back a little back to the history. So this is a New England paper. You can see the old background of the New England here. And you see this paper compared 6 weeks of oral anticoagulation to 6 months of oral anticoagulation. First paper, almost 1,000 of patients enrolled. So at 2 years follow-up, in the short-term observation of the 6 weeks, 18% recurrence versus 9.5% in the 6-month group. So the first message is the lower you prescribe anticoagulation, the longer you prescribe, the lower the VT recurrence rate. And the most important thing is that major bleeding rates were similar. So this is a very important message almost 25 years ago. And then we come close to 2021. This is a meta-analysis of 2015 that says if you prescribe even longer for 1.5 years anticoagulation compared to a shorter term of just 7.5 months, again, you have lower VT recurrence. So the more you extend the anticoagulation, the more numbers of of patients, you prevent the recurrence of the VTE or PE. So maybe someone will ask, then we could go to a lifelong therapy with a VKA after VTE. Yes, this may be true in terms of recurrence rate, which is reduced by 90%, but the major issue is the major bleeding. So this is, what we always do in medicine, in cardiology. We have the balance between two opposite things. And here is thrombosis and bleeding. The major bleeding rate per year is almost 4%, which is not a low number using VKAs. And this is a large meta-analysis with almost 11,000 patients, 33 studies. And you see these are the numbers of the major bleeding rates, 2.5% per year, with intracranial and fatal bleeding 0.6%, and a case fatality rate of almost 9.1%. So you lose 9 out of 100 patients with a major bleeding. This is not a small number, so major bleeding is the major limitation of extending anticoagulation with a VKA. So one would say, okay, we have the warfarin, acenocumarol, we have a target INR of 2 to 3. Why don't we try a lower target INR of 1.5 to 2 when thinking to extend the anticoagulation? And this was, again, a New England Journal paper with using a low-intensity therapy group with a lower INR target, with a conventional intensity therapy group with a INR target of 2 to 3. You see here, although bleedings were still similar, the recurrent VT were much higher with a low-intensity INR. So this was abandoned. We should not use this strategy and target for lower INRs when thinking to extending VT anticoagulation therapy. And then always we have to, when we have a patient in front of us, the major thing that we think is the risk of bleeding. Again, we have some scores, especially in atrial fibrillation, the Has-Bled score, some easy scores to calculate. But when we have a patient after acute PE or VTE, I think we should take into account a number of more parameters. I have some of these here. So this is not a very easy thing to do. It's more like an eyeballing. You see the patient and you start calculating what is the risk of bleeding in every individual patient. Age, previous bleeding episode, cancer, renal and liver failure, thrombocytopenia, diabetes, anemia, of course, frailty with frequent falls and comorbidities, of course, use of other drugs that may increase the risk of bleeding, like antiplatelets or non-steroidal anti-inflammatory drugs. All these factors increase the risk of bleeding. So, it's very, very difficult in some specific cases to have this balance with thrombotic and bleeding risk. So do we have any other therapeutic options for extended secondary VT prophylaxis? Of course, we have NOACs. And these were, I think, landmark trials with the extension of the anticoagulation. This is the study with apixaban, the Amplify extension, where you can see here. Here is the placebo, and here are the 2 doses of apixaban, 2.5 and 5 milligram. This is the cumulative event rate of recurrent VTE or VTE-related death, and you see how both doses of apixaban lower the incidence of the primary efficacy endpoint. And regarding bleeding, the safety endpoint on the right side, you see that similar rates of bleeding between placebo and apixaban. And if we go to the absolute numbers, you see regarding major and clinically relevant non-major bleeding, the incidence was 2.7% with placebo against 3.2% with a lower apixaban dose versus 4.3% with the 5 milligram traditional apixaban dose. You see very insignificant changes in bleeding rates. And this is the Einstein choice with the use of rivaroxaban. On the left side, you see the efficacy. The main difference between the rivaroxaban and the apixaban study is that rivaroxaban was compared with aspirin, which, it was a common practice to use aspirin for the prolongation of the VT treatment after the 3 to 6 months. So rivaroxaban in both doses caused a significant decrease in the VT recurrence, in the major efficacy endpoint. And regarding major bleeding, similar rates of major bleeding between aspirin and both rivaroxaban doses. Again, this is a significant, I think, a hint or a significant result that aspirin and both doses of rivaroxaban cause similar major bleeding in this population. And further arguments for extending anticoagulation, these are patients with both unprovoked and provoked PE. We will discuss later that these definitions should not be used after the latest guidelines. We see here that rivaroxaban with the gray color here caused a decrease in VT recurrence in all three groups of unprovoked, provoked by minor transient risk factors, and provoked by major persistent risk factors. So in all patients, rivaroxaban caused a decrease in recurrence of VT. So what do the guidelines recommend? Of course, Stavros is the most, I think, a crucial person to talk about the guidelines. And we should congratulate Stavros that these guidelines were simple and very easy, I think, with clear messages, new messages for the extension of the anticoagulation. So when is extended anticoagulation not needed? We should not extend anticoagulation when there is a low long-term recurrence rate, less than 3% per year. And which are these cases? These cases are where there is a major transient or reversible factor, and this is either major surgery or major trauma or major condition or chronic illness that confines the patient to bed. So these are just three categories of patients that we should not extend anticoagulation more than 3 to 6 months. You can safely discontinue. On the other side, we have these patients with high risk of long-term recurrence, more than 80% per year, which are patients in which we should definitely extend anticoagulation beyond 3 to 6 months. And these are patients with active cancer. These are patients with a previous episode of VT. Of course, when we have a previous episode, and this is a second or a third episode, we should prolong anticoagulation lifelong. And finally, patients who have antiphospholipid antibody syndrome. These are patients with a very high risk of recurrence, and we should extend anticoagulation more than 3 to 6 months. But these are the two extremes. The majority of our patients are here. The majority of our patients are in the, not gray zone, but in the zone that there is a non-identifiable risk factor, as you see here. There is a persistent risk factor, other than the antiphospholipid antibody syndrome, like a chronic disease, like Crohn's disease, ulcerative colitis, or a chronic condition that may predispose to PE or VT, and patients that have a minor transient or reversible risk factor, for instance, use of estrogen or a long-haul flight. This is the majority of our patients in which we should consider extended anticoagulation with a class 2A in a recommendation. Of course, we have remaining questions. The remaining questions are some cases that are not cited in all these guidelines, in all these tables. When we should continue with full therapeutic doses, because guidelines recommend to prescribe, based on the two studies, the lower dose of both apixaban and rivaroxaban. And in a subset of patients, maybe a full therapeutic dose is indicated. And this is patients with a repeated VT event. Of course, we should not prescribe low dose of NOAC here. Active cancer, VT recurrence while on reduced NOAC dose. If you are on a reduced dose, then you should be, and you have a recurrent V, of course, you should go to a full dose. With an ongoing medically indicated contraception or hormonal treatment, of course, with an antiphospholipid syndrome, this is the only indication where NOACs are not indicated. When it's triple positive, the syndrome is triple positive, then you should start the patient on VKA. When you have a severe hereditary thrombophilia, like a protein C or S deficiency, for instance, and when you have other serious comorbidity and you feel that the patient should be on strong anticoagulation lifelong. And then is a question in whom we can safely discontinue or terminate the anticoagulation, and you feel safe, you feel secure that you stop the anticoagulation, the patient is safe. There may be some patients that are particular in this category. Of course, we can use here in this particular setting our risk scores, especially the HER2 score. And if you consider all these 4 parameters, hyperpigmentation, edema, and redness on the VT side, D-dimer more than 250, BMI more than 30, and age more than 65. If you have 0 or 1 of this parameter, then I think you are quite safe to terminate anticoagulation. And if you use this score, you can easily differentiate patients who are low risk from patients who are high risk, and this is it can safely you can safely attend these patients, follow these patients, and you have a difference in survival. And this is a case that is mentioned in the supplementary material of the guidelines. For example, in a young female patient who suffers an acute PE while being on oral contraceptives, what advice should we use? So if the patient is taking an estrogen-containing contraceptive, young female patient, especially if the PE happens after the first 3 months of initiation of contraception, we can discontinue hormonal contraceptives and consider discontinuing anticoagulation after 3 months. This is safe to discontinue anticoagulation therapy in this particular setting, of course, after discontinuing the hormonal contraceptives, which was the trigger of the event. In all other cases, you should manage chronic anticoagulation as after acute PE, occurring in the absence of identifiable risk factors, and consider using a risk score like the HER2 score I mentioned before. And when you have a score of 0 or 1, this may identify young women who can safely discontinue anticoagulation treatment. So the HER2 score is very, very special for these young women who have a VT event while being on contraceptives. And of course, you should advise patients on the need for prophylaxis with low molecular weight heparin in the case that she becomes pregnant, where, of course, you have the higher incidence of having a recurrent VT event. So what we should do in my last 4 minutes is we should, 3 minutes, bring back the patient 3 to 6 months after the episode. This is very, very important. All patients should be back in our home office 3 to 6 months after the acute PE episode to discuss about what are we doing with anticoagulation. This is a very important time slot when, as Menno see about CTEPH incidence. So I will not go again through this algorithm. Menno showed that. What I would like just to say is this figure from the guidelines. It's very important to have a routine clinical evaluation at 3 to 6 months after acute PE. We should have an integrated model of care after acute PE to ensure optimal transition from hospital to ambulatory care. We should not say to our patients, okay, just go home, you survive the episode, all is fine, and just go back to your cardiologist or respiratory physician for just seeing the anticoagulation. It's very important to to connect the patient to the continuing care, both for anticoagulation but also for the CTEPH situation. And all symptomatic patients who have mismatch perfusion defect in vacuum scan beyond 3 months should be referred to a specific expert clinic for pulmonary hypertension or CTEPH. And this is my last slide from the ERS statement on CTEPH. How do we follow up patients after acute PE? Earlier diagnosis of CTEPH is relevant for patient outcomes. We should diagnose early in order maybe to have a better prognosis in terms of CTEPH. How is CTEPH identifiable more early? Menno showed us that CTPA is very important. Seeing the clinical risk factors is very, very important. For example, if a patient with splenectomy has an acute PE, we should always have in mind that it may be CTEPH under that. And finally, asking about symptoms at the time of the acute PE. We should ask the patient, did you have symptoms before the episode? Yes, I'm tired for 6 months. This may be CTEPH. It may not be just an acute PE. Echo is very important in this patient. And finally, my final comment is, although guidelines say that we should follow them and bring them back after 3 months, we have lost patients before 3 months after the episode. So they have the acute PE, and they had significant pulmonary hypertension and CTEPH, and we have lost them before the 3 months period. If the patient is symptomatic before, of course, after the first month, he should come back to our clinic to see if there is chronic thromboembolic pulmonary hypertension. Thank you very much for your attention.
Thank you, George. And for those of you who don't know it, this is the beautiful promenade of the city of Thessaloniki. Mount Olympus is just over there. Very nice city to visit also for young people. So, very nice presentation. And I would like, of course, the most important thing I want to emphasize starting the discussion is that the guidelines part referring to continuation or not of anticoagulation is a great work that was done and supervised by Cecilia. Cecilia was here, she's perhaps out. By Cecilia in collaboration with Paolo Prandoni. That was really de novo work because we had in the previous versions a few brief paragraphs, so she wrote it all over, and with, of course, with Fionnuala. And we had an excellent workshop here by Fionnuala and by Elena on the continuation. It's not an easy subject. It's not guidelines say continue or not continue. It's what to consider and what to weigh, right? And I think also the workshop made clear there is no yes or no answer, but it's important to, as you pointed out as well, to know what the data are. And then, of course, you must do some intellectual work and interpret the data for your patient. And we also have another workshop, Cecile and I, on the bleeding risk and what does this mean and how it comes into these decisions. And the second part of this workshop will be today. So this is really a very important subject that actually has been the topic of all spring schools since 2013. It has evolved, but from the questions, I don't know, Fionnuala, what your impression is, but from the feedback we had at the workshops, I think that most people now are well educated, right? And know how to make the decisions. I don't know what you think.
Thank you, Stephen. Thank you for the most fantastic presentation. I enjoyed that very much. It is such a crucial and difficult question that, as you pointed out, consumes so much of our practice. I think you're right, Stavros, as hematologists, as cardiologists, as pulmonologists with an interest in VTE, I think we all understand the nuances and the challenges and the limitations of data. I do think we have more work to do in terms of raising awareness amongst the general community because it's such a common problem and we have so much to lose in each direction. So it's fantastic that we can work together to do that. Thank you, Menno.
So thank you for your presentation, and may I come back to the fact that you were introduced as a cardiologist, but you are the example of a cardiologist who oversees the full spectrum of VTE treatment. And I would like to invite you to the Netherlands at some time to explain this to our Dutch colleague cardiologists, who are very good, but they are very far away for cultural reasons from VTE treatment in general. Now I would like to challenge you a bit on the HER2 rule. And I am intellectually biased because I was one of the authors of the BMG paper. Before I do that, who uses HER2? So quite a few. And an often asked question is, first, is it handy? And there is possibility to see that on your mobile phone, isn't it? So this is very important because all complicated rules, including what I learned from Andrew Sharp, again, is Andrew here? That he uses PESI because it gives him more information on the severe PE patients, and with the mobile it's no miscalculation. But is it still true for the DOACs? And this is an often heard question if you discuss HER2. Can you comment, please?
I really don't know. This is a great question because HER2 was developed in the era more, yes, of VKAs or. Yeah. But I really don't know if we have papers of the current era of NOACs. But you can give us our.
Well, to answer it a bit, there were a few patients.
I would like to know from you what you think, because I believe anticoagulation, but what is your opinion?
Well, I will respond to it in the following ways. I mean, we are looking at thrombotic risk. And as we have seen in the VTE trials, comparing DOACs and vitamin antagonists, there was virtually equipoise. It doesn't matter if you give DOACs or vitamin antagonist. So in terms of recurrence prediction, that would not make a lot of change. You still can use it, in my mind. And the second point is interesting. How is the D-dimer behaving while patients are taking DOACs opposed to vitamin K antagonists? And honestly, I have not delved into the literature. I don't know if anyone can help us here. Olivier, you're a bit of nodding. Okay, you're just wondering. Because this is, of course, quite crucial. And this is also practicality. And we have met some difficulties. Some hospitals said this while under anticoagulation, DOACs, is it possible? Can anyone help in the audience? Has he experience? I don't know whether they're small studies.
I do not know of literature about this. The only thing that we say, and we do observe, when we stop anticoagulation on NOACs, especially in younger women, we do 1 month later a D-dimer test. And then after a couple of months, so we do try to see if there is, because especially if the patient is a little bit uncertain. I would think that, many people better than I do, say that, of course, in the D-dimers, many laboratory tests may be different, the lupus anticoagulant and so on, but I think the D-dimer test does not depend on the DOAC or the VKA, it's the effect of anticoagulation, right? So I would think 1 month later, if you start having any problem...
But the HER2 rule, you must do it under anticoagulation, yes, so to pinpoint, yeah.
That's right, so we use the same cutoff, and we have never had a problem on anticoagulation, but then after anticoagulation, I think the time that you let go, right? I think it should be similar.
Okay, thank you.
Further questions, comments? Oh, there's a question from... Oh, that's good. That's good.
Remote question.
Okay. So that's good, because so you will need to say 2 or 3 words about the algorithm, or what your opinion is, not just what the guidelines say necessarily. So a colleague from Austria asks you, so for daily practice, what does re-evaluation after 3 to 6 months mean? Shall I do D-dimer? Shall I do echo? Which are the parameters that will make me extend the anticoagulation, which I did not know in the beginning and I know now?
So as I said, it's very important in two columns. The first one is extension of anticoagulation at 3 to 6 months, and then the other is about CTEF. So I think if the question is regarding extending to anticoagulation, you don't, of course, need to do an echo for that, just to see the risk factors and see how was the index P event, and then decide. This is the more important in terms of deciding the extension of anticoagulation.
But George, can I challenge you on this? I mean, the colleague's question is, yes, that's fine, but didn't you know all that when you discharged the patient? So why call him back? I mean, you knew what the... Or do you have now something new that you would like to evaluate?
Yes, I think of course, again, you have the time to discuss. You have the patient that, he's away from the episode, and you see the bleeding risk. You see if he had a recurrence of bleeding. This is the most important.
You see how he tolerated
how he tolerates the anticoagulation. Re-examining the bleeding risk is very, very important. Not only after 3 to 6 months, but always. This is very, very important message because we should prescribe anticoagulation maybe lifelong in some patients. So the re-evaluation of the bleeding risk is very, very important in these patients.
And then regarding CTEPH, as you said and showed, right? I mean, if the patient had risk factors for CTEPH or continues to complain of some symptoms, then you could either apply the Leiden rule or go to an echo for orientation. But of course, if someone had no risk factors and is feeling fine, you don't have to do that. We do it routinely, but you don't have to do it. So I think that's good. And as we just discussed with Professor Huysman, also for our colleague, you may, if you intend to not to reduce the dosage of anticoagulation, because there I think you don't need any laboratory tests, but if you intend to stop after 3 months, for example, in a 30-year-old lady who had hormone treatment and now wishes to stop, then of course you can do, or you, as part of the HER2 rule, the D-dimer test, have it on anticoagulation, then stop the treatment, and then of course you can also always control it, although it is not explicitly clear if the cutoff would be the same with DOACs as it was in the VKA era. But perhaps some things make sense and can be used already. Thank you very much.
The main message is that this time slot of 3 to 6 months is very, very important to bring the patient to discuss these two main issues.
And exactly, and it's not, of course, you had all this information, or much of this information at baseline, but it's another thing to call the patient 3 months later, and of course you will now know how the patient also tolerates the medication, how the patient feels towards anticoagulation, on top of the other factors you already had, and how the patient feels 3 months after treatment, because if someone continues to have symptoms, it will be very difficult to say, okay, never mind, you can stop now. Okay, very good. Thank you, George. Now we move. So we are pretty well on time, and just 5 minutes past. So now we have, of course, our president, not the president of the Republic of Poland, but the president of the working group on pulmonary circulation and right ventricular function of the ESC, Professor Piotr Pruszczyk. I have known Piotr, I think, since 2006. It was the first time I came to Warsaw, when then Adam Torbicki had started to call in the first task force for the ESC guidelines. That was a long time ago. We were never invited to Warsaw ever since. I'm just mentioning that.
But in the close future, why not?
Probably we didn't make a good impression. I don't know. But what I remember, an anecdote perhaps is not that bad, what I really remember, and that was totally crazy, so there was some entertainment program, back then it was okay, and there came a professor, a pianist, right, a professor of music, and that was so crazy what he played that everyone was absolutely fascinated. So no one remembered what was discussed there. Maybe it was not so important, but I mean, this professor's performance on the piano was great. So maybe Piotr now will be motivated to invite us again. So Professor Pruszczyk will talk to us about CTEPH now, but not on diagnosis, detection, but what you do with it. You know, Andrew Sharp talked quite a lot also in the plenary and also in the workshops about how to treat acute PE interventionally, but what to do with chronic disease. So that's very interesting. Thank you, Piotr, for being here.
Thank you, Stavros, for a very kind invitation and introduction. And I will deal with chronic thromboembolic pulmonary hypertension. Of course, we can distinguish at least 2 forms of this disease, proximal and distal. And please look at this nice graph quite recently published. So according to the diameter of pulmonary artery, we can, let's say, propose a different treatment. I will discuss it in details. Of course, there is a classification proposed by Jamieson for types of CTEPH, very proximal with proximally present thrombi and very, very distal in subsegmental arteries. So we should discuss not only the fact that the patient has CTEPH, but also what type of CTEPH it is. I will not deal very long with surgical treatment, but please know that this type of treatment is a treatment of choice and mortality rate is quite low, definitely below 5%, and survival rate is very high. We can appreciate this very unusual devices to extract organized thrombi from pulmonary circulation. There is a problem, because if we look at data coming from international registry, we can say that approximately 50% of patients were operated, but it also means that half of patients were not submitted to surgery. And this is a real problem. Despite the progress in surgical therapies, currently also substantial part of patients are not submitted to surgery. And also very important information that if we look at factors influencing prognosis, if the patient was not operated, this prognosis was definitely poor. So invasive surgical treatment was one of the major determinants of improved survival. So please also look at this graph. If we look at 4 years mortality, patients that were not operated in blue, definitely the survival rate is very, very, very poor. So, okay, we can say that if somebody has been submitted to surgery, the prognosis should be fine. But there is a problem with patients who are not eligible from different causes for surgery. If we look at current guidelines, I understand that next year we will have new ones, but current guidelines say that we should first of all consider pulmonary and arterectomy, and of course targeted medical therapy, and in some cases also BPA in expert centers. So the patients who are let's say considered for balloon pulmonary angioplasty, these are patients who are technically non-operable or have quite substantial surgical risk. So this is a story of BPA, which is still rapidly evolving with different technical approaches. So it would be the question to the audience. Do you know where the first case of BPA comes from? Leiden or Japan?
No,
Leiden.
88.
Okay. Okay, so we can definitely appreciate that the first case was published comes from Leiden. I will show this case. So everything started in Leiden. So this is it's okay. So first of all, we should have a very good visualization in terms of pulmonary angiography, and we can appreciate typical signs of CTEPH with proximal changes, for example, in this part of artery, and a lot of occlusions, and we can also say that there are no perfusion in the periphery. And of course, there is a need for selective pulmonary angiography, and we can see here very nice change, abnormality, and the question would be if this is of hemodynamic significance. So this is the first case that indeed has been published in Leiden in 1988. So everything, as it was said before, started in Leiden. And then, after several years, we had new publications. coming from US. And this is a very important publication because we can say that out of 18 patients who were treated with pulmonary angioplasty, 11 cases developed reperfusion edema, 3 required mechanical ventilation, and 1 died. And this was the cause why for some period of time this technique was not developing, at least in US and in Europe. So there were some small, let's say, series. The most important information is that peri-procedural death rate was almost 10%. So it was a very risky procedure. Almost nobody wanted to perform this kind of aggressive therapy. But then Japanese papers came out, and we can say that due to significant changes in technique, results were much better. We can appreciate the number of patients. This is one of the first papers with refined balloon pulmonary angioplasty in patients who could not be surgically treated. And we can say that results in terms of change in functional class and also safety, 1 death within 28 days. So it means that this was very, very successful. We have also a classification of vascular lesions in chronic thromboembolic pulmonary hypertension. Some of these lesions are quite easy to be treated, some are risky. So it is very important to have very good, let's say, not only localization but visualization of abnormalities. This type of lesion is quite easy to be treated. Also, type B, as it's shown here, is also quite easy to be treated. But some changes are at higher risk. So usually, if procedure is performed in not in the first session but in the subsequent sessions, these high-risk lesions are touched. Of course, there is a very good place for advanced techniques. The technology and the technique is still evolving. There is a local expertise, differences in techniques between centers. We can distinguish 2 approaches. The first one, where small balloons are used, usually in the beginning 2 millimeters in size. A lot of small vessels are opened. And the second approach is, let's say, targeted approach, where balloon sizing is precisely performed, for example, based on pressure measurements within pulmonary arteries. And once more, I would like to underline the role of imaging. I don't want to go very precisely in this our strategy of treatment of lesions. We decided in the very beginning, it was several years ago, to be as safe as possible. So we at the time used in all patients advanced modalities. Nowadays we are using, for example, OCT or IVUS quite infrequently. So this is also the place for congratulations to all my team for this, in my opinion, very interesting approach. I would like to show you some images. This is IVUS of one lesion. This green color indicates fibrous tissue, and this is a regular IVUS. By the way, this is a case of CTEPH in patients with advanced sarcoidosis we discussed yesterday. If COPD or other diseases can go together with CTEPH. And please look at this lesions, this bends, this let's say webs inside the vessels, and they will be much easier to be noticed in OCT. So there is a lot of, let's say, lesions, a lot of webs. Definitely this kind of abnormality will obstruct blood flow. So if we look at pulmonary angiography, we can also try to establish if this lesion is of hemodynamic significance. In the very beginning, in Japanese centers, blood pressure was measured distally and proximally to the lesion, and we can say that there is a definite change in the pressure, proximal mean pressure 55, distal pulmonary pressure only 11. So if this lesion would be dilated, definitely blood flow would be better. So according to these measurements, also angioplasty could be performed and was performed, and you can see that the difference in blood pressure is completely different. It is very important that if after balloon dilatation distal pressure is too high, exceeds 35 millimeters of mercury, there is a risk of lung injury and lung edema. So this is the case why in some centers this procedure is performed with support of pressure wire, and in other centers only small-sized balloons are used for this kind of lesion. And so the last image on OCT, you can see how it was before the dilatation, and after dilatation with 3 millimeter balloon, completely different structure, definitely less inside located material. Okay, looking at imaging, there is also a place for advanced CT and advanced pulmonary angiography, 3D reconstructions, and we can appreciate, let's say, more vessels after several sessions of balloon angioplasties. Okay, this is a very important, let's say, summary of Japanese activities. Please look at numbers. Over 300 patients in national registry, and very low mortality rate, which I will say. So please note 3 days mortality below 3%, 8 patients died, and very dramatic improvement in functional class. And also if we look at cardiac index and PVR improvement, which is without no doubt. So the authors concluded that hemodynamic results of BPA were very good. Complications, however, were high, because please notice that pulmonary injury was present in almost 20% of cases. But mortality rate was rather low. There is an ongoing debate if Europe is still behind Japan, and there was a nice series of national registries from Germany, from France, and quite recently from Poland. And we can also appreciate the results of these registries. Definitely good results with improvement in mean pulmonary artery pressure, and also with low mortality rate, approximately 2% of cases. And talking about, let's say, our own experience, I mean Polish experience, 4 patients died due to severe lung injury caused by vascular injury, and one patient died due to pulmonary edema. It means that technical issues are very, very important, because if there is no local injury, most probably this technique would be safe. So this is a place for training and for planning of all these procedures. And of course, not only vascular injury, perforation, dissection, or thrombosis, also we can have bleeding, pulmonary infection, ongoing discussion if reperfusion edema exists. But also we should remember of extra thoracic complications such arrhythmia, renal dysfunction, or access site complications. But nevertheless, this procedure in expert centers is safe and may be of, let's say, good value for the patient. This is an example of extravasation due to vascular injury, and here there are some regions of local pulmonary edema. There was a very nice summary indicating what is the main cause of lung injury, the most important and most dangerous complication, and it was also underlined that vascular injury, so once more technique, is very, very important, because vascular injury, especially in patients with advanced stages of CTEPH with high mean PAP, these are patients at risk of reperfusion edema or lung edema caused by vascular injury. What is the place of this procedure? This is a subset of our patients. Please note that the mean age in this population was 81. Patients who were rejected from surgery, all patients above 75 years of age, all patients were, let's say, offered balloon pulmonary angioplasty. Some of them, 3 were in functional class, as it's written here in advanced class 4, 7 in the class 3, and after BPAs, definite improvement in hemodynamic status and functional status. So patients who are not eligible for surgery, this patient may undergo balloon pulmonary angioplasty. And coming back to this slide, we have patients with proximal lesions, patients with lesions in segmental or subsegmental arteries. So definitely BPA is very good for patients with subsegmental, segmental lesions. There is ongoing debate where is the, let's say, limit how proximal thrombi could be treated by BPA, and in opposite, how distal thrombi or thrombotic material can be removed by advanced surgical therapies. So in conclusion, I think that for both techniques there will be a place, and definitely there is a growing place for balloon pulmonary angioplasty. So showing the same image, I would say that most probably all these items, I mean pulmonary endarterectomy, targeted medical therapy, and also BPAs will be used in majority of patients, maybe in combination. Thank you for your attention.
Thank you very much, Piotr. Great presentation, and congratulations, of course, to you and your group for the work you are doing on this. I mean, first of all, I must say I did not know that Leiden had the first patient of PPA. I thought that was in Japan. But this shows that this is truly a school on thrombosis and embolism.
I can tell you very short the anecdote.
Yes, tell us an anecdote.
Of course, I'm never proud of Leiden, but Leiden is proud on itself. And I heard this from the cardiology department, and it's the only department in the Netherlands which is called hartziekten, so diseases of the heart. So if you're referring to the Department of Cardiology, you end up in an old building somewhere else. But this was initiated as therapy for pulmonary stenosis for very young children. And there it worked fine because everything is more plastic. But then they turned into this first patient, and that was a small disaster because that patient got really complications. So Professor Buys, who was doing this intervention, said, I will never do this again. And that was, of course, what Japanese doctors copied then and made into a big success. I have a question for you. I'm fond of randomized trials, and I think there has been a debate, will this be able to replace surgery? Or in a complicated session or whatever. So primary balloon angioplasty versus PEA, is that too much, or is that coming closer?
There is a project to perform some kind of, not some kind, randomized trial on BPA versus surgical therapy. It should have been launched in the second part of this year, but due to COVID, I think it has been postponed. And I have to admit that the first case which was performed in Poland was performed in Adam Center, Adam Torbicki Center. Yes, it was his. It was 2014, I believe. Yes.
Yeah. And this gives us also the opportunity, also for those of you who are younger here, to remind everyone that Adam Torbicki, who is a true European, he's not just a Polish professor, but he speaks, I think, 4 or 5 languages, and he is an extremely competent and also charming person. He was the first one who started the guidelines on pulmonary embolism, at the time when no one in European cardiology cared for PE, in 2000. So the first paper was more or less a consensus statement. There were no formal recommendations. And then came 2008. That was why we were in Warsaw in 2006 to start preparing this. And that was really so. And I must say it very clearly, because then someone, Andrew yesterday was talking about gravestones and what everyone will have on their gravestone in tables and risk stratification. So the risk stratification table of pulmonary embolism is an idea of Adam Torbicki from the year 2008. So we, of course, all of us try to develop further what the previous generations have done. So that's really great. One brief question on CTEPH and BPA. I know Professor Matsubara, and I remember I met him in Japan and we were having dinner, and he was telling me he believes that CTEPH in the Japanese population is different from CTEPH in the European population, and this is why he believes that BPA is there so successful. Is this an anecdote, or is there any fundament in this? Is there any scientific basis in this?
I think that there is a difference in localization. I think that they have more distal forms of CTEPH. And usually, this is beyond the discussion that we have patients who have phenotype of CTEPH, patients who have phenotype of pulmonary arterial hypertension, and there is a subgroup which is in between. So very distal organized thrombi with no history of pulmonary embolism. So I think that looking at frequency of Takayasu disease, definitely there's a variety between European and Japanese populations. So maybe also the same.
There may be some basis in this, right?
Yes,
it's not
maybe.
just an impression. Yes. And Piotr, I think you were present. There was some discussion, but then I will pass on to Nicola and to Lilian. I think immediately there was a lot of discussion in our previous workshops. It was also with Andrew, I think, on if you have, and I think it was with Lilian and Michael Sproul as well. So if you have on acute on chronic PE, and there was a lot of fear if patients who have acute on chronic PE are taken to the surgeon for embolectomy, and then there is CTEPH underlying, and these patients may die, and we had similar cases. is there, could one say, well, if the patient, you do an intervention, then it is less of a problem. Then, of course, you could say you would try to treat interventionally acute PE, and if something is wrong, you could proceed to BPA without having this terrible dilemma that the surgeons have if they discover something chronic suddenly.
You know, I think that in majority of cases, we can expect if this is acute on chronic, and usually, if it is possible, we don't like to send to surgery in this period of time. Our surgeons say, okay, we would like to remove organized clots or just fresh thrombi. This mixture is not optimal for them.
Yes.
And but of course, there are some cases that were almost immediately transferred acute on top of chronic, yes.
Thank you, Piotr. So Lilian wants to say something, or I think, Nicola, you were first, and then Lilian, please.
Thank you, Piotr, and congratulations for your nice presentation. Maybe I missed something, but how many procedures are necessary to get good final results with clinical improvement? And in this setting, is the ionizing radiation a problem for the patient?
Okay, indeed I didn't mention this. Definitely all patients are treated for several times. It depends on, let's say, on the technique, but average number of sessions is between 5-7 sessions, and during each sessions, several vessels are being opened or dilated. And of course, there is a question of approach and of technique, because if somebody is using small-sized balloons, the number of treated vessels per session is larger, but it does not mean that results is better when compared to let's say, targeted dilatation of specific vessels. But definitely several sessions are needed, 5, 7, sometimes even above 10 sessions per patient.
Thank you. Lilian?
Yes, thank you for your very nice presentation. And could you give your opinion about the role of BPA in residual pulmonary hypertension in patients after pulmonary endarterectomy? And do you perform that in your hospital?
Yes, there is of course an important role for this kind of therapy. Usually, we, of course, all patients after surgery are follow-up, yes? And if there is an ongoing residual pulmonary hypertension, they are not only catheterized, but also they are with pulmonary angiography diagnosed. And in selected cases, balloon pulmonary angiography is being performed, yes.
Piotr, just a brief comment from me. It's here,
yes.
Michael Dalton. And just a couple of very, very quick questions. The brief comment is that I think that, I hope you agree, all agree here, that the BPA should be limited in a very expert center, because, you know, we cardiologists are convinced, some of my friends, that if you can put a stent in the left main, you can do everything. So this is different procedure and require very, very expert centers, and the centers must offer all the opportunities. I mean, the BPA, the surgery, and the drugs, of course. This is the need for having a CTF team as in your center. This is very, very important, because there's not, I can do, so I try to do. This is very complex procedure.
It's a very important remark, because in all centers, CTF teams should be active, and we should decide together if this patient should be submitted to surgery or to BPA. So this is true. And very aggressive interventional cardiologist will fail with BPA, because, as I mentioned, if the vessel is, let's say, too opened, yes, and the blood flow is very high to the revascularized region, there is a lung injury. And this was the cause of the first fatalities in almost all centers. So we should be very, very cautious how aggressive we should be. So we should not be aggressive in this type of treatment.
The question is related to this, if I can. When you consider you satisfied, I mean, do you look for anatomical resolution, you look for pulmonary pressure, resistance, and so on? And finally, is there a space for an hybrid approach? I mean, for some patient, just minority of patient, I start with drugs. If the patient, of course, is not so compromised, start with drugs, Rio, and after approach with surgery or intervention.
Of course, this depends on the patient. We had several also patients with CTED. One very active young man. He was sporting very intensively, and although he had no pulmonary hypertension, he wanted to be very active. So with distal forms of lesions, he underwent several sessions of BPA with full satisfaction. And if we look at elderly patients who are not so active, we can limit the number of sessions, yes? And by the way, if in expert centers BPAs are performed, usually we can decrease mean pulmonary pressure below 30 millimeters of mercury. It is possible, yes.
Piotr, when PCIs of the coronary vessel started in the 80s, I mean, it was absolutely important to also have a cardiac surgeon there and, you know, and make these decisions together. I mean, nowadays, of course, PCIs are done in cath labs where the surgeon may be hundreds of kilometers away, and that does not matter so much. Do you believe, of course, and it's very important, and I think you emphasize it very clearly, and Michele, I think, agrees absolutely, BPA is not just a CTO procedure, it's something totally different. You have to have specific expertise. So not every, of course, it's good to have interventional cardiology experience, but not every interventional cardiology becomes automatically a BPA. I mean, George is nodding, he knows why. So the question is, do you believe that a center, an expert center for BPA, should also be an expert institution for PA, so that there can be a decision that can be made multidisciplinarily, and so that the surgeon tells you, yes, Piotr, that's for you, or otherwise, no, I will take it? Or do you think it's okay, you can judge it, you do the BPA, otherwise you refer to the surgeon?
Of course, we are collaborating with cardiosurgeons. In my hospital, we have no cardiosurgery. There is one, let's say, specialized cardiosurgery in Warsaw, and this center is covering almost half or almost all Poland in terms of surgical treatment of CTEF. And in all cases, we are consulting our patients.
You discuss it?
Yes, definitely, yes.
That's very important. So it's not something that someone comes to Professor Pruszczyk and he says, I think that's okay, I will dilate it. I mean, it must be, we always talk about multidisciplinary decisions. We talked about alert and PERT, but here, of course, it's even more critical. Yes. You have the time to do it, and yeah, it's not something that everyone does. So I think it's very important to emphasize. It doesn't have to be the same house, but of course, nowadays with virtual communication, yes, this is possible. Any further questions or comments? So many thanks to all three of you for your perfect, great, and of course many thanks to all four, because Eric was with us mentally, and we were very happy, of course, to see all this great data. So now you have time for 30 minutes until 10:50. You did very well, so please enjoy a little bit of the sun, but please come back. We will then have, you've almost made it for the morning. We'll have a brief lecture that I will be giving, and then we will have the Young Investigator Awards. Just to tell you in advance, I mean, Menno and I will now sign the certificates, and then we will give you the awards. We have obtained all the grades. Those colleagues, all abstracts were great, of course, and the colleagues will, for you to prepare the colleagues that will be called out and will be asked to come and receive the certificate, and there is a symbolic present. Unfortunately, we're not allowed to give money anymore. Yeah, in the past we did, but now it is, unfortunately, it falls into the corruption law, so we are not allowed to do it. So you may receive something symbolic. But please, you will be asked to say 1 or 2 sentences about your work, right? Not give a presentation, but of course remind everyone again what it was all about. So, see you at 10:50. So we can turn on the mic. Thank you. So now we come to our second very brief session of the morning. We will talk a little bit together, about 20 minutes, 25, about new or next generation anticoagulants, not what we have, but what may be coming. I'll be very cautious. And then, of course, we have our Young Investigator Awards. So I will say a few words. I am not the expert on on next generation anticoagulants, so I'm not Jeffrey Weitz or Harry Buehler, so I will not tell you all details, and not all pharmacological details, but I would like to give you an overview of what we may get in the next years. First, why we need it, and second, what is in the horizon and where we have some first clinical data. I have, as I said, these are all indirect disclosures. I am not directly involved into the industry programs of the new drugs. So this is quite a long list of the structure of this presentation, and you will see that the first three topics are actually the introduction. But this, of course, will be brief, and then I will get into the new targets. But it's important to know why we might be able why we might need new drugs. So what is there to cover yet? I mean, haven't we done enough already? First of all, because a very small repetitorium of what was said. I mean, this is from of our first lecture on epidemiology, where Sigrid and Stefano so beautifully coordinated. These are the data of Stefano and Luca Valerio, who looked at the mortality of VTE, because the question would be, well, the problem is solved. You see, VTE or PE-associated mortality has halved in the past 15 years in the European region of the World Health Organization, so there's no need to worry. Things are doing well. But of course, the societies are aging everywhere in Europe and in most parts of the world, and this means that there, of course, the PE-related mortality, so the PE-associated deaths per 100,000 population, that's the mortality, right? I mean, they are very high in that population. And second, you remember very well, we discussed it many times, that in younger people, and especially in younger women between 18 and 55 years, there is a relative mortality due to PE, which is still very high. It's almost 2% of all deaths. And you remember, 15% of all maternal deaths during pregnancy or delivery are VTE associated. So that is a problem in young people. Fortunately, of course, in absolute numbers in young people, there are very few cases, but nevertheless, the absolute contribution of VTE to deaths, even in the younger, especially in younger women, you see that's the red line, as opposed, for example, here for Western Europe, this is very pronounced here, and for males, it is not so pronounced. So both for the old in terms of numbers of patients, but also for the young in terms of relative contribution. And of course, we had excellent talks from Marcel Levy on VTE and thrombosis. We had an excellent talk by Olivier Sanchez on VTE and thrombosis from the point of view of a major expert center taking care of these patients. This is the most recent meta-analysis, just to remind you that the overall prevalence rate of the studies that we have so far on COVID and thrombosis, COVID-19 and thrombosis are in the order of 8% for PE and 11% for DVT. So this is a problem that is here to stay, and every time we may have a new epidemic, we may have to worry about PE as well. So yesterday there was the question by Dr. Sharp, what will be, as we said, put on everyone's gravestone, so hopefully we're not very close to that ourselves here, but clearly for people like Giancarlo Agnelli and Harry Buehler and Sam Schulman, maybe this would be the best thing to put in there. This is the validation and the approval of the DOACs that we use today. They were used to be called new oral anticoagulants. Now they're not new anymore, because this is clearly has been the major revolution. I mean, we did have a revolution 20 years ago with low molecular weight heparins, I mean, most of you will not know that patients with DVT came into the hospital and they had to lie 10 days, right? And unfractionated heparin had to be adjusted, which never worked. But this was, of course, the revolution for millions of people worldwide, millions. So one could say, perfect, now we have everything, we don't need it. And guidelines say these drugs are to be preferred. That's for VTE, but for SPAF it's the same thing. But we do have some gaps. And there are gaps in knowledge in primary thromboprophylaxis, so in patients who, in orthopedic patients, in other surgical patients, we do have drugs, but maybe we need something which is even safer, because of course in primary thromboprophylaxis safety is an even bigger concern. You do not treat a sick person, you treat a person so that she or he doesn't get sick of VTE. In secondary thromboprophylaxis, we may need safer drugs over the long term if we're to treat people indefinitely, especially people who have a higher bleeding risk or have a reduced renal function, end-stage renal disease and hemodialysis being part of this problem. Then we have the patients, you know that the next frontier of cardiology are the devices for heart failure, now that everybody is treating the valves and the coronaries and electrophysiology. Now we will have an increasing number of patients who will have some sort of device in there, and there the NOACs and, or DOACs are not good drugs, extracorporeal circuits, and antiphospholipid syndrome is also a question mark. I will very briefly mention this. So this is, for example, just to show from the AVERT and Cassini trials 3 years ago, or almost 3 years ago, that we are not there yet for primary prophylaxis in cancer patients. So Giancarlo Agnelli wrote an editorial on this saying that this shows that it does not work, it was not safe enough, and then he told me that he was being, he received many unfriendly emails by both industries telling him that he was killing the products. But I mean, it shows that, okay, they worked, but of course, they worked, but of course the level of safety for such a population of primary thromboprophylaxis was not high enough. Then I said we discussed all these recommendations, or that it should be considered to prolong anticoagulation, but then of course you must make sure it can be done safely. We know that these drugs are not recommended or contraindicated in severe renal dysfunction, as we know. And then we have an issue which is very controversial, the antiphospholipid antibodies. That was not a huge part of the discussion. It became quite a big discussion in the COVID-19 era. There were some reports that up to 90% had antiphospholipid antibodies in relation to acute COVID-19. As Marcel Levitt said yesterday, it is unclear what the importance of this is for treatment. But if you measure them and you have, I mean, we had a young lady with COVID-19, she had an anticardiolipin antibody titer of 6,000 units per liter, and then this is of course something which is quite, yes, worrying. And maybe if you need to treat these patients, you might need something different, we'll know. So, what are our new targets and what are the expectations? So, this is a very simplified, rather primitive, but I hope helpful presentation of the coagulation system, just to remind everybody that, of course, we have the so-called extrinsic pathway and the activation of factor 7 circulating. So this is a little bit weak. I'll try it here. I don't know if it works. Yeah. So we have the activation of factor 7 by contact with tissue factor at sites of vascular injury. Then we have the generation of factor 11, and then we have the generation of thrombin. So this is the so-called final common pathway against which DOACs are working, right? You know all this. Now, this amount, and this was some very nice work that is already more than 20 years old. This amount of thrombin that is generated this way is very little. So what is needed now is a positive feedback loop that now will generate the true amount of thrombin to ensure that there is a clot, that there is hemostasis. And this is done via interaction, via activation by thrombin of factor 11, which then, by interacting with factor 9 and factor 8 on platelet surface, will generate even more factor 10 and more thrombin. So please remember that we do not just have factor 7 and factor 10, and tissue factor make factor 10, this makes thrombin, and then we are done. This is true, but this is just the initiation. So the second step is the true mass of thrombin coming in. Okay, so why is this important? You will see it in practice in very few minutes. Now, and there was this obscure so-called contact pathway or intrinsic cascade of the coagulation system, which many people thought, well, that's not really of importance. It's only of importance if you want to explain why you measure the prolongation of the APTT, or it's important just for those working in the lab so that they can do some experiments and have some publications. But things changed over the past years, because this is not something which is only for the lab. It was found, I mean, you know, there has been this huge, very interesting bibliography that at sites of infection or at sites of thrombosis and at sites of inflammation in general, there is this activation of the neutrophils as well. I mean, Eric just submitted a proposal to the European Union for funding. We had done so 20 years ago for atherosclerosis, and back then there was a work package. It was from the UK, the role of neutrophils in atherosclerosis and thrombosis. So the proposal was rejected, like most EU proposals are rejected, and it was rejected, and Andrew, one of the reviewers, said, I mean, he said, this is totally ridiculous. The neutrophils have nothing to do with atherosclerosis and thrombosis. And so the proposal was rejected. So it came out that neutrophils have to do with something with thrombosis quite a lot, and you know these neutrophil extracellular traps, which are actually traps for bacteria when there is an infection, work here, and they can activate, you know, via the polyphosphates and factor 12, they can also activate this so-called intrinsic system. So you'll see now why I'm saying all this, because the issue is, after having targeted the final common pathway and having good drugs for the vast majority of people, but having been unable to dissociate thrombosis from antithrombosis from antihemostasis, so from bleeding, the hope is that finally it will be possible one day to have drugs that prevent thrombosis without affecting hemostasis and thus not causing bleeding. I mean, that sounds logical. The question is if it's feasible. So the question was, what do you do if you want to do something? Nature has redundant mechanisms. So if you block the final common pathway, then of course you will have bleeding. So you will also not have hemostasis. But the hope is that if you go further up, so if you go upstream and start blocking factors like perhaps factor 12, factor 11, or perhaps factors 9 or 8, then you will be at an upper part of the hemostatic mechanism, and there you may have good antithrombotic effects, but not have such an effect on hemostasis that the patients may bleed to death or have some serious bleeding. So this is the theory. And what do we have today? So this is I think one of the best reviews on the subject by Nigel Mackman last year in Nature Review of Drug Discovery. So where he listed what is here and what is coming up. As Menno said, I mean, you will be receiving password protected all the slides from the Spring School, of course, if the faculty members agree to share them with you as PDFs. So now it's quite interesting. What you see here, I will repeat this slide in a few minutes. What you see here is the fact that all the substances, the antithrombotic, anticoagulant substances that are actively clinically being investigated now, you see, are substances against factor 11 and one against factor 12. I'll come back to that. I have hidden here something. You'll see why. So research on factor 9 and factor 8 inhibitors is not going on. I mean, they have not proven to be, for various reasons, promising targets. So the promising target is factor 11 and factor 12. And I remind you, factor 12 is upstream, right, of factor 11 in the so-called contact or intrinsic pathway. Then we have the factor 11, which is still officially considered to be part of the intrinsic pathway. So, okay, so what do we have on this and what is so promising? Now, factor 11 has some epidemiological data that speak in its favor. So there are humans with factor 11 deficiency, and it is known that these humans have a reduced risk of VTE or stroke. So it appears not only theoretically in the graph, but it appears also clinically in humans to protect. So deficiency of factor 11 protects against thrombosis. And interestingly, there is no, and vice versa, in some patients where it has been examined, for example, in women taking contraceptives, there may be an increase in factor 11 levels, and increase in factor 11 levels was associated, I did not say it caused it, but it was associated with an increased thrombotic risk. And generally, patients with lower factors of factor 11 are not patients who bleed. So this appears to be a relatively safe target. Now we have factor 12. Factor 12 would be great. Contact pathway, maybe it's good for patients with artificial surfaces, valves. That would be safety, because then one would hope, by being so far upstream, that there would be no problem for bleeding. There would be other mechanisms. But the role of factor 12 in humans has not been shown. So there are data in mice. You know probably that the mouse genome is approximately 85% overlapping with that of the human genome, but in so-called higher primates, this has not been to play a physiological role. So the only substance that is being currently investigated against factor 12 is for hereditary angioedema, which is not a thrombotic condition, right? So this is not being actively investigated for thrombosis. So it's easy. We just stay with factor 11 at the moment. And of course, there are some other things. It's not just the target. It's not just the target, but it's also how you give it. We said that the main problem is not the big population that is very nicely covered with the DOACs. We don't have to reinvent anticoagulation every decade, but we have the patients with for example, with terminal renal or with almost terminal renal failure, so patients who are very vulnerable. And there, of course, it's the question if we can give something that does not need renal elimination, like all the small substances we have nowadays, and if we can give also something that perhaps does not need to be given twice or once a day, but you can give it once a week or even once a month. It has been tried in the past with little success. We'll come to this. So there are not just the inhibitors, the small molecules that we have today, but we have antisense oligonucleotides, we have aptamers for binding and blocking the factors, we have monoclonal antibodies, you know, that's a big progress in many parts in oncology, but it's also in antilipidemic therapy, in hypercholesterolemic therapy, and also possibly in anticoagulation. And we do have some small molecule against factor 11 as well, a reversible binding, and this is the only treatment right now, the only one substance that is being tested clinically in this area, which is a small molecule like the DOAC. So it's not just what we will target, but possibly other forms of drugs and other forms of giving the treatment. There is also a possibly promising area of going even further upstream. I told you about the polyanion, the polyphosphates, that targeting those polyanions, but this is still something which is at an experimental stage. Now, as you saw, we do have, therefore, the anti-11 substances. The anti-12 substance is only for hereditary angioedema, so that was the column that was missing. It is now. And you see also now, trying to find the arrow, yes. Okay, and you see from the arrow, this is, of course, tested right now, in fact, in phase 2 trial, so dose finding. It is not tested for approval in the next year or so. It is being tested for chronic indications for particular patients, so for atrial fibrillation, and you see total knee arthroplasty, and you also have a number of studies on hemodialysis, right? Because this is for patients with terminal renal dysfunction. Does anyone know why all these drugs, almost all anticoagulants, have been first tested in orthopedic surgery, total knee or hip arthroplasty? Is it such a huge market? Is it so? Some other young investigator, a little bit older, not the very young always. So why is orthopedics so important as a market for these people? What's the idea? Why is orthopedic surgery so important?
there's a high incidence of thrombosis in this population.
Yes, that is, so it's not so important, and it's not so, it's not the big medical, it's the model, it's the best model. You have an elective setting in which there is a huge, maybe I can say it, I will of course let Menno speak, but I can say it from the point of view of a clinical trial. When you want to do a clinical trial, when you want to show that a drug is prevents or is effective against some disease, you must make sure, in order to test and validate the drug, that we had this discussion, and you had it with Professor Vico and Luca, and we had it also at our workshop with the clinical trials. You have to make sure that your event rate in the control arm will be high, because if you choose a setting in which all patients, I mean, if you choose appendicitis or, I don't know, some nevus extraction and want to show if these drugs are good in preventing thrombosis, you will have 0.1% in the untreated and 0.5% in the treated, and you will need 100,000 patients to show that the drug is working. So there is a practical and methodological reason to do that. Menno, you wanted to say something?
Very short. The ideal thrombosis model, if you use contrast venography, is this elective hip and knee surgery. First, because it's planned, so you can plan.
Yes.
And I'm afraid that for most European countries, more on the eastern part, are still wanting to do venography, because who has done a contrast venography for the last week, last month, last year? Nobody. So,
yes.
But and the second point is, as was very nicely indicated, high asymptomatic thrombosis rate. Now we can fill hours on the discussion on how relevant that is, but at least it's reproducible.
Exactly.
The nicest bleeding model, by the way, you know what that is for a study for bleeding, antithrombotic? Prostatectomy. Most fantastic bleeding model. Please remind. Thank you.
This affects only older men, of course, and not the whole population. So, but this is true. So it is very important, and you can ask Eric and Luca at the statistical workshop. I mean, it plays a huge role, because, I mean, when you want to validate a drug, you have to spend an amount of money as a company, which, for example, for apixaban or rivaroxaban was about 3 billion euros to bring the first drug into the market, 3 billion. So you do not want to have even more hundred thousands of patients tested. So somehow you have to think practically. So this is a good model. This was just an excursion to this field. So, but this is why people do it in TKA. Actually, in many countries, Denmark is the country which is a champion on this. People leave the hospital after TKA and THA within 3 to 5 days, and then they do not receive anything but aspirin meanwhile, the TKA and THA patients. And this is a trend because they now stand up on the same evening. It's unthinkable that doing total hip arthroplasty and standing up on the same evening and then a couple of days later going home. But this shows that this is not the market for the companies. It's just a model. Okay, so what do we have? So we have 3 substances or 3 monoclonal antibodies. I mean, we have some smaller results, but we have 3, let's say, major studies. These are all dose-finding studies. And look what the concept is and what is good and promising and what is less promising. So this is the antisense oligonucleotide technology. Antisense oligonucleotides have been used for about 25 years. In fact, we did have a postdoc in 2000 who went with a Marie Curie fellowship to Montpellier to work on these. And this was, so in that case, of course, this antisense oligonucleotide is injected subcutaneously, right? Goes into the liver, so it does not have to be cleared by anything. And of course, what it does, as you see here, it performs a duplex with the factor 11 in this case, right? That's a factor 11 antisense with a factor 11 mRNA, and what it does is that it inhibits the transcription, and it inhibits the production of factor 11 in the liver. It is very clear, so this is from the first major publication on this by Harry Buehler in the New England Journal of Medicine, the first study that validated this in VTE. And that is, of course, as you may understand, since this must all work in the liver, it takes a couple of days for it to work. So you cannot have a patient who has acute PE and intermediate high risk, and you say, let's give him an antinucleotide so that it starts to anticoagulate immediately, right? So this is for prophylactic or chronic use, for example, SPAF. Okay, so what they found, do not worry, there are some numbers, but the numbers are only to show you that the patient, this is a dose-finding study, so it is not for approving the drug, it is just to show which dose is the best one. And the standard, so the control arm was enoxaparin, right, which is the standard in orthopedic surgery. You can also give rivaroxaban or apixaban. And so you see, it was, since it is planned surgery, as Menno said, that's a good thing. I mean, you will never test a drug in emergency surgery and don't know when to start, right? So planned surgery, so 36 days preoperatively, it was started, subcutaneous doses on days 1, 3, 5, then once weekly, and so on, so don't have to memorize all this. And then it was given one dose 6 hours postoperatively, and then let's say the liver was saturated and did not produce any factor 11 anymore, and that was a very promising result. So the higher dose of 300 milligrams of the antisense injected through many times reduced the risk of VTE. And as Dr. Huysman said, this is VTE also with venography. So just the model. Who cares if it is perhaps some kind of clinically, sometimes if it's some kind of distal asymptomatic thrombosis. But this is just to validate how the drug works, and if the drug works. And you can see with the high dose, you had a 4% rate versus 27% with the low dose, which did not work very well, versus 30% with heparin. Again, these are not clinical rates of thrombosis, right? This is just venography. And the safety was great, 3% versus 8% of heparin. So you would say that's the way to go. Okay, we will see. So that is a principle. And then we had a drug that was in the year 2020, osocimab. And osocimab is a long-acting monoclonal antibody against factor 11. So it inhibits activated factor 11 and inhibits its binding to factor 9. So factor 11 is activated by factor 12 and by thrombin, as you remember, but it cannot work any further. So you do not have this boost in thrombosis. Very nice. The advantage, the antibody will have an effect immediately, so you don't have to wait for a couple of days for a synthesis to occur in the liver or a reduction of synthesis. You give the antibody, then you will have factor 11 inhibition. The other advantage or disadvantage, depending on how you see it, is that, of course, it will last long. So perfect. Again, right? Orthopedic surgery, dose-finding study, 945 patients, big study, elective primary TKA, so knee arthroplasty is particularly popular with the people who validate these drugs, more than hip. Primary outcome, VTE, again, mandatory phlebography for these reasons. Well, very good results. So it was found that that this post-operative, so starting post-operatively, in this case, the good thing was that it was given post-operatively, right? It was given post-operatively once. It did not have to be given all the time, or it could be given pre-operatively. In fact, if it was started pre-operatively, it was superior to enoxaparin. We'll talk about safety in a moment. So, good study, antibody against activated factor 11. And this is a very recent study. Now the New England Journal does us a favor and has a very beautiful figure of the whole study, so we don't have to draw it ourselves. So this was published a few days ago by Peter Verhamme and colleagues, and Jeffrey White's Menno is always in any new anticoagulant since 2005. There is no study on a new anticoagulant without Jeff White, so he was here as well, participating. And so actually, now this is abelacimab. That's the company's name for it. That is the Anthos company. It's also a monoclonal antibody. The difference is this is now an antibody that inhibits activation of factor 11. So it's a little bit further upstream of the other one. It does not inhibit the activated factor 11. It prevents activation of factor 11. Okay, so this antibody was given, in this case, that was only a single infusion. Antibodies are given IV, the previous one and this one. And here there was a single infusion which was given after surgery. So the advantage here was that you did not have to start before surgery. It was given after surgery. And you see the incidence of VTE, so these are the very fresh data, the incidence of VTE is 13%. So and with this dosage, so we had 3 dosages that were tested versus enoxaparin, and you see again very impressive results. So very promising, to put it this way. So you see, with starting with a 75 milligram dose, you have only 5% incidence of VTE compared to 22% with the standard, which is enoxaparin. So I would say that's great. And going up to 150 did not really make it much better, and major or clinically relevant non-major bleeding was also, very low. Okay, so nice conclusion from this study. A single dose of abelacimab after knee arthroplasty was effective for prevention and was associated with a low risk of bleeding. So, are we done? So, is this the future? Well, I showed you this osocimab study before, and I said I have concealed one line, and this is the red line below. In the antibody study, the preoperative osocimab administration was superior to enoxaparin, great, but it was inferior to apixaban, because this was the only study that also had an apixaban control arm in terms of bleeding. So we're testing a new drug that is tested and developed to cause less bleeding, and it bleeds more than apixaban. Our question is why? And there it helps to remember again what we said. That, I mean, of course, for educational purposes, we all like to have some nice simplistic figures, and medical doctors always like simplicity, but life is not so simple. And we said, okay, this is factor 11, this is the intrinsic system, and this is the final common pathway, so that's fine. But factor 11 is actually, as I told you, important for the boost of thrombin. So thrombin in the quantities needed for hemostasis is not just created by this. Because if it was only created by this, then any time you had some minor injury, your whole blood would thrombose, right? I mean, then it would coagulate, because it would be enough to have the injury and all things would come up. So this is this internal boost that helps thrombosis and is regulated. So if you stop factor 11, of course you have an antithrombotic effect, but you have also a potential antihemostatic effect. So it's not also easy. And we'll have to see how much in phase 3 trials these drugs will really prove that they are superior. And another thing, I mean, there are studies ongoing on end-stage renal disease, but in these studies that I showed you, patients with end-stage renal disease were excluded. So that's nice, but it doesn't help us a lot. So we'll have to see. And we do not have yet the data on patients with atrial fibrillation for stroke prevention. This might be a possible indication. So finally, 2 slides, very close to the end, just to show you that this is also as a small repetitorium, just to show you that it's not only about anticoagulation. You heard this during our workshops. We also have interventional and other approaches that may help, and other antithrombotic strategies. We had many long years of thrombolysis. We have discussed all this with its effects, but major bleeding risks. So many people believe that thrombolysis is now dead, but nevertheless it is some very effective treatment, and there are now combined low-dose thrombolytic and thrombolytic interventional approaches that are being tested. So we will have in the decade to come, for example, these are devices now that are coming into the treatment of severe pulmonary embolism. This is the ultrasound-assisted thrombolysis device, catheter. This is a catheter for thrombosuction, and we do have parallel trials that right now validate these with regard to clinical outcomes, and I would say that in 2025 we might have the first results. It takes a long time always in clinical research. So, to conclude, thrombosis will continue to have a major impact on patient morbidity and mortality, so it's not a disease that has been it's not a battle that has been won. We will still have many patients with thrombosis. We know now that the DOACs are the drugs. That was the major revolution. We have these drugs, and these drugs will remain. They will not be replaced by other drugs in the very near future. They don't need to. Important gaps do remain, however, in large populations: primary prophylaxis, extended secondary prophylaxis, end-stage renal disease. It's always about improving the safety profile of these drugs. And emerging surgeries target the so-called intrinsic pathway, which, as I showed to you, is not so intrinsic. It is overlapping, at least the factor 11, which is the main target. That is the target that is currently that has currently made it to phase 2. And so the revolution in anticoagulation is over. That's also, you can see that the funding for the spring school is also less, the sponsoring, but the evolution of anticoagulation continues, and I think that's also an important part. We don't have to have explosions all the time. We can also have periods where things can consolidate and become better. Thank you.
Thank you. Yeah. So thank you, Stavros. It's not more than logical that the last plenary lecture is given by the chair. Stavros, who has any questions? I'd like to challenge you a bit on your talk. Please. But before, there's someone in the audience who would like to raise a question. This is a COVID-free handover of the microphone.
Regarding the new drugs, are we not afraid of the half time they last in the organism? I mean, we do not have any means to reverse the effects. So in case we give the patient the antibodies and he or she needs urgent surgery, we do need to do plasmapheresis to revert that, right?
Yes. So that is a very important point. Thank you very much. I made a hint on it, but this is very interesting. The thing is, anticoagulation is not like cholesterol lowering. So when you lower the cholesterol, it's fine. If you lower the cholesterol, it goes down to 20 LDL cholesterol, then that's okay. It will rest at 20 in a month, and most people say that's safe. So there had been studies with idraparinux, with other anticoagulants, heparin, let's say, or pentasaccharide-based anticoagulants. And in these anticoagulants, I mean, the main problem was that if there was bleeding, so the problem with an antithrombotic drug, if there is bleeding, then you have to do something. And if you know, okay, we'll have to wait 1 week now until this drug is over, then it's a problem. This is also a conceptual and a practical problem we have if we treat patients once a week or once a month or whatever. So I do not have a ready answer to this. Seeing it from today's perspective, I would also have some reservations, and I'm also afraid that patients might forget to take their drugs if you tell them, okay, every 4 weeks you'll take your drug, or if they start to bleed, that we may have to wait then. And I told you that I showed you that anti-11 possibly will also bleed. There is no drug that will prevent thrombosis and not bleed at all. So very important point. We'll see.
Yeah, I would add to this that probably development is such that you get 2 ways. So a short-acting inhibition of the coagulation factors 12 or 11, and longer-acting. And Stavros had a nice looking back in the idaparinux, bioteparinux. So first there was a failure in the Amadeus study because that study in atrial fibrillation gave too much bleeding, which could not be counteracted due to the half-life. Then they developed a drug which had its antibody possibility, antidote in itself. So as soon as bleeding becomes a relevant point, which it will be, because I fully agree, there is no antithrombotic drug without bleeding, because it cannot work efficiently without giving this side effect. That is for me a dogma which I will never refrain from, being asterisks. And the second point is, so the short-acting drugs will come along if there is an anticipated need of a short-acting drug. So you still can choose. There was
perhaps one word on that. There is a small substance against factor 11 by Bristol Myers Squibb, which is also being tested. We have no results yet, but this is exactly as Menno says. This may be for instances where we will need a short-acting, or we will believe we will be better off with a short-acting. We'll see.
Yeah, Andrew.
Stavros, end-stage renal failure is a very curious condition where, when you test anticoagulants in those groups...
Which one did you say?
End-stage renal failure. So
yes.
It's a very curious condition.
Yes.
If you look at atrial fibrillation data, it doesn't behave in the same way in end-stage renal failure as it does in others. Are there other potential novel targets in the end-stage renal failure group? Because there must be more happening in them than just a simple coagulation cascade.
Yes, so right now, to be of clinical relevance, I showed to you, I mean, there is further work being done. We should forget, for example, factor 8 at 9 for the moment. I think this is not, it has nowhere shown that it is a way to go. There is some work done on these polyphosphates, on the antagonism of the polyphosphates. If this will be a target group, I do not know. And with factor 11, I think we will know relatively shortly if these drugs are promising there. And otherwise, as you said, it's complete chaos. In many countries, I don't know how it is done in your country, in many countries, patients with AF and end-stage renal disease receive nothing, or even PE and end-stage renal disease. You are afraid to give VKAs, they are bad drugs. If it is end-stage, many people are afraid to give low molecular weight heparins. The NOACs or DOACs are contraindicated. There is a false assumption that apixaban has been approved by the FDA for end-stage renal disease. This is not true. The FDA said, right, Menno, this is a common misunderstanding. The FDA said, well, we don't know, so if you want to use apixaban, use these doses because pharmacological models have shown that it may work in patients on dialysis. So this is a very gray area. But you know, I mean, we have patients with end-stage renal disease. We will not have fewer in the future. We'll see.
Yeah, I can add to that there are two studies in dialysis patients and apixaban, one from Duke and one from Frankfurt. And they have been published, and they show at least that there is a possibility to give apixaban to these patients, and better towards the endpoints of bleeding than vitamin K antagonists. So we have published evidence. It's a bit more than the theory, but it's not yet there, and it's a sensitive area. May I come back to a bit of challenge you and going back to the study? So you said that ozosumab gave more bleeding than apixaban, but this is of course crucial because it was given preoperatively. So the question is, if it's not more the design, because of course all of us know that preoperative use has been left. So I was a bit surprised that it was given preoperatively. That's my first point.
Yes.
And the second point, I see these factor 11 really as niche medications. So at the one side, what you alluded to very nicely, there are hidden areas in which patients cannot stand DOACs, so lupus anticoagulant, heart valves, so that's on the thrombotic risk, because it was a failure of the DOACs. So factor 11 is of potential solution, and the other side, there is more on the bleeding side, so especially in cancer, what we discussed yesterday or before yesterday, whenever it was, so in the GI tract, urogenital tract, and I know there is now from Antos company a study being anticipated, isn't it, that will look specifically at these latter populations. So please comment on that.
Yes, so regarding the second comment, I think we totally agree. So we have remaining gaps with regard to efficacy, and we have remaining gaps, especially with regard to safety. Maybe it will it will help in cancer. Maybe it will help in end-stage renal disease. I do not know yet. We'll have to see. The first point is indeed more difficult, and I will say the following. As you know, the strategy of starting before or after surgery is quite a controversial, is a controversy, is a US-European controversy. In many European countries, at least I know it in Germany, anticoagulation starts in the evening before surgery. In America, it does not. Now, even with the drugs we have available. So in this case, they started before with the ososumab, and it could be that the design of the trial showed that it is that was the difference. That it is difficult to say because, of course, as you know, you cannot say that was a thrombosis or that was okay when the thrombosis would have best been prevented, and so I do not know. It also showed, of course, that the preoperative administration was more effective. What might also say that European surgeons may also be right in starting before, but you also have more risks. So whether it is really wise to start preoperatively, I think with the drugs we already have, many surgeons would start preoperatively, and whether with the new drugs it will be okay to start postoperatively, we will see. But nevertheless, I mean, regardless of the of the methodological issue, I think we should not forget, I mean, this artificial division between an intrinsic and an extrinsic system, and then at the end they come together, is not true. Factor 11 plays a central role. So it's as you said, we will have bleeding.
Yeah, coming back to that trial is not able to make out the question and answer the question whether pre-op is better than post-op, because it's apples and oranges.
It's a dose-finding trial.
And that was a flaw to that study, as I remarked when reviewing. Anyhow, so any more questions from the audience? Yes, please. Important. Audience much more important than we two. Yes, please.
Hi. There is some evidence that has shown the strong relationship between complement activation and thrombosis. So I was wondering if, what do you think if the proteins of the complement system would be a good therapeutic target maybe in the future, because it might take out the bleeding risk, but I don't know if you have any insights on that.
Okay, so I am not an immunologist, but I will tell you the following problem. So the fact that complement is involved in thrombosis is partly covered by the nets and the polyanions that elicit this process. So I believe the fact that the polyanion antagonism is at an advanced experimental stage of testing, not clinical, experimental stage, shows that this is a way to go. The problem with starting inhibiting complement factors is, of course, the problems on immunity, right? And it's like the interleukin medication that people have given for many diseases like sepsis and so on. It's not that simple. So in my opinion, although I'm neither, I do not know if Karen is with us and can say something on this as an expert in rheumatology. Karen, are you here? No, but otherwise, or I don't know if Giannakoulas as an expert may be more in this area, but I do not believe that beginning to antagonize specific factors of this system then we will have other problems, right? We may have problems with immune responses.
And don't forget that factor 11 and 12 have a role also interacting with the complement pathway.
Yes.
So it's just likely that they influence indirectly also the complement system. But in terms of academic expertise and knowledge, you should take that back to your institution and try to contact the firms who are developing factor 11 antibodies, because it's your idea. Take it back. It's brilliant.
But I will tell you, at the CTH, there is a colleague who did some very nice work on factor 11 inhibition and interaction with the angiotensin-converting enzyme pathway. They found that factor 11 inhibition reduces blood pressure. So they published it in Science Translational Medicine. And the next day, patients started calling and saying, so since I have some blood pressure which cannot be regulated, so can I please come to you and receive the new drug, right? So it is difficult, and I do not think that, for example, factor 11 inhibition will be for that. But with complement inhibition, I would not see a target as such. Maybe as a collateral benefit.
Yes, answer clear. Other questions, please. This is your chance. Bon. France.
Yeah, is there any data to target fibrinogen itself?
Fibrinogen targeting, another chance for the companies. Fibrinogen targeting.
So, I do not think so. You should, fibrinogen, first of all, there is the whole area of fibrinolysis, right? That's what we had and we still have. The other thing is, if you're thinking of inhibiting fibrinogen, I would like to remind you, again, that's a little bit like the immune system. Fibrinogen is an acute phase protein. It goes up in many situations where it can be helpful. I do not believe that the target can be to start inhibiting the production of such downstream molecules. So you will have, this can be in some areas where we still need to prevent or to lyse fibrinogen, but developing fibrinogen as a, let's say, future approach to antithrombosis, in my opinion, this is not, that's too central and too downstream.
Do you agree, or would you disagree? Or do you have some secrets for us?
No secrets, but hyperfibrinogenemia does not bleed that much. And
Yes.
there are also develops thrombosis in sometimes.
So that's a very nice thought to think over. So go back to these families who have this dysfibrinogenemia and develop something with the company Servier or whatever. So this is but this is why the ideas are so nice and important in this school.
We have one final question.
Yes.
I think.
Maybe.
Yes.
I wondered maybe about the role of inhibiting kallikrein, because
Of-
there's
another one, inhibiting kallikrein.
There's research.
Yeah, I talked about this in the frame of inhibiting factor 12. So this is not right now pursued as an antithrombotic strategy. It is probably not relevant. It is probably not relevant in humans. So it has worked in mice. It has not worked in monkeys. And in humans, there is no factor 12 deficiency to test in this sense as with factor 11. So right now, I have not found any serious thoughts, let's say, to develop this. Theoretically, yes. But not as an antithrombotic strategy, at least what we know for the moment.
Yes. Yes, my question was because a colleague of mine shown that kallikrein can possibly bypass factor 11 and directly activate factor 9. And I was just wondering, maybe it can be like an adjunctive treatment to factor 11 inhibition?
Well, this is for the future, but keep it in mind and work closely with your colleague. I think we have come to a close and to this last lecture. Now we have a short interval because Professor Konstantinides. Yeah, but you have to sign.
I have signed. Who has not signed? Okay, so an interval of 1 minute. Do not leave. I thought we have signed.
Professor Konstantinides, such a signature. 1 minute for 2 signatures.
It all has to be done properly.
You can copy mine. It's very easy. My children do it every day. Now the tension increases.
The tension increases. It's getting very...
Just think for yourself whether you think that you have won the award, the poster presenters.
So
and think whether you have not won it, but are second. Still did your utmost, but unfortunately, maybe next time. If you won, you have to come back the next time, because of course the winners must come back. If you didn't win, there's more per se to come the next time to win it then, because you never know, there may be nicer presents. Because we cannot give money, but you can give presents. So Stavros will take that away. So, okay.
So you keep the certificates, Menno.
Okay.
Perhaps we will then, the two of us, I will just read the results, and then we will stand with the winner right in front, so that we can be can be on the camera. So first of all, can we have the presentation? Yeah, this is just for some statistics. Can we have the presentation to show a little bit what we had and then announce, of course, the winners? So this is just for you. This is, so it's not, so this is what we had, right? We had 4 abstract sessions. We had 43 abstracts from 11 countries, and we had 8 chairs. Okay, these did not candidate, they were chosen. So, as you can see, okay, so, which is, of course, is great. We had most abstracts from the Netherlands, which is important for statistical comparisons because we have a large denominator also. But we also had, so we had 8 abstracts from Germany, 4 abstracts from Poland, 4 abstracts from France. So it's not the number. I just want to emphasize that we were very much impressed by the quality of your presentations, the brief presentations here. There are many senior people who cannot summarize their main findings within 2 slides. So you made it, almost all of you made it, and also your presentation right outside Menno was very competent. So congratulations to everyone. So congratulations. You really did a great job, all of you. And we are not now going to give awards to the best, but let's say those abstracts that, of course, received the highest grades. So we had like the European Song Contest system. So we had already grades by the committee. that first selected the abstracts, so they were all of you who presented, and we had also then grades by the chairs based on the content, but most of all on the presentation. So, and I am happy to tell you that 84% of the abstract presenters received a score of at least 3 out of 5. So that is really shows how good all the work was.
Yeah.
And Katerina Moore, whom I thank particularly for doing all the work on this, she actually calculated statistically, because she has now been checking with Luca Valerio, and so she found that the average score was 3.5 out of 5, but Katerina forgot to put the standard deviation, but that's okay. So the first session, so we will have 1 or 2 winners per session, depending on whether there was the same grade, right? So Menno, so the first one is Dr. Baildildova. Baildildinova, excuse me. So Gaukar. I think for the photograph, I will remove also my mask, right? Yeah. So there is no money. It's just as I said, a small souvenir. So we are not ready yet. Now you can tell us. First of all, congratulations. Now please tell us with 1 sentence or 2 maximum what your work was about to remind everyone.
Thank you for the award. My project was about differential plasma signatures for platelet activation in acute pulmonary embolism subtypes.
Congratulations. Thank you. Photograph worked, Katarina? Yes, thank you. So the second Oscar goes to, that's also from the session 1, to Annabel Hartl. Right, if you come over to us, you will receive your certificate. Congratulations. So, Annabel, please tell us what your work was about with 1 sentence.
Yeah, my research is about the transcription factor ISA and its role in myocardial infarction.
Great, congratulations, great work. So we will have no handshaking for reasons, right, for COVID-19 related reasons. We just hand over.
That was our Prime Minister, Rutte, last year.
Yes. So how was it with the king, who was on vacation in Mykonos, and all the Dutch people were in lockdown? Is that correct? Oh, okay. And actually, you know, embracing his friends there, that was very nice. So, anyway, so the next one is Milo Stals. That's session 2. Congratulations. Small souvenir. So please tell us, remind us again what your work was about.
Yes, in this study we prospectively validated diagnostic strategies for suspected PE in patients with suspected and confirmed COVID-19.
Very good. Congratulations. Great. Thank you. Now we go to session 3. And here the Oscar goes to Chantal Fisser. So you may as well, you know, cry and thank your parents and grandparents and everyone. But you can say that, but you can also tell us just what your work is about.
Yes.
Oh, yeah.
Yeah, for the photo it's better.
Like in the Olympics, you know?
Yes. So my research was about the effects of COVID-19 vaccination on anticoagulation control in VKA users.
Congratulations.
Thank you.
Thank you. And we have one more, Menno. So the last Oscar, what's the best movie or whatever, goes to Natalia Brahms. So whom do you want to thank and what was your work about?
Well, my work was about the right ventricular function during exercise in patients after pulmonary endarterectomy for CTEF. And thank you, Lilian.
Thank you very much. Congratulations. And again, I want to emphasize all abstracts were great. This is not just to say something polite, but this was the case. You all contributed to 4 excellent abstract sessions and very nice poster demonstrations that could be good for any international congress. And I think, so from my side, we are now free for lunch, but Dr. Huysman wants to have the last word, as always.
Yeah. No. You always had the last word. So we convey again at 3 o'clock, is that correct?
Yes.
And then will be hand-on tutorials, 1, 2, and then we proceed with the workshops. And I have one take-home message for all the ones who have done poster presentation, as well as the supervisors, to make announcement and commercial for our spring school. This is so important. We have had more abstracts than ever. In spite of our situation in the world, I tend to evade this word beginning with a C, because I cannot stand it anymore. But this is crucial. So please take it back and say to your other colleagues, this is a school which is different from any congress. And this is, of course, a bit making commercial, but this is for us so important. With the abstracts, the school is 200% more than without the abstracts. Yes. Thank you very much.
To all workshop attendees and all workshop presenters, so because tonight we have our beautiful dinner, please make sure that workshops are really on time today. Do not exceed the time, because if you are very late, first you will miss the sunset and then it will be too cold, the dinner may be too cold. So we will have to be ready. I think it's 18:30. And then we will have a brief session on asking you for your suggestions on what to do better next time, as we always do. But we will be ready at about 7 to 7:15, right? So at 18:30, the workshops will be ready, will be done, right? And then, okay, 35, we'll give you 5 minutes. And then 18:45, we will have a brief session here. We want to ask you for your feedback, and then we will be ready at 7:15, the latest. So then we can go over for our dinner. Kara will give us some information. The dinner, yes. Yes, Kara, so that will be the beach restaurant, not up here, so we'll be very close to the sea. I hope it will not be that cold, but I mean, make sure you are also, I mean, it's late in the evening. So, and then of course you can celebrate and have fun all night, but do it in a decent way. Yeah. So, very fine. So, see you at 3 o'clock. Now, you're free.
I'd just like to ask the abstract winners just to stay here for 5 minutes to take a photograph all together. It would be good.
That's very good. That's very good. And,
Please look at them again in the future, just as a general reference. So, because this will today really hands-on workshop, so we will not bother you with slides. So this is why Stefano said we already sent it to you. And in front, many thanks to him to be the model. And also with this kind of workshop, we want to encourage you to use sonography in your daily life, not just to do computed tomography. The sonography and the echocardiography is cheap, and it's really easy to access. And especially with this device from Philips, but also from other companies. But many thanks on this point to Philips Greece to give us the opportunity that we are pretty sure that this kind of device will be available in every smaller hospital too. So because it's, we know that if a patient is coming with dyspnea, it's not all the time pulmonary embolism. There could be also other reasons. So it's so important to have the echocardiography to exclude diseases also of the left heart and also to assess other problems. So we will start directly with you. Please take off your shirt. And I will show you the most important sections. And then we will try that maybe 5 or 6 people can at least try the 4-chamber view, because in the 4-chamber view we can see the RV dilatation, but we can also do with this device the M mode to assess the RV function. And of course, as I said before, we can also exclude other diseases. So this what you should try, and also when you're in your hospital, try to do it too at the night shift or whatever, because it's not as difficult as it seems like. So maybe yes, you can also say something. So lie please on the left side. Yeah. Yeah. So for the 4-chamber view, you put the probe between the 4th and 5th intercostal space, and then you have to hold it a little. So then here, maybe you can go a little less deep. Yes. Okay. So now you can see the 4-chamber view on the, okay, so like here. So now you can see the right ventricle on the left side of the screen, and on the other side you see the left ventricle. And if we stop now, yeah. So now in the end-diastolic, you can measure the diameter of the right ventricle and the left ventricle, and it's quite easy. So this is the RVD1. So it's slightly above the tricuspid valve, and you see that the distance is something about 32 millimeters. If you want now to compare the ratio between the right and the left ventricle, you will do the same for the left ventricle, and you can see the distance is almost 39 millimeters. So if you do the ratio, it's really below 0.9. So from this side of view, there's no signs of RV dilatation. And also, if you want to look for the absolute numbers, the RV is below 41 millimeters, so the right ventricle is completely okay in this patient. So we don't just want to know about the dimensions of the right ventricle, we also want to know about the right ventricular function. And this also, it's quite easy. You can put the M mode, please put the M mode. And now you put it on the lateral side. Yes.
Yeah, that's okay.
So, stop it, yeah. So, and now you can see the movement of the tricuspid valve from the basement up, and now you can measure how the movement of the tricuspid valve is, and you can see the distance is something about 30 millimeters. The pathological value would be 60 millimeters. So this patient, our model, has a normal dimension of the right ventricle, and he has also a good right ventricular function with the TAPSE. This is calling this kind of measurement of 30 millimeter. And that you also have the chance to try it, I just want to show you one more possibility. It's a subcostal view.
Yes, Lucas, do you allow me to say?
Of course, yeah.
Here I always want, sorry, I have to talk. So, here is someone comes to you, and because there's a lot of questions, doing an echo or calling someone for an echo, so all these discussions nowadays are worthless. So here is someone, he cannot tell you what he has, he's unconscious, he looks very sick, whatever, and he's blue or he's white. So he looks, the first thing that he does, before he does TAPSE or whatever, right, he checks this subcostal view. And he can now see if there is pericardial effusion. Always in intensive care, the thing is, find something immediately that you can treat immediately, if there is something that you can treat. So here you can see, this is the ventricle, the right ventricle, up there, right? There is nothing between the liver and the right ventricle, so that means there is no pericardial effusion, tamponade, so you don't have to puncture. And you can see that the right ventricle, right, Lucas? Is very small compared to the, so this of course is now, we have quite a lot of light, but this is very small compared to the left ventricle. So you already have, and you can also see that the left ventricle is pumping okay. So within 15 seconds, not minutes, within 15 seconds, and without doing anything, but just putting this thing on the patient's belly here below the xiphoid, so what you have is that you have excluded massive pulmonary embolism with shock, you have excluded pericardial tamponade, and you have excluded that this patient has, for example, acute dysfunction of the left heart, for example, huge myocardial infarction, pericarditis. I mean, he may have now sepsis, he may have other things, but within 10 seconds you have excluded 3 dangerous things. You have not excluded PE, but you have excluded a PE that would explain why he's in such a bad condition. Right? So that's the good thing about the echo. So always in intensive care, and also, yeah, please show the cover, very important, not only look at the heart, this is, right, this is the entry of the inferior vena cava. So when I started echocardiography, and we had a 250 kilogram device back then in the 1990s, my supervisor told me, don't look at anything else, that's no problem if you forget it, just look at the cava. So if the cava is not congested, below 21 millimeters, so 2.1 centimeters, and if during inspiration it collapses, then you cannot have right ventricular failure. Then this is not a patient, for example, with massive PE, if he's so sick. So this is useful. How much is it? 130, right? So below 2.1. So now you can also say, this cannot be a patient, so if he's now hypotensive or doing very bad, so you have answered this question as well, right? This cannot be a patient with acute right heart failure. Very simple, primitive.
I have a question probably out of the topic, but How often? Sorry. How often? Okay. Sorry. How often do you search for the diastolic dysfunction of the right ventricle? And is it worth it searching for the diastolic? And what is your personal opinion?
Yeah, at this moment, the diastolic insufficiency or diastolic dysfunction is not playing a role in the right ventricle for assessing the right ventricular dysfunction. But normally we do the RV diameter in contrast to the LV ratio or to the LV to calculate the LV ratio. And we had a paper together with Pruszczyk to additionally assess the TAPSI, and we demonstrated that if you assess RV dysfunction based on the RV-LV ratio and additionally put the TAPSI on it, the prediction of the patient is worsening than if the TAPSI is normal.
Diastolic parameters are not current standard of care. Don't have to worry about them. It is not for clinical practice. So if you want to do echo research, it's fine, but you do not have to do so like we do, like we do at the mitral valve, so that we check the Emax, the Amax, the deceleration, then we do the
E to E prime.
Exactly, so we do not need to do the tissue imaging, the tissue Doppler, and so on. We don't know. I mean, you can do it, but it does not acutely help you. It is not standardized clinically, right, Lucas?
I totally agree.
If you have myocardial infarction of right ventricle.
If you have myocardial, but this will not be the diastolic. This will not be the diastolic function. So how do you diagnose myocardial? That's a good question. So how do you diagnose right ventricular myocardial infarction? So how would you distinguish it from acute PE? In both cases, huge right ventricle, paradoxical septum, congested cava. So what is the answer? We can't?
We might measure the jet velocity of the pulmonary artery, and
yeah, that's the answer. In that case, what you have to do is, but we do not have continuous wave Doppler for this emergency situation, but in that case you may need the cardiologist. So if you have such a first of all, you have to check that you must have inferior wall myocardial infarction, so it will not be just like this. In order to have shock due to right ventricular failure, it's not just the in V1 leads that you have some elevation, it's really that this patient has very severe myocardial infarction, inferior wall, and then you have to get the big Phillips device, and then you have to check, because then you have such a huge ventricle, and you have a velocity of 1.5 meters per second, or 1.8, nothing. It generates no pressure, right?
Exactly, yeah.
Okay.
So I would say we continue with the questions, but on the same time point, I want to encourage at least 4 or 5 colleagues just to do the subcostal view. You have to do it also in the clinical practice. It's really important and it's quite easy.
Apical, right?
Or the 4-chamber view. So take your chance. And meanwhile, we will do other questions, of course.
Don't be afraid. We will not examine you. We'll have our model.
So take the probe and take your chance.
So, Katarina, how is it in clinical practice? Because that's very kind that you are sitting next to the colleagues, but or standing. Otherwise, he just holds it on his other hand, or he puts it on the table.
Also genau, der Probe ist quasi ist da. Ja.
Okay,
Und dann
okay.
einfach reindrücken. Just push it.
Some people use tripods. Some people use just regular.
What does it say?
Give me a second, please. Okay, it got disconnected. Give us just a second.
So should I hold something?
This is actually a really good way to show you that you have to first put this, then this, so that it doesn't come off.
Oh, yeah, that's.
So I think there was another question to break the time. Oh, sorry. It's working. Ja, ich komme auf die andere Seite. Genau, perfect.
Perfect.
Very nice. Not yet. So you can also see next to the liver there the right ventricle. It's quite small. There's no pericardial effusion, and from the distance, the diameters, it's smaller than the left ventricle. So now you can exclude what Professor Konstantinides said before. There's no massive PE.
Christine, if you want, I know it's not so easy if you haven't done, to just show the inferior vena cava. Yes, yes. That's it. That's it.
Yeah. You want to do the fourth chamber?
Yeah.
So please lie on the left side. Oh.
So it's good to see where
Yeah.
I have to put it.
Genau. You have a little more sonography here. That's okay. Oh, perfect.
Could you freeze this? Can you move it a little bit forward? So let's see. Okay, what is this? I know we do not have many cardiologists. What is this? Lucas, you know it, right?
Yeah.
Okay. This one? Is it a vessel? I mean, that's the right atrium in here. And something comes into the right atrium. What is this? Yeah. Very nice. We do not examine the coronary sinus to see some pathology, but it's good to know that this is what comes out.
So we tried again. It was already good. No, very good.
That should be good now. Yes.
So now it was a little the 5-chamber view. So this it's quite good, perfect. Yeah. Do the M mode properly. So now we go with the M mode to the lateral thoracosphere valve, and now we have a more nice signal than before. You see that the waves is moving, and now you have to measure from the lowest point to the uppest point, and you have again a TAPSI about 27 millimeter, which is quite far away from the cutoff. So next one.
Thank you.
And if there
Afterwards, you can collect your board certification in cardiology. Okay. We have some printed outside.
This one, yeah. So for the 4-chamber view, you put the probe between the fourth and fifth intercostal space, and the mark is orientated to the left shoulder of the patient. And of course, you have to adapt a little because the heart is lying in every patient a little different. This is quite good. Hold it. This freeze. Mm-hmm. And here again, you can measure the diameters. And we have the sinus coronarius when you have so perfect. Good. Next one.
Maybe show one thing. Can
Yeah.
I show them one more thing? I'd say, as we are looking at the article, and one more colleague can also come. I don't want to, but just to show something here. So a little bit to myself. So, because I was thinking, if we will be able. Yeah, I was hoping we would get a better. Yeah, here it is. Yes, so one thing for you to know, when you are, this is typically difficult in slim and quite tall persons, so it is sometimes more difficult, but please try. So of course this comes with experience, and it has to do, of course, with the somatotype of the patient, but please try to have the heart in the middle of the picture, right? So that the septum is the middle line of the picture. The thing is, if you want to focus on the right heart, your heart has to be tilted slightly, right, Lucas? So you see here the right atrium is now, so don't do the heart like this, right? You have to go a little bit focusing more on the right heart, so that it is the right heart that is in the middle of your image here. Yeah. You do not show them the parasternal, right?
You can show the parasternal. Sometimes it's in young persons.
So this is very nice in young people, the parasternal view. You can see very beautifully the aortic valve up there. You can see the mitral valve, which is very nice to see. And if you look at it, yes, that's nice, right? You see very beautiful, very smooth valves, very tender valves, as they should be. If he was an old person, he would have thick white valves, which is the calcination. So you see very nice flow through the aortic valve, and this is the mitral valve now. And if we take off the color and just turn it by 90 degrees, this is the cross-section of the left ventricle. And if the left ventricle is, above the left ventricle is the right ventricle. So if the right ventricle is too big, and if it is pressing on the left ventricle, then this one would be a totally flattened septum. Lucas, maybe you can show the septum. And this is not the case here. So this is a very nice, you see all sections of the right ventricle of the left ventricle are moving okay. We can freeze, please. Okay. So what you can see here is, so this is, for example, so in the middle you see the mitral valve, right? The mitral valve is closed, now it's open, and you can see very nice all the walls of the left ventricle, which you can see as a circle, as a ring, are contracting very nicely. So it is really very, very simple to do. And within a few seconds, if you do it on an emergency basis.
So, I think it's your turn now. There are some additional questions from the audience.
Yeah, I was looking how to connect.
And Lucas, you have to leave, right?
I have to leave, yeah.
You'll miss your plane.
Yeah. Okay.
2 minutes? 3? It's okay. You want, so, exactly. Yes, so you do the subcostal. So very simple, he's lying down, he cannot tell you anything. And you go, subcostal means that you're exactly subcostal. And you look at, and then you have, yes, and of course you have to remember where the heart is.
Yes.
So, like that, right? And the heart is of course beneath it, so you do not have a perfect figure right now. You have to try to get the 4 chambers. Sometimes if the patient breathes normally, you can ask him to breathe in, deep, It doesn't help, it's not always. So this is some, this is a little bit, so this one, this part, it's easy to remember, this part should also face you. This part should also face you. Now, because now you have dextrocardia transducer. So just remember, this thick line always faces yourself. So, and then it's easy. Yes, that's better, that's better. Yes. Yes, exactly. Right? You see the liver, you see nothing between the liver and the right heart. The triangle, which is the right heart, then you can see the septum, if it is dark, and then you see the left heart. Of course, we must say, Katarina, you agree, this is, of course, not as beautiful as the image you get on the full screen, right? On the full, but yeah, but okay, the other one is a 200,000 device, or not depending on it, and the other one is for the full echocardiographic. This is just for you to tell now, is this acute severe B? Yes, perfect.
If I try the inferior,
and then you have to go to the inferior vena cava, sorry, and you have to go here, that's here. Excuse me, that. Here it is, that. That is here. That is the inferior vena cava, right? You see, in the middle.
Yes.
Hepatic veins coming from above, and this is inferior vena cava.
Okay.
So if you've done it a couple of times, then it takes you 15 seconds to do it.
Yeah, I know on the ward it's often a question if they don't know what the filling stages of the patient is.
Yes.
Yeah.
Very simple.
Would be nice to be able to.
Yeah.
Okay. Thank you.
Shall we hand over to Dr. Parker?
Would you like to do heart or veins? Heart or veins?
Can I?
Heart or veins? Yeah. Go ahead.
Gel is at your feet. So this is basically. If you want, you can come closer.
Perfect. Yes, and a little bit shifting this way because the heart is here, so you have to be look. Yes, very good, and get a little bit flatter, probably. Yes, that's it. Now you see the tricuspid valve. Yeah. Now you see the triangle, which is the right ventricular cavity, right? And then above it, I mean, this white line that you see is the epicardium, actually, or the two layers of the pericardium. And then you see the liver, yes. And then you have to turn. You can also have a look if you want to know like this. We're taking the vessels off Dr. Barker. It's very brief time for the workshop, right?
Oh, apologies. No, we can
No. So now you have to go here to the fifth intercostal space and try what is all. So now you have to find the so-called, here it is. It's of course, here it is, you know. And you know, because you may think, see, that's perfect. That's the right image. If you tilt a little bit towards, you know, towards the head, then you get the aortic valve, because the aortic valve is in front of the mitral valve. It's not to the left. And if you tilt towards the spine, then you get, oops, here. That's it. Here you can hold it. So sometimes, depending on the person, you have to find the lowest space available in which you see the heart. It should be apical and not supraapical. If you go too far up, you get huge atria and small ventricles, and you say that's a big problem. So normally, the ratio of atrium to ventricle is 1 to 2. So if this is all a 3. So.
Yeah, sure. I mean, I guess. I'm already here.
for the baby, I don't know, shall we stream when we check the veins? That's okay, right? I mean, not that the people...
Are we streaming? Yeah. Are we streaming now? Yeah, you can turn the streaming off, perhaps.
We would not stream for
this one, yeah. So, question for the audience. Who knows what's the standard way to diagnose a proximal distal deep vein thrombosis below the infrainguinal ligament? Compression ultrasound. And how would you diagnose a thrombosis in the common iliac vein or in the vena cava? Just by looking at your femoral vein. What is the best signs when you expect thrombosis of the vena cava, let's say, that is occluding
within half an hour. But this is something that really works quite, really can be learned quite fast after a few patients. And you can really complete it within a few seconds. Yeah, that's nice. We can leave it on the chair perhaps so that...
Yeah, I don't know.
So now we will have the second. I will just check. I will go out and call the other one. Oops.
Kann man das Ding jetzt hinlegen?
So now we have here number 4 and number 3 will be in the other room, right? We are number 4, right? 3.
Yes. So let's wait a few more minutes for other people to come, hopefully.
And our guest.
Of course.
The other tutorial is still ongoing?
Yeah, we have to. I asked them to throw the others out of the other.
Okay, yeah, right. Yeah, it's a pity. We need to rush.
Yes, the duration. So maybe we can have a very quick question. What you think? Do you think that the workshops are too short?
Or
They are short. I mean, I know they are short. But would it be better to have fewer workshops and not cover the topics? The problem is, I mean, there are some things that you know, well, they should be longer. But the other question is, what is the better idea, right? If you can say, well, some topics perhaps are no longer so important. Until now, the impression was that you find most topics that are at least, or at least all of them, that you found them important. But if we want to cover those 12 topics that have been, let's say, our classical number that we've had from the beginning, we used to have them 3 in parallel and cover them better. But then, of course, what we had was you were able to follow 8 workshops out of 12. You would choose which 8. We could get back to this. Yes, so this is until we start. No?
Yeah, yeah.
We could get back to this, 8 out of 12, or we go to 12 out of 12 the way we have it now. But then the only way we can do it is indeed to have 45-minute workshops, like a lecture time. Don't know, Christine, what do you think?
I like it the way it is now with 45 minutes. Maybe just the only thing that we could prolong a bit is the hands-on.
Yes. perhaps this is a good idea. So we will bring the flip chart in later. And perhaps the good idea will be perhaps for the more theoretical discussions, because this is something you can continue outside, but you cannot continue the hands-on outside. So perhaps this is a good idea to, this would be a good suggestion to say the hands-on should be 1 hour, so that everyone would have, let's say, half an hour full for the heart, half an hour full for the vessels, and that could be better. And if we could tease some time out for some more hands-on outside the workshop, if someone would like to come on, and the lady, she's got, and the lady from Philips, for example, she's here, would be here to help someone, or from the simulator. That could be some. But it's all eating time off your breaks, right? And that's the problem. Let us start, right? What do you think?
Maybe we just start.
I think we can start, yeah. So, hello everyone, dear colleagues. Welcome to our workshop from the first idea to the first patient enrolled, conducting clinical trials in academia. And this workshop, so with this workshop, we would like to provide you insight in setting up a clinical study and also to increase the visibility for what's going on behind the scenes and how much work it actually is or how much work is required to set up a study until you have your first patient in. And I'd like to start introducing my colleague, Dorothea Becker. So she is a molecular biologist by education, and since 2017 she's working as trial manager at the University Medical Center in Mainz, Germany, in the Center for Thrombosis and Hemostasis.
Yeah, thank you. And I would like to continue to introduce to you my colleague Nadine Martin. She is biochemist by education, but she also made her way into clinical trial management, and she joined the CTH in Mainz already in 2014. So, as US Americans would say, we are senior clinical trial managers at the CTH. Additionally, I'd like to introduce our guest of today. He is a young, ambitious scientist, a high potential, I would say, might once become a key opinion leader. Please welcome with me Dr. Konstantinides.
So I will come with an idea.
Yes, he approached us.
They have to do the study for me, right?
Yeah, and just before Dr. Konstantinides is going to present his idea to us, I would just like to say this is meant to be an interaction meant to be, if you have any questions or comments, please don't hesitate to interrupt us. Raise your hand and you will receive a mic. So also the people joining by stream can hear what you're saying. So we would really love this to be interactive. Thank you. Dr. Konstantinides.
So, yeah, the way this is, so I come to you because I've heard that you have this clinical trial unit at the CTH. So you are expert trial managers and you know how to set up the study. So, and I hope that will be very easy to do, because I have a great idea. And the great idea is that my supervisor, who's a senior scientist, did a study, and he studied this intermediate risk pulmonary embolism. They did a thrombolysis trial. Thrombolysis was very good, but there was a lot of bleeding. So now I came up with the idea, let's reduce the dose of thrombolysis. So what I want to do is a randomized, controlled, double-blind, everything trial, so the best that you can get in the market. And I will halve the dose. I will give half dose thrombolysis versus standard of care heparin. And what I want to show is that this half dose thrombolysis is effective, is better than heparin. But I also want to show, of course, that it does not bleed as the full dose bled. So this is the idea. So what I wanted to ask you, I can give you a few numbers. So I would like to ask you to write the protocol, submit the study to the authorities, and then we can start. I'll speak to my friends in the hospitals in the area, and we can start including patients.
Thanks very much. This is already quite some information. So, as I understood, this is you like to test a drug in a specific patient population. So this is a medicinal product study as opposed to a medical device study. These types of studies are actually subject to different regulations and laws, but no matter which type of study you want to perform, clinical studies are increasingly highly regulated, both scientifically and legally.
Yes, and therefore I'd like to ask you, the audience, what do you think would be the next concrete steps or the basis to set up the study when you have the idea?
What would they ask you for? Okay, now.
If you approached us, what would we like you, in addition to this idea?
Very briefly. What must the scientist deliver to the managers?
So just a hint for you, this is always included as the first part in your protocol. So what?
The principal investigator, the funding, things like that?
And no, this is
in
too
there.
detailed.
It's
It's
also
in there,
in
it's
there.
in there, exactly.
We don't have the funding yet. To get the funding, we need something other first, something else.
The first part of the protocol, or, yeah, please.
Maybe a very detailed description of the study, how many patients are needed,
Yeah.
Exactly. So this is what we need, a structured trial synopsis, so the summary of the key data of your study. And here we will show you, can you click here? So we show you a plank synopsis. This is actually taken from the German Research Foundation, a German funding agency. But the information they require is almost the same across all EU funding agencies, and we will come to this in detail in a few minutes, except the statistical part, because there's also a statistical workshop held by Dr. Vico and Dr. Valerio. This is also today. Yes.
Yeah, as said, this trial synopsis is part of the protocol, and it's actually, yeah, it's essential for the protocol, but not only that. So it's absolutely essential in many ways. It's your must-have, so to say. So, for example, if you want to introduce or describe the study to a possible sponsor, this could be your medical institution, the scientific director. He will want to receive details before he agrees to take the responsibility. And then second, as already touched upon, if you apply for funding, the funding agencies will always ask for that. And third, you might want to introduce that study idea to your network, meaning other investigators and researchers which you would like to invite to take part in the study or in the application process.
So the synopsis is not something the managers do for you. The managers will write the protocol for you because the protocol has a large part of regulatory things that must be done by experts in regulatory issues. But you correctly, not you as a person, but the steering committee that you have chosen with your expert friends and colleagues, you will now deliver to the trial managers, and then to everyone else, you need to, as Dorothea just showed, this synopsis. And the structure of this synopsis, the elements that are needed, are the same everywhere in the world, with very, very small details that are different.
Yes, right, thank you. We would like to go into some more detail of these three fundamental items or questions. And let's start with the trial sponsor, the sponsor in clinical research.
Exactly. So does anybody of you knows what in clinical research the term sponsor means and why you need a sponsor to perform your trial? Yes, please.
I hope I'm not mistaken, but it's either the hospital or
it can be an institution.
So if it is investigator initiated or not, and I guess it's about more legally who's responsible if something goes wrong.
Exactly, this is very good. So according to the ICH E6, so the guideline for good clinical practice, which actually our Bible, to say it like this. The sponsor is a legal term, and he takes all the responsibility for the whole trial.
can be an individual or a company or institution, of course, and the sponsor does not necessarily finance your study. So, of course, he can, but as we are talking here about clinical trials in academia, it's usually not the funder or the one that funds your study.
Course, this is nice, but of course in clinical trials, in serious clinical trials, the sponsor is never one person, right? The sponsor is always an institution. So it will be your hospital, your university, so whatever legal. And of course, it also can be an industry, a company, if it is a company-sponsored trial. So that is, you can have an investigator-initiated, industry-sponsored trial. So it is possible, but.
Thanks for this additional information. Yeah, talking about financing, this was the second item or big question. So you should have sufficient funding to perform your trial. There are different funding opportunities, and you should make some research to find opportunities that fit your project. These opportunities can be public, industrial, or even private, but as we are talking about academic clinical trials, funding is mostly provided by public funding agencies. And the application for public funding is often a two-stage process, and we would like to go a bit into detail regarding the first step of the application process, which is the outline process or the draft proposal, which again contains this synopsis that we have shown before. So what is the very first item in this synopsis or for your outline, and it's very crucial for your study? That is the hypothesis.
Exactly. And this was provided already by our researcher, and the hypothesis, so it provides justification for the study and also the direction to the study. But it is only a general information, and now our researcher has to specify what exactly he wants to test. So the researcher's task is now to define the endpoints.
Yeah, right, endpoints. Can somebody define endpoints in clinical trials to me? Is there anybody who would like to tell me what endpoint means in a clinical study?
So after stating generally, we want to state that drug A is better than standard of care, or it is not worse, but it is safer, whatever, then we have, so that is overall, that is just an introduction, what we want to do, but then now we must become specific. This is blah, blah. Now we have to get specific. Yep. Specific means, what do we want, so what do you mean better? Better in what? So what is an endpoint? Yes, but why is it called endpoint?
Target? Yeah, but what will the target be? It must be something, and maybe I give a hint, it must be something measurable, right?
Yes, like the statistical significant data postulated by your hypothesis. And when you reach that data, you stop the trial.
Yeah, that's already pretty close. So in very simple words, it is an event or outcome. Endpoint in a clinical study is an event or outcome that can be measured objectively to determine whether the tested intervention was beneficial or effective. Yeah, and I'm sure you've all heard about it. There are different kinds of endpoints, and the most important one, or the main result of your study, will be the primary endpoint. And we are not really going into detail into this area, but can somebody tell what is the relevance of the primary endpoint for the study? Why is it so important to define that primary endpoint from the very beginning? Yeah, please.
I think for the sample size to calculate.
Exactly. Yes, very good. Yeah. So the statistician will actually, on the basis of existing data, the statistician will use the primary endpoint for power and therefore sample size calculation.
So that's a good point. That's a good question. Okay. So you go to your statistician and say, you know what? I want you to calculate the sample size because my primary endpoint will be, let's say, death or shock within 7 days. Okay. So So you go home, and then in 1 week you come back and ask the statistician, have you had it?
I think
what is missing?
The statistician would like to know what is a clinically relevant difference, or the expected difference. Maybe?
So before he knows the difference, he must know what differs, right? So so if you have two arms, what does the statistician need to know? Yes, the standard arm or control arm, best, right? So if you say this is it, he must know how much percent is it in the control arm. And how will he know that?
Literature, or you will tell him?
It's your job to tell him. It's not the statistician's job, right? You must know. So, which means you must choose your primary outcome, not just because it seems very important to you. So it's primary, so primary must mean it must be important. But you must choose something which, based on the evidence you have, can be measured and you can estimate approximately. Of course, if you knew everything exactly, you wouldn't need to do the study. Say, I suppose this will be 3% in the placebo, and it will be probably 30%, or vice versa, the 3% in the control, and 3% only in the arm, and then please tell me, I want to compare those to find a significant difference. So this is, of course, statistical workshop, but you have to do this work. I'm saying it because people come to us, usually surgeons, and say, you know, we want to do a study, you have to show better thromboprophylaxis. I said, so, well, what exactly do you want? I don't know. You will tell us. No, we will not tell you. You will tell us what you want to compare, and Dorothea and Nadine will, and me, of course, also in support will do it. But this is your job. It's not the job of the trial managers, and it's not the job of the statistician.
Right. Yeah, exactly. Yeah, and then, of course, you can have further endpoints, secondary or safety endpoints, which will additionally characterize the safety or efficacy of the chosen treatment. All right, so now we have a hypothesis, and we know what we want to measure. So we have our endpoints. The next question would be, in whom do we want to measure? And that brings us to the item patient population, as well as eligibility criteria. So this would be inclusion criteria as well as exclusion criteria, and you can see there are study or disease-specific inclusion criteria on the one hand. These will be provided by the researcher, and there will be other criteria required by law or GCP, written informed consent, of course, should never be forgotten. And the same applies to the exclusion criteria, and also here labeled in red, the general criteria. Yeah, with that, we come to the next step. So we know what we want to test, in whom do we want to test it, and now what exactly will these patients or this group of patients receive?
Yeah, so the treatment or procedures shall be defined. It was now already mentioned. So we here we have an experimental group. So the control group, and we would like to compare the verum in the experimental treatment group against the placebo in the control group. And here it's important that the placebo cannot be distinguished from the verum in appearance, and also not in the route of administration. And now we've talked about some features of the study already, so I'm pretty sure...
And not only this, Nadine, you will need to, and again, this is your job as investigators, you will have to describe them. So within 6 hours of the inclusion criteria, you will start the infusion X, and it will go on for 15 minutes, and then you will give this. So you will have not only to say, we will compare heparin with 50 milligrams of that. No, you will have then to describe exactly how the treatment will be, because this is a protocol. You have to standardize the treatment, and this is sometimes what takes most of the time for a steering committee. You have to agree on exactly what will happen when, and that is a good study. That is an integrity of the study. Otherwise, if everyone is allowed to do any way they like it, then it's fine. That's a registry.
So it must be specific. But on the other hand, a pretty recent GCP requirement is also that you should not, that your study should not be overly complicated. So it should be very specific and precise, but yeah, keep it to the required limit of specificity. User-friendly is a good term, yes, exactly. Thank you.
Otherwise people will violate the protocol because it's too complicated for me, I don't remember everything. On the other hand, it has to be specific enough because otherwise it will be laissez-faire. So, and this is not what should be the case yet.
Yeah, exactly.
So I think we can, yes, we can move these,
Yeah, so, okay, now we come to the trial type.
That's more statistical, yeah.
And yeah, I'm pretty sure that you can, or you will answer all the following questions. You can do this. So, what do you think is an interventional or an observational study? It's an interventional one, okay.
The example study.
Catheters or balloons?
What does interventional mean?
It just differs from the
simple.
routine treatment.
Yeah, did everybody get that? Interventional, the definition? Yes, it's a deviation from the standard of care. Actually, yeah.
Okay, then is it a randomized or a single study? If you think of the slide before, it's a randomized one. Yeah, it's is it placebo-controlled? Do we have active comparator? So it was said before also this placebo. And there's a blinded or open labeled. As we have the placebo, it should be blinded. Okay, so to sum this up, we have here a randomized placebo-controlled trial, so-called RCT, the gold standard in clinical studies. But yeah, you do not necessarily have to perform the gold standard, of course. You have to think what's the best solution for your idea, for your medical question, and you have to define the trial type in the beginning, very close with your statistician.
So what is better, a double-blind or an open-label trial?
And is there a correct answer to this?
Can you think of a situation where so double-blind would mean I give someone drug A and drug B, they look identical, right? There's two tablets, and I don't know, they don't know, but of course someone knows, because at the end they will have to compare. And but in which situation would you say, well, I have treatment A, treatment B, I must know as a doctor what they get, the patient knows, and is this acceptable, or is it nowadays not acceptable?
I think, for example, in some types of surgery, it will be difficult for the patient not to know. I
think sham surgery will be very difficult, or even catheterization. There used to be double-blind, not double-blind, but single-blind for the patients with surgery. If you can imagine, bypass surgery, some procedures in the 60s, but of course nowadays they would kill you if you did that, right? And catheter interventions cannot be sham interventions. If you insert the catheter, you must do something and not say, yeah, we inserted it and left it in place, just that the patient thinks that's right.
Yeah.
And what is the important thing if it's open labeled? Because then you say, wow, then you are biased, the patient is biased, so.
Especially when it's placebo.
So what do you have? Then perhaps the study is not worth much, right? Well, in the end, everybody said what they thought.
The outcome must be very objective.
Yes, the outcome must be measurable, as the manager said. It's not like, are you feeling well? Yes, I'm feeling now much better than the procedure. Okay, no, this is not okay, because in this case, patients always feel better if you do something. And what else? Very important.
The analyst can be blinded, maybe? Or,
Yes, a blinded adjudication committee. So there must be a committee that will, independently from you and the patient, of course, and independently from the investigators, receive the outcomes. The committee must and will not and cannot know what the patients received, and then the committee will say, yes, this was an outcome, yes, no, this was not an outcome. It is not perfect, but as Dorothea said, you cannot make it too complicated. And if you do a study versus VKA, for example, double blind also means double dummy. People get some INRs, they are false, and it's a huge mess. and it's tens of millions of euros, and that's nice to say, to discuss, but not easy to do, right? Okay.
Yeah, thank you. Then also required for your studies outline or the first stage in the application, not also for that, very briefly, they will want you to provide a flow chart describing the measures and the timelines, including time windows of your study. This is a simple graphic representation of a randomized placebo-controlled trial, and in most randomized trials, randomization is time 0. In this case, we have 2 follow-up visits at which endpoints are collected. Yeah, this is not only for the synopsis, but also you might want to put it in the protocol or in your design paper, and it's always good to have if you present your study in. Yeah.
This is also important because if you apply for funding, you must tell people what you need the money for and how much. So
exactly,
they
will want to know.
Every visit, this is what I want to do, which is not the standard, because if it's the standard, it's paid by the insurance. So for this visit, this, for that visit, that, for that visit, that, this costs so much time of work, so many consumables, we have that, and then this is how then the managers will write the budget. Because if you say, well, we'll observe the patients for 2 years, doesn't mean anything.
Yeah.
You cannot just ask for money, let's say $2 million or euros, because that looks nice, it's a round sum. No, it has to be absolutely justified.
Yeah, and it has to be pretty specific in the second application stage. Right. Talking about timelines, they will also want to know about the trial duration.
Exactly. And we asked the researcher what he thinks would be the in total, so the overall trial duration. He would like to include 500 patients. And then he answered that so the trial duration to enroll the patients will be 2 years plus a follow-up of 6 months. So all over time period to perform the trial is 2.5 years. So this was the answer. Do you think this is feasible? So does it make sense to you when you think of the overall duration of the trial? Or what do you think? Does he answer me? Did he answer me? Sorry.
2 years of enrollment and 6 months of study duration per patient. Will the overall study duration be 2.5 years? What do you think?
So, I will answer the question, so of course not. Because what he told us is only the time from first patient in to the last patient out. But this is not the overall duration of your trial, because you have to consider there's time to set up your study, to start for the starting phase, so the time until you can enroll the first patient, and you have also to consider that you also need time to close the study. And this would be the overall study duration. And so I'd like also to mention that the startup phase can be very time consuming, because the sites, when you start enrolling, so the sites will not all be activated at once. So this can also be time consuming.
So we would rather suggest an entire trial duration of 4 years. Mm-hmm. And that's not an overestimation, I would say.
For a 2-year recruitment duration, you should at least count for 4 years. Of course, if you apply for funding, you cannot say, I want the funding for 6 years, because then they will not give it to you. So everybody tries to compress it, but it should seem realistic. We all make some optimistic estimates. Without optimism, we would never do studies. But you must consider you will need 1.5 years to start your trial before the first patient is in. And not all and people say, oh, no problem. So I have 50 centers, 5 centers per year each, so that makes 250, 2 years, that's fine. Remember that some of your sites will be initiated 1 year, up to 1 year, the last one after the first one. So it doesn't go like this, right? In the beginning, it's very small enrollment, then it goes up, so you need a lot of time.
Yeah, this is actually exactly what we are showing here. So if you want to select sites to participate in your study, you should have your enrollment target on mind. So how many patients per time unit, let's say months, you would have to enroll, and how many sites would then be required. And as you can see on the right, this is a part of an enrollment curve of one of our studies actually, and as you can see in the beginning, there is kind of a lag phase, or enrollments are pretty low in the beginning, and then they are slowly increasing with the increasing number of sites. So please consider this. Yeah, if you are applying for funding, then you will also have to name the sites, or at least in the first stage, give the number of sites, and then also name the sites. And for that, it will be interesting to have, but also required for a funding application, that you do some research or feasibility survey for these sites. This is mostly done with questionnaires, and these questionnaires will contain questions on the expertise of that site in the field of research or the relevant patient population. Do they do competing studies, which is very important, and do they have the required facilities and so forth. And last but not least, experience in clinical research and confirmed GCP knowledge. One more comment regarding the relevant patient population. So sites will indicate how many patients, let's say per year, in the desired indication they treat, but you need to consider that not all of these patients will be study participants, because they might look like they are suitable on first glance, but then exclusion criteria might apply for that patient, or they might simply not consent. But that is very much depending on the investigator if patients consent. Do you agree?
Absolutely. So this is really something that people say, no problem, I have a lot of friends, they do tons of, they see tons of patients with this disease, that's no problem. So you want to do a study in pulmonary embolism, which is severe, and say to the center, we want 10 patients for you per year. He said, that's nothing. I see 100 patients per year, that will be no problem. Yes, you see 100 patients per year, but we have 30 exclusion criteria because it's a trial, that's not just an observation, and this and that, and in the end, so as a rule of thumb, of patients who are potentially eligible, you include 10%, not 80. So, and this may seem primitive all here that we are saying, we're just having it in a 20 million euro study, that people did not know that this is the case. So, everyone, no problem. They wanted to do an intervention, Dr. Sharp talked about it, want to do an intervention, we do tons of interventions, no problem, we'll have hundreds of patients each year. You must also think, I mean, hundreds of patients each year means that 2 patients per week, and it's a lot of work for the management also, right? And someone has to do the work, you don't have the teams. And one thing that's more important, that does not concern the managers, but it concerns you. You must have, of course, people who complete the formal requirements, and your investigators must be researchers who have what we call equipoise in this question. So if you include, especially for open label studies, if you include investigators, so I want to see that the 2 colleagues are great, you know, they do tons of DVTs per year, okay, but they believe, for example, that anticoagulation for DVT is nonsense. So, of course, then they will take out all the patients who have serious DVT and they will leave some selected patients. And that's not the idea. Then the study is destroyed. So you have to have colleagues who say, yes, we believe that the question is relevant. We do not know what is true, A or B, and we want to test it. And we will include all the patients who could fulfill the inclusion and none of the exclusion criteria. And this is a good study. Absolutely. When an investigator signs a protocol, the investigator must adhere to the protocol. Otherwise, he's thrown out of the study. If he thinks the protocol is rubbish, then he should not sign the protocol and not participate.
Yes, sure. You don't want tons of protocol deviations in the end, of course. Yeah.
Right.
What we have been discussing here is actually leading to the next topic, because enrollment target, reaching your enrollment target, and the entire trial duration has to do, of course, with money. Time is money, and yeah, this is Nadine.
So the next crucial part of your funding application, so this is to write the financial plan. So you always have to adequately budget and adequate your study, so it must be adequately funded. Otherwise, you also will not get the approval from the authorities. so from the regulatory bodies, because it's not acceptable to start enrolling and then early stop the study due to financial problems.
Yeah,
so
that's unethical.
Yeah, it's just unethical. So we prepared for you, as we thought you will be very interested in numbers, to see what such an RCT can cost. So we calculated for you some numbers, and we had, so on the right-hand side you see the key data which are needed. So we will include, as I said before, 500 patients in the trial. We will have all over 10 sites. And the case payment, so the per patient fee will be €700 per patient, and we calculated with a trial duration of 4 years, and then we ended up with about €2 million. And this is not a too high number. You always should expect such numbers when you're planning to perform an RCT. And what's not included here is the institutional overhead. So you always should keep in mind, and please never forget this, to add the financial so the institutional overhead. And yeah, it really depends from where you come from. So does anybody of you know how much the person? Do you know what overhead is?
What is the institutional overhead, for example?
So this is the indirect cost which you need to keep your institution running. So like cost for heating or for light, electricity, and stuff like this, rent. Yeah.
Administration.
So indirect costs, and every institution has it.
Infrastructure they provide, they are paid. It's not the money for the trial managers. They are priced. By the way, these topics are fixed, so we do not say, well, shall we put fees and insurance? No, this is what is fixed. You must budget all this, right? And then, of course, exactly, and then you must always think that your institution, so if you go for public funding, your public funder has a fixed amount, percentage, that is given to the institution. The institution must also not lose money. If you apply to a private funder, then you must negotiate this.
You need to consider that. Calculate that. Yeah, exactly.
In Europe, it's about, let's say, a good percentage is about 25%. That's as it is in Germany. It can be a little more, a little less. In the United States, it can be up to 100%.
Yeah.
So you ask for $2 million, and $2 million are paid on top to your institution. In America, everything is expensive, right? Yeah.
Just. Can you tell?
I don't think so.
There must be. I guess there must be something like that. You didn't consider?
Because the problem is, if you don't do it, at least in Germany now they've woken up, they do not discuss with you. They will, when you ask a company for funding, the company says, great, Dorothea, now you had the first patient in, $1 million. That was what we had agreed, because the money comes in not all at once, it comes in with milestones. Get $1 million, and then you see on your account $750,000. You go to the institution, excuse me, there's a mistake. No, there's no mistake. 25% overhead, this has already been kept. It's not being discussed.
Yeah. Please
but I
keep that in mind.
I don't really understand, because is this something you have to pay, or sometimes the hospital also pays it itself?
No. So
this I don't know. I don't want to interrupt you. This is the cost that the institution has to pay. For example, for rent, there has to be a building, and then you need to pay rent, light, heat, administrative stuff, and all this. And if you are a scientist in this institution, and you want to do research with this institution, that institution will be paid, needs or wants to be paid, and they will just, withdraw some of the funding to finance the institution.
So this will go automatically. So you get not the full what you want to have on your account. So they take the overhead.
So the good thing is if you apply for public funding, you don't have to price the overhead because they know they have a fixed overhead that they give you. Your institution, they call it differently. They call it, so in Germany, Projektpauschale, so this is a once amount, the once a time amount that they give to the but it's about 20 to 25%, up to 30% sometimes. So there you don't want to price it in. But if you go to a private funder, you must be very, very cautious, because if you just budget in what you will spend, or the girls or me or whoever does this job and coordinates, then suddenly you will find 25% less. And it may be, there may be some exceptions, we don't want to go into details, there are some pass-through costs and this is less overhead, whatever, but generally you have to price it.
Pass-through cost? Is that term clear to you? Pass-through cost? Or maybe another question, which of these costs could be pass-through cost?
Pass-through is I give you some money which you give immediately to someone else.
Right. So
it's not for you to keep and play with.
Maybe insurance?
Exactly. Fees and insurance, this is the line, yes. Fees for ethics committees, for example, or competent authorities when you submit. And insurance, which type of insurance would you guess would that be?
Well,
in clinical trials? Sorry?
Insuring the patient?
Yes, private insurance, right. So, yeah, this would be pass-through cost. Anything else?
Patient fees, right?
The case payments as well. Yeah, could you also, yeah. Right. So you receive that money, but yeah, you will pass it on, pass through to the next position. Yeah, just as a disclaimer, this is just an example, and every study should be thoroughly calculated because every study has its individual requirements and cost. And lastly, the overall cost will, of course, depend on the price level of your country. Yeah. So, but this is not overestimated for Germany, I would say. Yeah. Right. And then I think we almost, have run out of time. So, very briefly.
The workshop was absolutely. I mean, we are past 6 minutes past, but this was because we started late.
Yeah. Okay. Right. Okay. Yeah, just very briefly, the network that we would like to have. So what would you propose? Which partner would you like to have or would you need to perform a successful study? Any ideas? Could be internal, external, whatever. And we have touched upon a few of them. Yeah, it's, yeah. So
okay, so keep this short. So this is just an overview of all of whom it's good to have in your network to conduct the study successfully. And I only want to highlight here the legal department because it's very, very important to have a good connection with them. As you have to, or you would like to have more than your own study site in the study usually. So, so you have to contract many study sites. So this why a good connection is good for it. And it's also, or sometimes you also want to contract an RO or an COO. Does anybody knows what this stands for?
CRO
is so this is
clinical research.
Yeah. So the CRO is contract research organization. So they can perform some tasks for you. You can delegate tasks to them, and then therefore you have to make a contract with them. But always remember, so the overall responsibility for the trial they always recedes with the sponsor, no matter if you delegate some tasks.
Any questions, comments on that presentation?
All the others are clear to you, more or less.
Yeah.
So
yeah, I think they are.
And this is why it takes almost 2 years, from a year and a half at least, from the first synopsis to the first patient. And depending, of course, on how many countries are involved and so on. So it's a very long process, reduced now here to 45 minutes. But it's a long process, and of course, So there are many regulatory steps, as we call them, which we have the managers for. So it's not luxury. It is what we must have to do a professional study. But there is also a lot of work to do for the investigator, right? We do not. It's in the beginning, so you don't just ask them. They will write the protocol, because the protocol is a formal document, but without a synopsis you cannot write the protocol, and you will write all the medical parts.
Yeah, right, the medical.
Last question, you wanted to ask something?
For example, if you're running your trial and you receive funding for a fixed period of time, but by the end of this time limit, let's say, you haven't reached the amount of patients you had to, like you designed on the beginning. I'm wondering what happens with the trial, what happens with the money, with, I don't know if you face this situation or...
Yeah,
you can.
Yeah, basically that depends on you. So let's say the funding agency will not care too much. They provide the funding to you, and so this is why we emphasize this process so much. You really have to thoroughly calculate, and it's very important to have the right sites. I would like to stress this, because that would also depend on how fast your study can commence. Because, as we said, legal department is very important. Contracting with sites can be a time-consuming step or a rate-limiting step even. So you have to calculate very well. It is for the, I don't know, in Germany, for example, you have two different funding periods, but yes, overall, you have to calculate, because in most of all cases, if the money is used up, or if the time has run out, there will be no additional funding.
Of course, what is very important is the fact that, as I said, it's like the European loans that are given to the countries that are poorer or have debts. You never get 30 million euros like this, right? You have milestones. So if you say, I need 2 million euros of budget, for example, for this study, and let's say they say, yes, fine, good study, we will fund it. First thing is you get 100,000 euros, then you get another 250 after the first patient, and it goes on like that. So, and of course, you have to send them reports every 6 to 12 months, depending on what agency funds you, and even if it is the industry. So it cannot happen that they hear from you after 3 years, oh, sorry, you know what, we have a problem, we have not included patients. No, they will be testing your patients, and you will be asked. And so you must, from the trialist's point of view, so from our point of view, you must have, with your statistician, also have inserted some interim analysis and adaptation rules to say, if things don't go so well, or we will do a predefined analysis anyway, and if things don't go very well and are not promising, we can stop earlier. So what is not allowed, and it's ethically not allowed, you're doing an experiment in humans, so you not just do your experiment for 5 years and then wake up and found out that that was not a good study. So you are checking we are checking every week how the progress is, and you have to send a report every 6 months, right? So it's and then if the study needs longer and you don't ask for more money, that's okay. They will tell you, okay, we will give you an extension of 6 months for the study without more money. If you ask for an additional reasonable budget, they may grant you the budget, it's not sure. But of course, if they see on several occasions that you are not reaching the targets, then they advise you to find a way to terminate the study. And the only thing you can do in that case, we had it once in a study, so you can go to you always have also an independent monitoring board that has nothing to do with you, and you ask those guys, you know what, we have problems with funding, what shall we do? And they can give you an advice on how to terminate the study with providing some results on the patients without, what you are not allowed to do is just drop the study like this, nothing happens, you owe it to your patients, you owe it to your funders, to everybody. The results, a study that has started must some way, right, be terminated officially. So studies cannot just die out, and no one. This is why all studies are registered initially in the clinical trials called COV-UTRA-CT. It's very important.
Yeah, WHO registered
So there are no hidden studies. So now it must all be very transparent. It's experimentation in humans every trial, and it is very, very, very closely regulated.
Yeah,
20 minutes break.
So if there are no other questions, then thanks for your attention and for your interest in the workshop. And of course, the presentation and also some more information will be available after the Spring School on the Spring School homepage.
Thank you.
Yeah, we'll do 20 minutes, right? So
It's the last but one of the day, end of the conference, and on the end of the spring school. We hope it is... Oh. We hope it is worthwhile. I am Luca Valerio from the University of Mainz in Germany.
And I'm Eric Vico from Paris, France.
So we decided to make it more interesting, also because we cannot really cover the content of the title, Statistics of Clinical Trial and Epidemiological Studies in 40 minutes. It would take 5 years. We decided to make it more practical, and we will go through a series of real-life cases that I found online. If you spend time on the internet, you find interesting things. And you can just comment with what you would do, whether you see problems or things that you would change if you were to write the article or review the article. I have, so therefore we will go through the ideal stages of actually writing the method of a research article and the results. We will touch upon some typical points that we all go through, and I assume you did it already several times. Can we block the automatic animations? The problem is that it is in Greek, otherwise I would do it. And I have a couple of disclaimers. The first one is that these are real examples. Either they were published, and they were published with an open peer review, so we can also see what the reviewer said in these cases. This is incredibly interesting. Or it is cases that I found, or I actually reviewed as a peer reviewer, and I did not cite them, in contrast to what you usually do, also because I criticized these colleagues, and but I anonymized the data. You can block the automatic animations. So this, yeah, you see that there are animations. They appear 1, 2, 3, but you can block them. It is an option. It should be somewhere around there.
I think.
Well, it's okay. If it's too complicated, I will play with the remote. Yeah? Okay. It's okay, we'll survive. The second disclaimer is that because I improvise a lot when I talk, the Professor Vico doesn't take responsibility for what I say, and he may correct me if I say something wrong statistically at all times.
I will share responsibility, no problem.
So let's start with the, let's go backwards or forward. Let's start with the first case. So we have here a typical first sentence of a material and methods research paper. And we can just read it together. I hope you can see it. If you are too far, you may move 1 or 2 places because there is a lot of text in the presentation. But what we write, what we read here is the data of this prospective study were collected in a private dental practice. This is a published study. A prospective non-intervention, do we have a, oh yeah, we have a pointer. A prospective non-interventional study design was used based on the analysis of primary patient data that had been extracted from patient records. We evaluated patient compliance rates with something over 10 years. So just think about it. I will not point fingers as in high school, but you can just think whether you find at least one of these 3 sentences unusual. There is something that should be conspicuous and spring to the eye. Does anybody has an idea of what it could be? Exactly. So despite them writing even twice, this is a prospective study, prospective interventional study design, if it was based on extracted patient records, by definition, it is not prospective. This is actually the definition of a retrospective study. And this allows us to review very quickly what I think we all have had in basic epidemiology courses. This is not statistics, but actually epidemiology, which are the basic study designs. Yeah, we have actually what the reviewer wrote. This is the magics of open peer reviews that didn't exist until 10 years ago. This is a very good comment by the reviewer. because it is perfectly correct, in my opinion. If the authors evaluated the data after 10 years, the study is not prospective but retrospective. If the authors designed the study 10 years ago, and they have collected the information during 10 years following the patients, then it's prospective. The key is, which is the position of the researcher in the timeline. Because in epidemiologic study designs, we have two timelines. The first is the timeline between the variables, the exposure, which we assume to have to be the cause of the outcome, and the outcome. And the other is the time sequence between the occurrence of these events, the variables, and the moment that we decide to make the study. We define our variables and we collect the data. If we apply this approach, these two timelines, we have the simplest is the cross-sectional study in which the exposure and the outcome, so it could be a risk factor and the disease, or treatment and the outcome. And in this case, they are measured at the same time. This is a classic snapshot in time. Of course, we have a lot of biases in this case because we don't know which one came first. And this is a typical chicken-egg problem, confounding bias. And of course, there are several measurement problems because the value of one of the variables can affect the probability that we find a specific value in the other variable. Slightly better are studies in which we first identify the outcome. I like very much the researcher or detective icon. We identify cases. This is typical in rare diseases in which it would take too long to wait for a disease to occur. And then, based after we have identified the cases, we look back in time again to check whether they had an exposure. This is, of course, you have guessed it, a case control study. It is slightly better. The reverse causation is less of a problem because we make sure that the exposure occurred before the outcome, but there is still some residual confounding and, of course, other biases. Slightly better is that we decide at some point in time, as our colleagues from the Faculty of Dentistry somewhere in Germany, to go back in time and at the same time collect the data of exposure and outcome. We do not first collect the data on the outcome, then based on those, the exposure. We make sure that the exposure preceded the outcome in time, but the moment that we decide to define our variables and perform the study is afterwards. And this is therefore retrospective. The first word indicates the position of the researcher in the timeline, and it is a cohort study or follow-up study or longitudinal study, and this word indicates the sequence between exposure and outcome. So one word is the position of the small detective in the timeline, the other word is the relative position of the variables. Even better is if we decide beforehand what our definitions are, where and how we will collect the data, and afterwards we wait for the events to occur. In this case, we still have the word cohort, follow-up, or longitudinal because the exposure precedes the outcome, but we use the second word for the second sequence, prospective, because the researcher decided everything beforehand. Confounding remains, but decreases progressively, and also all types of misclassification bias, for instance, recall bias, decrease progressively. Of course, there is another study design that doesn't fit in the slide, which is randomized clinical trial, in which confounding is almost removed, so I would write it green, but even though confounding always remains.
Just to add something regarding case control studies, you should be aware that case control study indeed is a very difficult study to do. It appears very simple, but in fact, to do the thing really in a proper way, it's very difficult. Why? Because it's very difficult to have the right control. Case, it's easy to get case, but control is very difficult. Very often, for instance, we see control as patients in other department and things like this. These are not good controls because if they are in another department, they are for other reason, and the contrast is not a good one. So you should be aware that in the story of medicine, there have been many mistakes in a case control study. So really, when you have a result based on a case control study, you should keep in mind that many mistakes have been done with this kind of studies. The other thing is regarding prospective and retrospective. A key point is the quality of data and the choice of the variables that you study. if you have done clinical research, you know how difficult is the collection of data, even for a randomized controlled trial. So, obviously, if you consider a database that has been filled like this for 10 years, the quality of the data very often is not good. And obviously, if you have decided 10 years after what to collect or what to collect in a database, the quality of the data very often is not good. So the quality of the data is something very different in prospective and retrospective study.
Very well, we go to the next sentence in our ideal methods. It is important to know that this was a study that looked at the determinants of some problems at childbirth, so such as preterm birth or low-weighted birth. That was the outcome of the study. You come across this paragraph. 1 second. This is a lone-standing paragraph, meaning that this is the whole paragraph, I didn't cut it, called covariate. They already announced that they want to do a multivariable model, a regression model. It had, I think it had both logistic and linear regression, but that is irrelevant now. And you read this paragraph as a reviewer. It's a long paragraph, and it is a little bit more difficult to understand what's the problem here, because it's not that something is wrong, something is missing there. It's always more difficult to find something that is not there and should be there. But if we read, everything seems all right. Maternal and paternal age at childbirth was categorized. Maternal psychotropic medication was defined as dispensation with the medication period overlapping the pregnancy. So it's also about pharmacology and psychiatrics. Paternal and maternal psychiatric disorders diagnosed prior to childbirth were ascertained based on having at least one diagnosis, and so on and so forth. It seems very thorough, right? Socioeconomic status was defined by paternal and maternal education length, tables, references. But what would you expect in a paragraph, in an article using a multivariable model with the title covariates? Are you satisfied? So this will be a multivariable regression model with as outcomes these typical problems at childbirth, and they announce all of these covariates. But what would you want to know as a reviewer or as a supervisor or as a PhD student? What would you write? So this is the point. So what do you need to provide?
An odds ratio or hazard ratio?
But, yes, so that would be an association, but that is the methods, that's not the results. You mean the odds ratio and hazard ratios from where?
Which describes the association between the covariate they wanted to assess in the model and the outcome, which is the outcome at childbirth.
Exactly. So what is missing is a justification of how the variables were selected. Why these covariates? Why this very specific thing, psychotropic medications? And indeed, this was just to show that it was indeed a complex model where they tested the independent association of several covariates with preterm birth and low-weighted birth. But how did they select these covariates? And this is a very important problem. The reviewers, again, realized this, and they directly asked, how were the covariates chosen? And especially add more reasoning and justification on how confounding variables were selected for the adjusted models. And they say, of course, we will do it. We added references and so on. And this is very nice to see, because this is the final published paper. And you can see that it is exactly the same paragraph that I showed with we categorize ages and so on, but they added the sections in green every time justifying why that variable had been added. Maternal and paternal age are well-established risk factors with reference. Maternal use of antidepressants and so on has previously been associated with many maternal and office-related outcomes. Genomic studies have identified genetic correlations between many psychiatric disorders, which is why they included as a potential confounder psychiatric disorders. So the bottom line is that you need always to justify the choice of covariates in multivariable models. And to the best of my knowledge, there are only two valid ways to do it. One is what you said, so previous research that already showed associations, at least univariate. So they are potential confounders because they are known to be associated with the outcome. But another very good one has nothing to do with statistics. It's plausibility. This is where the scientific method starts. It must be just a biologically or clinically plausible hypothesis. And I wanted to mention very quickly a family of techniques that in the last 20 years have become very popular, which are automatic variable selection methods. There are several. They are implemented in most of softwares. Maybe you know them. For instance, this is an example of backward elimination. They started with a model in which they added 50 variables, and then there are processes based on p-values or model performance that check with what the minimum number of variables is that works best for the model performance. So from these 50, they obtained, this was a score for bleeding risk, like there are already 30 of them, and they ended up with these 5 variables that are already included in all other bleeding risks. But it is very important to be careful with these methods because they have been proved to be biased in several ways.
I think that's a very important change in the view regarding multivariate model and covariate that occurred in the last years is the fact that you have to justify the choice of this covariate from something external to your study. It's not because in your study you have a correlation that you should take into account a covariate. It's because externally of your study you have, for external reason, the demonstration of this association, that you should introduce this covariate in your model. This is a complete change that occurred in the last 10 years regarding multivariate modeling. And it's very important. And why is it important? Is it important because you should consider that any multivariate model is, in some way, the best model to predict the past. Is the best model to predict what occurs in your own sample. But what you want to do, obviously, is not to predict the past, it's to predict the future, or to predict what happened for another sample in another hospital, and the question of the generalizability of your result is crucial for multivariate analysis. And if you only take information from your own sample, the possibility to generalize your result is minimal. So what we want is to avoid this, what is also known as optimism of a model. Optimism of the model is the fact that your model is very good for your own data, but not for others. So introducing all information external to your sample is a good way to introduce covariates or information for a multivariate model.
Very well, so we proceed to the next sentence in the methods. After you have specified the statistical method and justified how you choose the variables, you may write something like this. This is also a standalone paragraph, so this is the whole paragraph. It was just these 3 lines, I didn't cut it. So the baseline data of some cohort, comprehensive cohort, contains 30,000 participants, very well, representing over 3.7 million Canadians. Of these participants, 28,000 completed some questionnaire. Given missing values on some measures, the actual sample size used differs somewhat across measures. Would you be satisfied with this paragraph describing, providing information on the study sample? What are you not satisfied about? What would you add or remove?
So what's the study sample? So it's somewhat different, but the article does not say what's actually the sample size.
Exactly. So what kind of information in particular could you provide or should you provide if you wrote or reviewed the paper? I would say, given missing values on some measures, which measures, how many missing? And even more importantly, but just as important, what did you do with the missing? Because there are several things you can do with them. Dear reviewer, there needs to be substantially more information on the amount of missing here. In particular, which measure are the most missing, which measure are the least missing. If it is greater than 10%, there may be some problem. And the second thing, just as important, how were missing data handled? The reviewer helped the authors, I assume, through listwise deletion. This should be stated. The point is that there is always a point in the methods in which you should say how many missings you had and how you handle them. Nobody will believe you if you pretend you had no missing. There are almost always missing in clinical biomedical data. And the authors handled this elegantly with just 2 sentences. This is all it takes. Missing values were deleted listwise in a multivariable analysis. Missing values were minimal, ranging from less than 1% to 2.6%. This is enough. It doesn't take 200 percentages for 200 variables if you provide a range and show that the worst that happened was 2.6%. These are the 2 points. And well, one common thing that is done, especially if the missings are limited, is this so-called listwise deletion or complete case analysis, just removing the missing, but then showing that they were not too many, and maybe doing a small sensitivity analysis to show that they were not too different, they were not too old people, all old people, they were not all of one sex, gender. One other things that you could do, that maybe some of you have done, are more complex methods, such as multiple imputation, maximum likelihood estimation, but you need to say what you did with missing data.
Yeah, just to add something that is very important regarding missing data, two comments. The first one is that if you consider missing data in multivariate model, you should consider that any missing data well, I would say, the multivariate model will only consider complete case. So if you have, for instance, 2% missing and a model with 10 variables, for instance, and if it's not the same patients, in fact, you have 20% missing, even for your analysis. Because the model will take into account only complete case. So that's very important to consider this aspect. And the other aspect that is crucial is to think about the reason for missingness. So the question that missing is, I would say, completely at random or not completely at random is very important to take into account the fact that your results can be biased by missing value. If missing, or in survival analysis, for instance, if censorship is informative of something about the patient, you should take this into account in the interpretation or in the method that you have to use in order to analyze your data.
And we have a final point, typical part of the methods, definition of the outcomes. This would be an example from a much, in this case I simplified it because it was a little bit more complicated, and I even highlighted the more important elements because there is a lot of noise. The death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and the site of the pregnancy, that is maternal death, an international standardized WHO definition. And then maternal mortality rates were computed per 100,000 live births. If you have experience with this kind of indicators, you have already gotten where I'm getting at. But can you see at least some question arising on these 2 sentences? So they are defining this outcome. This is actually a measure of disease frequency, technically. Maternal mortality rates. They were defined as death of a woman while pregnant within 42 days and so on and so forth, per 100,000 live births. This is a subtle point.
Why per live births, not why per pregnancies?
Exactly, so that is the point. It's not that this indicator is wrong, but the curious thing is that, to say it more explicitly, the numerator is not included in the denominator, because a woman can, if the woman can die before termination of pregnancy, there will not have been a live birth. So it is not, some women in the numerator didn't make it to the denominator. This opens the big chapter of the most used indicators in epidemiology and statistics, which are measures of disease frequency for binary variables, 0-1 variables. There are several. I originally had a much more complicated slide, but then I found in a good book this picture, and I used it. And, you know, all divisions in mathematics could be called ratios. You can talk to mathematicians and they will confirm that if you have two numbers and you divide one by the other, either writing the typical column or a fraction or calculating the result, that is a ratio. Mathematicians will be okay with it because they have more complex things to think about. But in epidemiology, we define at least 3 different entities based on what we feed into the numerator and the denominator. And we can distinguish them in this way. If the numerator is included in the denominator, then the next question is whether there is time at the denominator. So it is months, years, minutes, days. Then we have a rate. A rate is always some kind of speed. You can calculate derivatives, integrals with it if you are familiar with those. And of course, the value can range from 0 to infinite. If time is not in the denominator, we have a count of maybe individuals in the numerators and a denominator that it's a superset of those individuals. So all individuals in the numerator are also in the denominator. We have a proportion. I added risk because a risk also has all individuals in the numerator in the denominator, but a risk is a probability. So usually the event in the numerator occurred after the baseline denominator, but it is a proportion. It is an odd-dimensional number between 0 and 1. If the numerator is not included in the denominator, you are just comparing two numbers. You are free to do it. There is no law against it. You are comparing whether the numerator is larger than the denominator, in which case you have a ratio higher than 1. If they are identical, the result is 1. If the numerator is smaller than the denominator, the result is between 0 and 1. And of course, you can get up to infinite. So knowing this, if we go back to, so this is a side point that we can discuss. We don't have a lot of time, but knowing this, what would you say this is actually? Is it a rate, a risk, a proportion, or a ratio? It's a ratio, technically. Very good. So this is, technically, it is a ratio. But however, this is a widely debated point, and back in the 70s and 80s, if you open those books, they called all of these measures rates. Technically, this is calculated per year, so they are trying to get an information over time. But to be very specific, this is a ratio, because the numerator is not included in the denominator. And the denominator is not time, it's not months, it's not women month, which could exist as an indicator. Shall we go on? Now we move to the results. This is actually, it gets very easy now. This is just a seemingly minor point, but if you want to do research at a good level, you need to think also of these things. This is a paper that I reviewed, and actually from the field of venous thrombosis. And yeah, so of the 150 patients, 53.8% had DVT. Very well. Of which, this is questionable English, but this is beside the point, 29%, so not 29.8%, but 29% had left lower limb thrombosis. So I thought maybe 29 is 29.0, and they felt that the 0 was not important, but it's okay. 13% had right lower thrombosis, 10% again, maybe 10.0, had bilateral lower limb thrombosis, and 1.33%, very precise, had upper limb thrombosis. I was getting a little confused, and I thought that they wanted to distinguish the perfect third of an integer number, third of a unity, so that is 1.3 periodic, 33333, and they say, okay, they are very precise. But then later on, I saw 8.27%, and I realized that my theory didn't hold. So they are just randomly reporting frequencies with no 0, with no decimal places, with 1 or with 2, just randomly. This will never kill your paper. If you are publishing a revolutionary trial on the New England, they will shut an eye on this. That is not a big problem, but it may confuse readers, especially if the subject is complex, the reviewer is sleepy or whatever. And there are a lot of rules actually about this. I would always recommend to have a clean article, not cluttered by numbers, to report categorical variables, of course, as percentages. First, always give numerators and denominators, which didn't happen there. You have read or written several good articles, I'm sure, with the typical 10 out of 15, therefore 75%, and so on. And the decimal places, most of the time in biomedicine, one decimal place is enough. If the sample is smaller, just integers. If the sample is very small, don't even use percentages. It doesn't make a lot of sense to say 18 out of 20, therefore 90%. And whatever you do, be consistent, not like those authors. A similar problem we have, I will be quicker here, with continuous variables. Of course, you would use measures of central tendency. And in this case, the question arose in me anyway, whether it makes sense to report 100s of years of age or 100s of BMI. If you are physicians, would it make a difference whether the patient has a BMI of 27.44 or 27.49? Probably not. And even for these, there are values. Never forget not to round numbers during the analysis, only when you present them. Analyze the raw numbers. And when you do round them, 2 significant digits have been suggested, this is a very nice, old but nice article, to be the highest number of significant digits that we can get. Significant digits are all the digits different from 0 starting from the left, so irrespective of the position of the comma. And summary values should be rounded to, I would say, the same number of decimal places, or at most one more. Do you have any comment on this? This is a very simple topic, but precision in science is important.
Just to mention that, for instance, New England Journal, they ask also for any percentage to put the numbers, numerator and denominator. And this is also very important when you consider the things like it was in the slide, that you consider percentage and then percentage of the percentage. So just put the number in order to be sure that the reader can really understand what you want to say.
That is true. That also happened in that article, because one was a sub-percentage of the DVT. That's true. Yeah. We go on with this table, also from a paper that I reviewed. I simplified it a little bit. What do you find, not necessarily wrong, mind you, but potentially questionable? Would you do anything different? Would you have any question to ask if a colleague of yours or an author sent to you this table? And one step backward and forward. So we have gender, males, and that's it. And then notice how you have a series of continuous variables. What are those numbers? What are they probably? Should have been in a caption, but what do you think they are? They are probably means of standard deviation. I should also point out that it is not, the plus minus is not a very good way to report a standard deviation, but this is what they are, indeed. This is what you would expect, and this is what they are. Is it always correct to do that? You have 20 continuous variables, you just report means and standard deviations. It's not always correct. The point of standard deviation, we all learn it in also, this is also chapter 1, paragraph 1 of all textbooks. It makes sense if the variable is continuously distributed, because what does it mean actually if it is not continuously distributed? Nothing. You have a number and you cannot do anything with it. If the variable is normally distributed, then you know what it means. Then it means that plus minus that value include 68% of the data, plus twice that value or minus twice, 95% of the data. But if the variable is not normally distributed, you can better use the median, the 50th percentile, and instead of the mean. And then you just use the interquartile range, because for the interquartile range, the 25th to 75th percentile, it is always true that that includes 50% of the data. Then the question becomes, how do I check that variables are normally distributed? This is also a long debated question. The easiest way would be to check it visually, but then it is quite arbitrary because in my experience, everybody sees what they want to see. There are the old tests from the 20th century that are also included in most softwares, but they are not very reliable. I want to give you a very nice trick that I've always liked, a very simple numeric trick. If you see a mean and a standard deviation, and the standard deviation is more than half the mean, you already know it. It's a magic trick in my mind that the variable cannot be normally distributed unless it is a quantity that can be negative. But in biomedicine, counts and blood pressure, it cannot be negative. And if twice the standard deviation includes negative values, then it is impossible. And if you go back to the table, this is very typical to days to the occurrence of an event. They will not be normally distributed in most cases. And indeed, time from injury to orthopedic surgery, 5 plus or minus 2.9, which means that something like 5 to 10% of the patients had the injury after the surgery that corrected it, which is impossible. So let's not forget this basic point. Do you have any?
Yes,
yeah.
I think that the fact to use the median is a very good thing. I really like the median very much, median and quartiles, because I think that the information is very much more robust, because any mean can be completely changed by some outliers, for instance. And so it's not valid, it's not a good information, it's not a robust information. If the information that you give is dependent of only maybe 2 or 3 patients, it's not a good information. So a median is much more robust and should be used very often instead of mean. And especially, as mentioned, Luca, for any time to event data. For instance, hospital stay. So you know that the duration of a patient in hospital is so highly dependent on what happened to have the possibility to send the patient in another department, in another hospital. So it's not something that is that can be considered as a mean. But median value is a very robust way. And the other thing that maybe we will discuss after, but the question is that in any case, you should adapt, you should be coherent regarding the way you describe your central tendency as mean or median, and also the test that you will use as parametric or non-parametric, and the type of figures that you will provide to the journal. So I think we will discuss this a little bit after. Yeah.
Next point, because we are seeing the results and we stay in the typical table 1. Here is our table 1, in which you cannot really read the details, but you don't need to. I just found it very quickly online because there are so many of these table 1s. What is a very typical feature of the first table in the results published in Scientific? Oh, sorry. What is a very typical feature of table 1, the first table that describes the sample in a biomedical research paper? And it is very, very common in this case. Several of the mistakes that I am describing are rare. Most people don't do it, but this is actually very common. It is also not completely wrong. What strikes you of such a large table? Very, very common. There is one specific column, p-values. What's wrong with them? What's wrong? You don't need to read the specific p-values. It's their sheer existence that is troublesome. You know that a p-value is by definition, when using the 20th century definitions, the probability that the observed result is lower than 5%, assuming a certain distribution. However, this means that if you test several, in 5% of the cases, even by chance, you will find statistical significance. And yet we systematically compare in table 1 of almost all research papers two variables, usually the two levels of the exposure, sometimes the two levels of the outcome, and we always give the p-value. Is this a good idea? There is a lot of debate on this actually, methodologically. It's not completely wrong. There are situations in which you might want to do it. I found this very nice information. The number of p-values is increasing. It even doubled in the proceeding of the National Academies of Science in 20 years. 5 to 9 p-values per article, even in Science. In Nature, quite higher quality. It increased slightly. I don't know whether it is statistically significant. Maybe we should do 3 p-values on this. And, but the question is whether it makes sense. Let us stop 1 minute and ask why would we do that? There are reasons to do it. One reason to show table 1 is simply to show the sample characteristics, to prove that your findings are generalizable to a specific population. So if there are only women, maybe you can only generalize to women. If there are only older patients, it's generalizable to older patients. For that, you don't need p-values. You only need one column with medians or means and percentages. In an observational studies, we may want to compare the features of the levels of the exposure to show that we are then adjusting for the right covariates, as we already discussed, potential confounders. However, we already discussed that that is not a good way to select candidates for multiple adjustment. You better refer to other external findings, previous literature, or to your hypothesis, not to what you find in your own data, knowing that 5% of the correlations will be statistically significant. If you have a randomized clinical trial, at which I wish to you all that you publish a randomized clinical trial, why would you do that? You don't need to prove randomization, and you wouldn't with p-values, because even in clinical trials, again, you will find 5% of statistically significant associations. And if you look at trials in the New England, there are never p-values in table 1. This is a very large topic, and we can discuss on the appropriate use of p-values, but
yes, I will say first, obviously, no, it's clear in any journal, in any good journal, they will not accept p-value for table 1 for randomized study. So regarding observational studies, another story, I will say, because that says something that the difference that you have observed in your sample is not, maybe not due to, is not only by chance. And if you consider what you already know about the importance of some covariates, you can say, okay, this difference tell us something about the associations between, for instance, male and this parameter, or female and this parameter. So it's an information that can be important for the interpretation of data, not for covariate adjustment, but for interpretation of data. The other, I will say, message that I want to say now regarding p-value is a very simple message. The less p-value you have in your paper, the most convincing paper you have. So the best paper is a paper with only one p-value. And I really suggest to you to read the guidelines, the statistical guidelines by the New England Journal of Medicine, published in 2018, where all these aspects are really focused on, and you will see that, well, the way to use p-value is highly selective. You have one main criterion, basically. That's why for this criterion, you should make a test and provide a p-value. For all the other, you have to discuss very precisely. Either you just give the information about the difference with confidence interval and you don't provide p-values. if you absolutely want to provide p-values, you should use very specific methods in order to adjust for the multiplicity of the test or to do some kind of what is called a hierarchical strategy. That means that, for instance, for all your secondary criteria for a randomized clinical trial, for instance, you should specify the order of the variable that you will test. And then the hierarchical strategy, we say, okay, I begin with, for instance, my main criterion. If the main criterion, if I have a significant difference for the main criterion, I can test the other one. If not, I will not test anything more. So that means that you can have a paper with one p-value larger than 0.05. That's a possibility. If the main criterion is significant, you begin to test the secondary criteria, but you begin to test the first criterion that you have listed a priori. And if it's significant, okay, you can put the p-value in your paper and try to test the second one. If the second one is positive, you test the third one. But if, for instance, the first secondary criteria is non-significant, you will stop. So it's possible to have papers with very, very few p-values, and they are not less convincing, but more convincing than papers with 10 p-values with 10 secondary criteria. So that's really a very important change. I will say the most rigorous journal at this time is the New England Journal of Medicine regarding this aspect. But others begin to be more rigorous too. Not at the same level, but Lancet, not at the same level. Circulation, not at the same level. But the idea is the less p-value you have, the better is your paper.
Very well, so our time is up. We have a last very easy point. Just a very quick question. If you have a continuous variable, one variable, you want to show its distribution, could be age, could be blood pressure, what plot would you use? This is very simple. So how do you show the distribution in 100 patients? Would you use this plot? Which doesn't even have a name, I don't know, a linear dot plot, I don't know. I find this is a very weird idea. Does it really describe the distribution? Do you find any message? There was probably 400 patients with a weird disease and they wanted to show the age distribution. But if you look carefully, you cannot probably from where you are, but there are exactly 10 dots between the age of 10 and 20, 10 dots between 20 and 30, which means that the level of precision is year of age, which means that this dot could be one dot, one patient, it could be 100 patients, because they overlap. We will never know. So we actually don't get any information from this plot, except the fact that for younger patients, children, the data was more granular, so the precision was probably in months, because you see this is the only age range in which the dots are not equally distant. This is just a reminder to use the appropriate basic plot types for the appropriate variable type. So not only the right test for the right variable, but also the right plot. And in this case, it would be a histogram. And this is actually how we, in a collaborative paper, described exactly the same. It is quite more informative. Ignore the fanciness of the density plot, but a histogram is the right way to show the distribution of a continuous variable. And let me remind you of the fact that you only need 5 basic plots for 80% of your research. For a categorical single variable, you use bar plots, counts on the y-axis. For continuous variables, a histogram. If you have a categorical variable and the second categorical variables, so it could be sex and the disease, you use simply a dodged bar plot. it doesn't change much from a basic bar plot. If you want to add to a categorical variable a continuous variable, use box plots. They give you the opportunity to show median, mean, interquartile range, outliers, and so on. And then if you have two continuous variables, that's the easiest of all, you use a scatter plot. This is what you need in 80% of the cases. Then there are a couple of fancier plots, but in most of your career, these will suffice. And don't use that strange plot that probably was generated in Excel by that paper. That was it. Thank you for your attention.
Maybe an additional question, a short additional question or comment. No? Okay, thank you for your attention.
Good afternoon. I think we still have to wait some minutes because the previous workshop is still ongoing, but just 2 minutes, okay? And because of technical problems. But now I know that technical problems are solved, so we can just start with the first case. So we are going through thrombosis in unusual sites. So these are my conflict of interest. And let's start with a clinical case. So please be awake, because this is an examination. So the first one is Sabrina. Sabrina is a young woman. She is 35-year-old, and she's admitted to the emergency department because of abdominal pain. And in her medical history, we have substance addiction. So at time of admission to the emergency department, these are the laboratory examinations: a mild leukocytosis, 12,000 of white blood cells, mild anemia, and mild thrombocytopenia. Some mild abnormalities with coagulation and reduced creatinine clearance. And despite she was referring an ongoing treatment with estroprogestin therapy, anyway, we decided to perform a pregnancy test, and it was confirmed to be negative. So what is important in my view is that at clinical examination, the patient had signs of bowel obstruction. For this reason, the emergency physician decided to proceed with CT angiography. And as you can see, I'm not sure whether it works. No. Maybe with this one. No, okay. But this is the liver, and you can see the conjunction of the portal branches with contrast medium. And if we proceed with the scans, you can see the conjunction of the splenic vein with the portal trunk. And in the next one, you have a huge thrombus in the mesenteric vein. So the diagnosis is done because the patient has mesenteric vein thrombosis. And in the, let's say, further examination, an infection with liver virus C was found, and according to the clinical presentation and blood examination, a diagnosis of liver cirrhosis was done. So it's not completely surprising because you know that cirrhosis is a risk factor for splanchnic vein thrombosis, and at the same time, the patient was on estroprogestin therapy, so despite the young age, she had 2 risk factors for splanchnic vein thrombosis. And if we look at the localization of thrombosis, you know that the majority of splanchnic vein thrombosis are located at the portal vein, about 35%. This is a case series, a large registry indeed, from the Mayo Clinic. But then we have 20% for superior mesenteric vein and 20% for splenic vein. So overall, we are among the most common situation, while we have some rarer conditions, and in particular, the Budd-Chiari syndrome is only represent 5% of the overall splanchnic vein thrombosis. And in this registry, you also have some additional information because the authors compare the clinical course of splanchnic vein thrombosis with that of thrombosis of the lower limbs, and they found no difference in terms of recurrence. Consider this is an observational study, so there is no randomization, and the duration of anticoagulation is not fixed. So all what we can say concerning recurrences is despite the duration of anticoagulation. But we have some difference in terms of survival, as you can see, probably because of the severity of acute clinical presentation in a considerable proportion of patients with splanchnic vein thrombosis. You know that the first complication of mesenteric and portal vein thrombosis may be major bleeding from the gastrointestinal tract and mesenteric infarction. So these 2 conditions are quite common in patients with portal or mesenteric vein thrombosis. And in this case, mortality is usually occurs in the acute phase of the disease. But let's go on. Let's stay on Sabrina, 34 years old, so a young woman, and she has signs of bowel obstruction, and she has a huge thrombus in the mesenteric vein. So what do you do in your clinical practice with such a patient? So do you prefer a continuous infusion of unfractionated heparin because you know the patient may have the risk to require surgery, or we know that we have the risk that the patient has a major bowel bleeding because she has infarction of the bowel, or the other option is to use anyway parenteral but subcutaneous anticoagulation, or you prefer to go directly with an oral compound. So who is for unfractionated? Okay. Who is for LNWH or fondaparinux? Okay, that's fine. And who is for an oral? From the very beginning? No one. Okay, first of all, we have no data from randomized trials. So please forget level 1A evidence. This is not the right clinical setting, but what we know is that if we look at what happened in the ISTH registry on unusual site thrombosis, this is a publication by Walter Regino, you know that about 50% of the patients overall receive LMWH of fondaparinux. We have an additional 10% about of the patient that is treated with unfractionated heparin in the acute phase. Then you have the you have to note that there is a certain proportion that varies from 30% for bad Chiari and portal vein thrombosis to 15 to 10% of other localization of splanchnic vein thrombosis that receives no treatment. And this is important in my view because this gives you the proportion of patients with very severe presentation. These probably are the patients that requires in the very acute phase surgical intervention or interventional maneuver to stop bleeding. Because you know that portal vein thrombosis is associated with portal hypertension, so the risk of variceal bleeding. And if we look at a recent meta-analysis, this has been released just some weeks ago. This is a meta-analysis of case series observational studies, so don't, again, forget randomized comparisons. But overall, if we compare what we can get with anticoagulation in comparison to non-anticoagulation, we can increase the rate of splanchnic vein recanalization in a significant measure. But what is probably more important, we can reduce progression of thrombosis and we can reduce major bleeding and overall mortality. So don't forget that this specific localization of thrombosis may be fatal because of acute abdominal bleeding and perforation and complication. But if we go to consensus documents, because it's really hard to write down guidelines when you don't have the evidence. So if we go to consensus documents, this is an ISTH consensus, and this is really interesting from my point of view, by a clinical point of view, because this is just like some very useful suggestion. First of all, divide your patients based on the presence of very severe clinical presentation, shock, increase of lactate, peritonitis, perforation, intestinal infarction. These patients should be treated before anticoagulation by the surgeon, by the interventional radiologist, by endoscopist, or whatever you want. But before anticoagulating this patient, you have to solve the critical situation at the abdominal level. For all those patients that don't have active bleeding and don't appear to need rapid proceed to operative room, then early anticoagulation is important because of what we were saying before, reduction of mortality, reduction of thrombosis progression, and so on. Second point that is interesting in this document, in my view, is the suggestion against thrombolytic agents. Have you ever used thrombolysis in patients with splanchnic vein thrombosis in your clinical practice? Not for Fionnuala, not for Stavros, yes.
Not us directly, but after discussion, the interventional radiologist wanted to do it in a patient with cirrhosis and portal vein thrombosis.
Yeah, but this is a suggestion because this is something that is done in clinical practice. I think that the position against from this document is related to the high risk for bleeding in these patients. And again, the lack of evidence, but the lack of evidence is still there also for other recommendations. So this is not the, but I think that the first point is to highlight the high risk for bleeding and the potential risk for the operative theater. And another classification that is really, in my view, important in this consensus document is to classify the patient based on the presence of cirrhosis or the absence of cirrhosis. And in these two groups of patients, different approaches for anticoagulation are suggested because, as you can see, in the absence of cirrhosis, then full therapeutic DOACs are suggested. And this is really interesting because none of you choose this kind of, let's say, approach. Do you want to comment on that? Any question, any, don't know, thoughts that you have? Is it a, let's say, did the authors of this document drunk because they recommend to use DOACs, or do you think it's an option? What do you think about that? Menno, please.
Fully aware of the lack of evidence. You know, sometimes you like to make a decision, and I really see no point, you know, if there is no cirrhosis, no liver dysfunction, to start a DOAC in these patients. And of course you might always come with the, there is no trial, but as you said yourself, this is a evidence-free zone, as it is often called, and in spite of this, and while waiting for, what would be never come, because who would do a randomized trial on these patients? It will always be clinical decision making, and the view that the other anticoagulants are safer, that is based on nothing else. Yeah. So I would choose for practicality a DOAC and just follow this patient, and that is my view. But other colleagues in the Leiden University are much more prudent, including Eric Klok, and he likes to stick to evidence.
He's younger, he's not prudent, he's younger.
Yeah, he's 1 year, he's still younger, but then he's of the same age as I said this morning. But seriously, so he tends to try to stick strictly to guidelines we have in our hospital, which we made ourselves. And then so you hang yourself, and I say, come on, Eric, we have to move forward. And people like, patients like DOACs. That's also important.
Well, but your comment is really important, because this is why I was asking, because obviously we have no evidence. There is a cohort study of consecutive patients with portal or mesenteric, anyway, splanchnic vein thrombosis treated with rivaroxaban that has been submitted. So the study is completed and results have been submitted to the American Society of Hematology this year. So I hope that the results will be released soon. This is a cohort study. We have no randomization. And as I was a participating center in this specific study, I have to admit that the real concern on the use of a DOAC in these patients relates to the very beginning. When you have a patient that have a severe abdominal scenario, and in this particular condition, until the resolution of the very acute phase, you don't have an antidote, so it may be somehow, let's say, I'm sorry, concerning using this kind of agent, even though you don't have an antidote also for LMWH. So in that case, or you decide to use unfractionated heparin, or to let's say, use whatever dose of protamine sulfate, or otherwise it's not very, very much different to use a DOAC. But anyway, the principle here is that if you are able to reach therapeutic anticoagulation, the patient will go better. And this is different for cirrhosis because you know, we repeated several times during this meeting that DOACs are contraindicated if you have severe liver damage, that means child PANC C. They are not completely contraindicated in child A and B. But anyway, first of all, check, let's say, stratify the risk and the severity of your liver disease, and then you can get a decision also for the DOACs. And the other point is that your patient also has another important point, that is that we made a diagnosis of cirrhosis during this admission. So we don't know anything concerning the presence of varices. So the other point that all the guidelines say before, let's say, discharging the patient, before, let's say, stabilize anticoagulation, please check for the presence of gastroesophageal varices, because this can make the difference. And the other point in our particular patients is the coagulopathy, let's say, because you can remember that she has mild thrombocytopenia. So does it impact on your decision concerning anticoagulation? Would you use anyway a therapeutic dose? Would you be prudent? Would you whatever? The patient has 68,000 platelets. So again, we are outside the evidence, so all your answers are correct. Don't mind.
I wouldn't use full dose, for sure.
Okay.
When I expect that patient may need urgent surgery, then I really would go for unfractioned heparin. We don't really, yes. If patient is stable, if patient don't have any indications for the surgery, then probably I would use low molecular heparin, but in this case, I wouldn't go for low molecular heparin.
LMWH at therapeutic full dose, or would you adjust for something? Don't know.
If I would use low molecular weight heparin, then LMVH I would use in reduced dose. In fact, I don't really have much experience with those patients, but probably in case of cirrhosis, I would rather go for like 75% of it. I would reduce the dose. You would
reduce. But, and this is the point. Now we have an acute scenario due to abdominal obstruction and abdominal infarction. So maybe we also have to wait until this acute scenario resolves. But the issue of patient with liver disease that requires anticoagulation also during stable phases of their disease is quite common. Yes. And indeed, the only indication we have concerning thrombocytopenia concern cancer patients. So we don't have that much evidence on patients with cirrhosis, and what we know is that the indication, the suggestion again, because these are consensus, these are not real guidance, but what is the, let's say, much supported consensus is to stop anticoagulation when platelet count is below 25,000. While until you are above 50,000, you can also go with full dose LMWH or even a DOAC. In this case, you know that thrombocytopenia in the majority of cancer patients is transient. In this case, you have a patient that has an acute scenario that has a chronic cause of thrombocytopenia, so maybe that the use of intermediate of prudent dose may also be the right choice. But anyway, after the initial phase, when you also have evidence on presence or absence of gastroesophageal varices, probably you should get a decision and take the patient to therapeutic anticoagulation.
And I would like to ask you how you verify that patient has gastroesophageal varices.
You need an endoscopy that in the very acute phase is not the best
exactly,
moment to do it.
The only way for me to do it during, for example, night shift in my hospital is just ask the patient and believe that he's telling the truth.
After patient, sorry?
Ask the patient,
ask the patient. No, yeah. But in this case, this kind of patient doesn't know. If you know that, then you have, again, to be prudent, and now we will see why. But if you don't know, you have to wait until obstruction resolves. Because I think that no one of the endoscopists will perform the examination while the patient has an acute clinical. So my point is, okay, let's imagine that everything is going well, that the patient received 3 months anticoagulation without any complications. So what is your decision? What to do in this young patient with such a severe thrombotic disease for prevention of recurrences over time? So would you choose for 3 months? Because overall, you may consider that as the patient was on estrogen therapy, thrombosis is provoked. Or you think that 3 months is enough because the patient has a high risk for bleeding. Do you prefer to, let's say, consider that cirrhosis is a persistent, a permanent risk factor for thrombosis, so you prefer to use lifelong or anyway indefinite anticoagulation? Or you believe that splanchnic vein thrombosis has a low risk for recurrence, so 3 months is enough? Who is going for 3 months? Please raise your hand. Someone. Who is going for indefinite treatment? A bit more. So again, no, don't expect data from randomized trial. This is again the results of the IST. These are the results of the ISTH trials. So if we look at the clinical course over time of patients after an episode of splanchnic vein thrombosis, and we categorize these patients based on the association with cirrhosis or non-cirrhotic disease and non-cancer, because you know this is another important risk factor for this localization of thrombosis, then you should face a high risk of bleeding over time. And this is mainly due to the presence of varices and to the presence of coagulopathy overall. But what is even important is that, as usually it happens in clinical practice, also the risk for a recurrent thrombosis is higher than that of patients with no cirrhosis and no cancer. So again, and if we look at the specific incidence rates that have been reported in this specific registry, in patients with liver cirrhosis, you face the highest incidence of bleeding, 10% per 100 patient year, higher than that of patients with cancer. And the highest risk for recurrent thrombosis, 11.3% per year, in comparison to cancer patients, myeloproliferative disorders. So I have to say that in this case, cirrhosis is a nightmare because you need to anticoagulate the patient, but you should also face a very high risk for bleeding. And in this case, compliance is really important. But if we look at different consensus and recommendation, and if we focus on those patients with persistent risk factor as cirrhosis, then the indication is to proceed indefinitely with anticoagulant treatment. So, and this is my last slide, some take-home messages. In the very acute phase, please consider that you should assure the patient therapeutic dose of anticoagulation, but you should also adjust based on the presence of varices and the presence of an acute bleeding at the time of diagnosis. So consider early variceal screening, and in case this is positive, you should also add something, beta blockers or something to prevent bleeding, and duration at least 3 to 6 months, but consider indefinite anticoagulation. Yes, please.
One remark, re-imaging. Re-imaging, because that's what we sometimes say to each other, and then in the routine workup of the liver problems, or per se the ultrasound. Could you comment?
Okay, the gold standard, let's say, for the diagnosis is obviously CT with contrast media, so with the CT angiography. And this is because you may often have a good visualization of the portal trunk by ultrasonography, but it may be difficult in a patient with an acute situation of the bowel to have a complete visualization and to follow the mesenteric vein. So in the acute phase, CT. For the follow-up, it depends on whether you are sure that you may visualize correctly, fully, the splanchnic veins by ultrasonography. Because if the residual is there and you are able to make your follow-up check by ultrasonography, so you may reduce the radiation dose to the patient and proceed with ultrasound. In case you are not, in case the involved vessels are not completely and fully visualizable by ultrasonography, then you may require a follow-up CT scan, and this is because you want to reassess the presence of collateral circles, of portal hypertension, and so on. But this is important also for recurrence event, because if you have the patient again in the hospital with an acute abdominal situation, is it recurrence? Is it let's say, the previous episode? So this may be the case. Yes, please, we have radiologists here.
No, I do believe that in patients who have liver cirrhosis or are cancer patients, the dose of CT really doesn't matter.
Yeah.
I mean, it is quite low at the moment. The CT abdomen is 1 or 2 millisievert. In like 10 years ago or 20 years ago, we would accept 10 to 15. I mean, then there was a discussion, but now with 1, 2, people won't die when they have liver cirrhosis or cancer to the radiation. Never.
Yeah, you're right, and even the age in this case, this patient had drug abuse, she had cirrhosis, so maybe that radiation is the last of the problem. But this is in a general way, when you have some episode of unprovoked thrombosis, then you can also, let's say, take care of this aspect. But I agree with you. And as you're here, any chance to make follow-up examination by NMR?
Yes, it is possible, but you have to need a certain expertise in your center. Mm-hmm. And MRI capacity is always a problem in every hospital.
Yeah.
I don't know, maybe in some hospitals it's really good, but in our hospital there's always a shortage. So, and CT is much more available. And much easier and much faster.
Okay, okay. So quite a good answer. Okay, so please, may I have the next set of slides? Because we are moving from this case to another one. As you know, this workshop was in conjunction with Eric. Eric is not here, but he sent his slides, so we are going through the next case. If you are not so, let's say, so tired and you want to go to the beach or to the sea, because we know we are in Crete, so.
I think we can have another 13 minutes.
Yeah, okay. Yeah, fine.
Because then we will have our feedback session and everyone has
okay. Okay.
For the special dinner.
Yeah, this is the right one. Yeah, okay. So again, a young woman, so this is not a good day for women, I'm sorry for that. And she is 32 years old, she has no relevant medical history. And again, she is an oral contraceptive. The prevalence of the use of this drug is really high. So, but she's coming to the emergency department because of new onset headache. So she's complaining headache in association with some signs of intracranial hypertension. But we also could say that these are signs that really that commonly associate with headache. So she has nausea, she has some disturbance with the light and with phonophobia. Should I put in presentation? Yeah. Okay, don't know what happened. Yeah, okay, that's fine. And so the point is the suspicion of the emergency physician is cerebral vein thrombosis. So again, we are not asking to the radiologist, but to the physician. So what is the, let's say, the gold standard for this kind of diagnosis? Do we have a clinical decision rule? We have the Wells score, the Geneva score for, let's say, deep vein thrombosis and for pulmonary embolism. Do we have such a score for cerebral vein thrombosis? Who's answering? How do you do in your clinical practice? Do you use the dimer? Because you know, headache is quite a prevalent symptom in the emergency department. So we should use some, let's say, something in order to keep a decision. Okay, so firstly for a CT scan, in order to exclude what?
In order to exclude any pathology, intracranial pathology that may be the cause of the pain. And I think that it's a quite common...
and may you have some information regarding cerebral vein thrombosis at a cerebral CT scan, or it's completely normal, completely negative?
In fact, patients with those problems usually go to be consulted by neurologists, and I don't really see them in internal work in cardiology. Okay. Yeah.
Does someone want to comment on that? Is cerebral CT just, let's say, something that we do for exclusion of other diseases, or may it inform also on the presence of cerebral vein thrombosis? Good question. She's on estroprogestin therapy. So this is one point, and this is quite important. Unfortunately, she doesn't have any focal neurological deficit, so the neurological examination is negative. But in order to get to set some points, we don't have, as far as today, any clinical decision rule that is validated in this specific site of thrombosis, despite we know that we may have some specific clinical, let's say, scenarios, and we may have some information on the dimer, because we have some preliminary evidence that if the dimer is negative, then thrombosis is unlikely. But I'm not sure that if you have a, let's say, significant clinical presentation, you can decide not to proceed with examination based on a negative D-dimer. So I think the data we are up to now are quite preliminary. Yeah, please.
Cecilia, could we say in such a case, I mean, what this patient has, I understand she has no focal symptomatic, she has photophobia and phonophobia and headache, right?
Yeah.
So what we are not neurologists, but what we are sometimes involved. So in such cases, if there is a history of migraine and she has had such symptoms in the past, then of course the first diagnosis would not be imaging. But if there is not such a history...
The first episode, specific, let's say, severity and so on.
Yes, but if there is no such history in the past, I believe there is no way this patient will not undergo imaging, whatever anything else says. So in practice, I think she will always go for imaging. And I would agree with a colleague. I mean, most probably the fastest thing to do will be a CT scan to make sure she has no huge tumor or whatever. And then, of course, everything else can be sorted out.
Okay, Manu wants to comment.
Yeah, just a short comment on the size of the thrombus, because we are dealing in cerebral vein thrombosis, not always, of course, there are larger thrombi, but usually, of course, it's a smaller thrombus in my experience. And then what is the dimer level? And there is some correlation we have looked in pulmonary embolism, others have looked in terms of increase of D-dimer, of course also depending on the days of complaints. But so I'm not sure that D-dimer, and I don't know if a formal study will guide you enough to say that if it's normal, there is no thrombosis or the chance is very remote. So I agree completely with Stavros that clinical suspicion really should lead the way here. And that is also sometimes tricky because the presentation is sometimes quizzical also for neurologists. And then lastly, it's of course not a patient that comes directly to us. So we're talking here about indirect knowledge, if you agree with me. And this is really the, as you said yourself, this is really the area of the neurologist. Less so with splenic vein thrombosis, but cerebral sinus thrombosis, you really leave this to the neurology.
Yeah, and in order to, let's say, confirm what Menno was saying, not because he needs confirmation, but because you know that this is the anatomy of cerebral vein, and you can see that you may have a huge, extensive thrombosis of the superior sagittal sinus, but you may also have small thrombosis of the transverse or straight sinus, and in that case, the thrombotic bulk may be really different. So the expectation of ruling out cerebral vein thrombosis by means of D-dimer is really optimistic. So, and I also agree that if you have a thrombosis, if you have a headache that is the first episode, so no story of migraine, the most severe episode, and a rapid onset of symptoms, then you should proceed to CT examination. And CT again, probably also because the availability, and maybe the patient has another situation and is rapidly visible on CT scan, but you also may have some indirect signs of thrombosis also by cerebral CT scan, and this is an example, because you may have, as you can see, the visualization of fresh thrombus by the cerebral CT scan, and some indirect signs with the administration of contrast median, and sometimes, in particular where you have involvement of cortical veins, you may have bleeding directly visible in the first CT scan that you perform at diagnosis. And this is really important because usually it's a very cortical bleeding, and this is the reason why the patient may have seizure. So, but after that, usually you have to confirm your diagnosis, and in order to assess the extension of cerebral vein thrombosis with NMR of the cerebral veins, and please be aware because often if you don't require specifically angio-NMR usually explore the arteries. In that case, you have to ask for the visualization of the veins. And in this particular patients, as you can see, you had the absence of the transverse sinus, of the left transverse sinus. So now the point is, you have a diagnosis. So are we managing these patients like all the patients with vein thrombosis, or are we starting with anticoagulation, parenteral, oral? Are we planning an intervention for revascularization? What is your indication in this specific patient? Are we using intervention for cerebral vein thrombosis? What is the risk of anticoagulation, and so on? Who wants to? Please go ahead. Just oral anticoagulation. Okay, do you agree? No one knows. This is a good question. This is a good question. At this specific spring school, in 2 years, we hope we will have forget this issue. Okay, so our colleagues is asking for platelet count. May you imagine why? Vaccination. So at admission, platelet count was normal. And so in this case, we cannot exclude because really the patient was vaccinated. And you know, the association with thrombocytopenia should be there in order to make a diagnosis, but still we don't know. So, but the question is important. Does it influence your clinical management? Why?
In case of vaccine-induced thrombocytopenic thrombocytosis, we would use steroids, prednisone.
Yeah, and no anticoagulation.
And anticoagulation also.
Okay, which one?
Okay.
But I think everything is fine because no one knows. So, but the indication, you know, is to avoid heparin. And we will see why. So this is important to, this is why I asked for you. So first of all, I have a general comment. The risk for this kind of patients is cerebral infarction, that is a venous infarction, so is prone to become hemorrhagic. But anyhow, please, colleague, we should be courageous, we should be, let's say, brave, because the risk of death in these patients, if we don't use therapeutic anticoagulation, is really high. So even though we have some blood in the cerebral CT scan, the treatment of cerebral vein thrombosis is anticoagulation. So I know that it makes some, let's say, tachycardia, but this is what we have to do. And you may choose between parenteral or oral. Maybe that for these specific patients, I would avoid oral from the very beginning. You know, we have one study with dabigatran, and this is the only evidence we have. But also in this study, dabigatran was given after heparin lead-in. But for your knowledge, we have only 2 studies, very small, with unfractionated heparin and LMWH. So this is all of the evidence that we have in favor of heparin. So this is not that much different from the DOAC. So this is not completely, let's say, incorrect. But due to the risk of cerebral hemorrhage due to venous infarction, then the indication from current guidelines is to use heparin, okay, in the very beginning. And what about intervention? Okay, because it depends on the clinical, let's say, ground. Because you know that not all patients will improve rapidly after the initiation of therapeutic anticoagulation. So if you have, let's say, you should monitor closely these patients, because if you have signs of stabilization or even improvement, then it means that your treatment is, let's say, is effective, that you are in the good way, and you should proceed with anticoagulation. But if the patient is deteriorating, then it means that something is not going well, and you have to do something more. What is something more? Again, we are moving in a very fragile floor, but you may also believe that endovascular treatment may be indicated. We are in a different situation because you know that current treatment for stroke is thrombectomy, is embolectomy for those patients who arrive to the hospital in time. So we are quite experts in removing arterial thrombi. There is much less experience in the venous setting. But this may be an option when your patient is deteriorating, when consciousness is decreasing, and you fear for death in this patient. So, and this is our situation, because as you can see, after day 1, the patient is worsening, and what we observe is the platelet count is reducing. So this is the point. So these laboratory results are really warning when we are anticoagulating the patient with acute cerebral condition. D-dimer is very high, but this is not something special because the patient has extensive thrombi. And this is why physician talked to a VIIT, because platelet count is reduced, because she has an extensive thrombosis in an unusual site, because the clinical course is unfavorable. And in order to, let's say, from suspicion to diagnosis, you know that cases not several, but cases of cerebral vein thrombosis has been described after vaccination. And you know that recently, very recently, a paper has been released, and this paper recommends, let's say, give some criteria for a diagnosis of vaccine-induced thrombocytopenia. And they say all 5 of the following should be there. Onset of symptoms that is timely related with administration of the vaccine, presence of thrombosis, lower than 150,000 platelet count, and this is our condition, very high D-dimer, positive anti-PF4, ELISA testing. And this is quite interesting because you know that before of these documents, all the guidance, all the consensus says that PF4 ELISA is not enough in order to diagnose VITT, but functional test is required. Indeed, if you check in the literature, you will find out that the majority of the patients that were diagnosed, that were published in the literature, didn't have a functional test for heparin-induced thrombocytopenia, because it is not available in the urgent setting, because we were not aware, several, let's say, conditions. But again, the test was performed, it was positive, so the patient had this kind of diagnosis, and she was managed by interruption of heparin and introduction of argatroban. Why? Well, because we know that anti-PF4 antibodies may be present in patients treated with heparin. So this is not, again, evidence-based, but it's common sense to use a different agent. So I see that Stavros is rushing, and we have closed our patient case. Thank you very much for your attention.
So perfect. And this, as the airlines used to say in transatlantic flights, this completes our entertainment program. We are landing in 40 minutes, but before landing in 30 minutes, there is some work. Maybe now we can, I believe we can switch off the projector. We will not need it. And we will have a truly active session, really maximum of 30 minutes, not longer. And no, that is true. First of all, the housekeeping information. We will be ready here at 7:15 or 19:15 or 19:20, the latest. We would be very happy if you could join us, let's say, short before 8 o'clock in the evening. We asked for a little bit earlier dinner, but it's very difficult for the hotel, so they have to carry all, you know, all the chairs and stuff there, so they do need this time. So at 8, the official start of the dinner is at 20:15, but we would be very happy if you could join us a little earlier, and we can say very few final words, nothing to do with VTE or thrombosis, and then of course you will eat and you will never hear from us again. And of course Emeno will be speaking the whole time everywhere, but I mean we will not be speaking about the spring school. So this is one thing. So then you will be able, we will see you down there at the restaurant, which is, you know, by the seaside. So not here upstairs, so we will go down to the seaside. It's not so close to the beach, it's a little bit further away. So this is one thing. And Menno, I think we will say the final words there, right, regarding the school itself. But now we would like to hear from you, as we always do. That's the tradition. Within a few minutes, we will do brainstorming, so we do not need to, you know, do a very, very structured thing. We do as... Yes, for 2023, if we are all alive and well. So we want to hear from you. First of all, also to let you know, Katarina will send you all an evaluation form that we will very kindly ask you to complete and send us back, send to Katarina. This is important for EBAC, that gives us the CME points. You know that from every kind of a conference, right? So that's very important. So when she sends your emails, please do not trash them, but send back the evaluation form so that we must be okay with EBAC for you to get the CME points. Now, please feel free to freely raise your hand and make some suggestions how you believe that the spring school can be improved if all goes well and we do it again in 2023. Anything, where we do it, how long we do it, what the content should be, what the form should be. Please say your ideas and we will put it all together and we circulate it in a couple of days. Is the length of the school appropriate? Is it too long or is it too short? Who believes it is too long? Okay. Who believes it is too short?
Can you comment? Yes. Yeah, you want to be here 2 weeks. Yes.
More free time?
Yes. Because I think there are a lot of workshops and a lot of lectures just in 3 days. So I think maybe you could make it a bit longer, but with yes.
This is like a harmonic.
Yes.
It started with 5 days.
Yes.
And then we did minutes.
That is exactly so. That is, of course, something that I must tell you, we have thought of this ourselves many times. We started with 5 days. Yes. So when we started the spring schools, we came in on a Monday afternoon. We started Tuesday, Wednesday, Thursday, Friday, Saturday, and Sunday morning. That was very long. The problem is, back then, that is 10 years ago, it was a little easier to ask, I mean, younger people, the older faculty to stay with us, because the idea of the spring school is that people also stay here and stay together as a group. And we had the phenomena of many accomplished faculty members who came in for 2 hours for a lecture and then flew back. I mean, what will you tell them? But this was not the idea. We reduced it to 4 days. So we went back, we went 1 day back. So we did two spring schools with 4 days. That was okay, but this was again found to be a little too long. We had the same phenomenon. This year, we did not have many defections from the faculty, we must say, almost none. So from the point of view, because when you are here, you want also to be able to have the people with you. We do not want to have speakers come in for 8 hours and then fly back, because then it's... So it is very well taken, but we cannot... What do you think, Menno? What is your idea on this?
Yeah, your idea is nice, but we'll not proceed with it. But anyway, thanks for the discussion.
A young researcher, there is a young blonde researcher who wants to say something.
Lilian.
I'll try again. I think everyone has to be live here. All the speakers and...
yeah.
So all the speakers must be in Greece.
Yeah, so
no screens, no online.
You mean your colleague?
No, I don't mean
She didn't mean anyone. She just wanted to speak about a radiologist. I mean, she didn't mean anyone.
No.
Yes.
No, that's an animal. Growth? What was its
name? Leave me, but
it's okay, it's okay.
Just
so,
so
it should be here, not
streaming. Yes, no streaming, because it gives a lot of fuzz and it just...
No.
I think it will talk easier if everyone is here.
Of course. So first of all, this gives us, of course, the information. We've said it again. We must really congratulate again our technician team that did a great work with streaming. So hybrid is a nice and easy word to say. It requires a lot of competence and expertise to do. I think overall it worked great. I believe we all agree that this should be a live event. And I must tell you, I'm extremely relieved tonight, because until last week, I believed there would be something in the last minute and we would not be allowed all to come here. So this did not happen. This will remain a live event. Whether we will have a very strict rule, because there will always be someone who will not be able to attend. I must say the only faculty member that was unable to attend was Michael Sproul. Sproul, yes. So Michael, and that was also the only one who came in contact with a known COVID-19 case in Glasgow. So that is also, so here in
his daughter.
His daughter, yes, yes. So, by the way, Professor Sharp just arrived in London, and he had to do a COVID test, which Kara so he found out that he would pay £500 if he did not do the COVID test, and he found out this afternoon. So we arranged a rapid test very briefly, very fast for him. He did it, and he was negative. So until now, there seems to be no massive spreading of the virus. That's some good news for tonight. So, what I want to say is we fully agree. I think it should remain mainly. Whether we will prohibit, let's say, we'll have no exceptions for people. And Michael was someone, you know, Lillian, he stayed, he did want, he was very devoted. But in general, yes. No, we don't need to discuss it. I think we fully all agree that it's absolutely agree.
Okay. Yeah. Now it's coming on. Oops.
Benno, now I'm thinking of Joe Biden, who keeps running all the time.
It's about the workshop. I think that if it could be a little bit longer than 45 minutes, it will be maybe better, because as soon as we start discussing or talking with the expert, it's the end of the workshop, so it's a little bit frustrating maybe.
So,
I think a very interesting point. This is also harmonica syndrome, because
so
we used to have it for 1.5 hours, and we thought it was a bit too much. So this will go perhaps to 1 hour, and you forget that you have
maybe
to go
Katarina can also write in parallel, so that I do not forget. So this is an important point. One comment on this, because we had it also in the hands-on workshops, where there really it is too short, because until people get to see, to use the device and get back from the device and whatever, it lasted too long. So there are two things. So now we will do a very small referendum for you, because when you make a proposal, we have to say, Menno, 1 second. So the question is the following. Do you want us to, there are 3 things that we can propose to do. One would be to go back to the old regime, which would mean you are offered 12 workshops, and you should only follow or attend 8 of them. You can choose which to attend, which means we have 3 in parallel. This year with COVID, it was not easy, but let's say 2023 it will be easy. So you choose 8 out of 12. This worked well for 3 workshops. Problem with this was, of course, that some workshops were less well visited, and this may be, I would say, insulting for the moderators, right? I must be very fair. So this is one solution. The other solution is we reduce the number of workshops to 8, which of course will mean less faculty, but some radiologists may stay at home, who knows, right? She said yes, yeah. No, but no, that's serious. It will reduce the number of the faculty. And the third solution would be to offer, and we cannot extend, of course, because we already have them for 12 hours a day, but we could at least go up with the hands-on, that's a compromise to go on with the hands-on for 1 hour. So maybe we can ask who would be in favor of having 12 and choosing 8. 1, 2,
and then it's a bit longer, isn't it? Correct?
No, it would be. Then it would be okay. We would have 3 in parallel, provided there is no COVID restrictions, right? We would have 3 in parallel, but then, of course, they would not be able to attend all workshops, because now they were able to attend all. Okay, I said what the side effect would be, of course, right? We might, but so how many would be in favor of this solution? Please raise hands again. 1, 2, 3, 4, 5, 6, 7, 8, 9. 23, approximately. So who would be in favor of reducing the number of workshops to 8, and then you attend all 8?
And longer.
And longer, of course.
Because that was the argument of yeah. But how long? Up to an hour?
1 hour.
1 hour.
I think if we go to...
for 8 for an hour?
So
8
let me count.
Hour.
Let me count. So that's 25. That's a little bit more.
Did you... Did we exclude the double voters? Because there were some double voters.
So I hope there's no double voters.
But we video everything, so we can check afterwards. Okay.
No, 8. No, 8 overall. And who would be for the intermediate solution? We keep this large number of workshops, but we would increase the hands-on only to 1 hour, because there definitely you need more time to move from place to place. 1, 2, triple voter. 1, 2, 3, or double. 1, 2, 3, 4, 5. Yes, so we do not have many.
That's a loser.
Okay, so I understand this is of course a small difference. More people, but this is a very small difference, would prefer to have 8 workshops. So there is no perfect solution, right? If we have 8 workshops, yes, please? Want to propose something? Yes. There's the fourth.
Going in front.
Yes, well, I do agree with the hands-on that we maybe could have more time to all practice, but maybe the other workshops can still be 45 minutes in my opinion, but there could be less of the PowerPoint presentation. In my opinion, there was a lot of PowerPoint in the beginning, and then what my colleague also suggested afterwards, there was a nice discussion, but then it was 45 minutes, so maybe a bit short of the PowerPoint and more the interactive discussion.
So.
Yeah. I think that's an excellent point.
That's a good
the
motion.
workship should have
10 slides or something.
Slides,
yeah.
So we have to instruct the preparers.
So can we improve therefore the question based on this suggestion and say, so who would be in favor of 12 workshops? All 12 you participate in all 12. We increase only the hands-on, but we limit the number of slides to be shown in all workshops, let's say to 10 and not 25. Oh, okay. That's so that's $24. So now that's a good. So now it's like German elections. I mean, all parties. So, okay, 20, but this might be, so because you know, this might be, let's say, the safest, the smallest, the lowest bleeding risk, right, solution.
So again, what is that?
That would
number maximum 8, and then 10 max slides, and the workshop are 1 hour.
12 out of 12.
Oh, 12 out of 12.
12 out of 12, like this time. In that case, only the 2 hands-on stay at go up to 1 hour, all the others are 45 minutes. But slides to be shown are let's say, maximum of 10, for example.
Yeah, and that leaves room, more room.
Yes.
Okay, where we started. Okay, now I suggest we go to the next remark. There are remarks. This is Trump. Oops.
I have just a small suggestion for the technical moment for demonstrating posters, because I mean, it's either to increase the number of displays, or if it's not possible, to probably have a chance to display 2 posters at the same time, because switching between posters wasn't that comfortable.
So this is a good idea. But I must tell you, I am considering our starting point, I was extremely happy that we could have 6 screens for 12 people, because of course the optimal solution would be 1 screen per person. That would be 12 screens. Another solution would be to select half of the abstracts, but we did not want to do that because that was good work by our people, and I think you all made such a great impression. We will think of ways to improve the poster presentation. I think it's already much better. You were not in the previous workshops where people were going around the actual workshops, so there were 30, 50 people going behind, and some people fainted, and Cecile, you had fainted, or there was some, you had fainted, right? I mean, so there were some,
yeah.
So there was some, so that's an improvement already. Of course, it would be optimal, right? Don't have a ready answer, we'll write that down.
Yeah, write it down anyway. Another 6 screens, why not? Okay. Another remark. I think there were, oh yeah, please.
Thank you.
Well, my remark is about one proposal regarding a session. We talked a lot about guidelines, the implementation. There was a poster session, but maybe we could offer the participants to show their clinical cases also, because in our clinical practice we often meet some cases that do not fit guidelines, and we have to do quite unconventional decisions regarding treatment or diagnostics, and there are questions remaining, and this faculty is a very good platform for that. Maybe the proposal could be, maybe there were too many cases, so the faculty could choose 5 cases for presentation, you know, with deeper analysis.
Yes.
I think it's a very attractive point. Of course, in the workshops, I was Giannakoulas, there was no evidence, so there were in fact cases, but of course prepared by the faculty, and this is coming up from the audience. We have to think, because pre-selection I think is necessary, but I think it's a nice idea.
I'll tell you what my experience is on that. The experience is that it's a great idea and everybody says great, and then you ask people to bring cases, and then only very few of them bring cases indeed, and then you have an organizational problem on site. So what we can do is, well, we said already that in the workshops we will minimize the slides to be shown by the moderators to a small number, which can be defined exactly. So we can then ask the presenters, we will then ask in advance, do you want to bring cases? But then, of course, we'll 2 or 3 slides, right? Not 25 slides each, right? 2 or 3 slides. And then, of course, the moderators, right, can reduce their talk. So I think we can accommodate it.
Yeah, and another way would go, I mean, if you see the program, you think, hey, what case did I have? And it's not so difficult to prepare 1 or 2 slides for a patient that you see, but you didn't have the answer. And then you can bring them along at the risk that it's not discussed with the whole group, but we also have the interval, and then you at least can bring this paper case or electronic case. So I like the idea.
It is written down.
Yeah, good. Next one. I think there were more. Did you? Yeah, please.
Yeah, it was about the lectures. Maybe I would have the pleasure to have a basic science lecture just on one theme. And on pharmacology, this morning it was very great to have a lecture on factor 11 pharmacology. And the other thing is maybe discuss the details of protocol ongoing trials, because all of the faculties are involved in ongoing trials, and so we could have the protocol and just work on it, on the hypothesis and the variables, and know better the protocol itself and why this protocol. Just 1 or 2, it's not that much, and it will be very interesting to go into details in understanding why the question has been raised, how to manage it.
I mean, we did offer a trial, not a protocol thinking on the protocol. We did offer a clinical trials workshop. I think it was necessary. Let's say, I believe we could have had, we had some very competent remarks, I think, but also the participation of the attendees can also be improved as reverse feedback. I think there was little participation. I must also explicitly thank Nadine and Dorothea that started something which is not a conventional workshop. So regarding the protocol of, so 2 things, as Menno knows, we have had enormous luck. I'm not a basic researcher, I mean, but so again, from my experience, but for today's topic, we had, of course, a great talk by Marcel Levy. We were really very happy that such a person gives an inspiring and attractive talk. In previous spring schools, when we tried to have basic lectures, the problem was that 70% of the audience was dead later. So that is a problem. So if you all promise us that you will sit here and ask questions, then it's good. But I mean, these people come in, no one participates, the people sit like that in the air.
Yeah. You know, it's your personal choice, and I think it's a very valid one, and it is an idea. Maybe you can think of one more. So we had the idea to invite Marcel, because I know he gives a translational talk, and he's a clinician. clinician. And ideally, you would see, I would see it that the clinician who has experience in that brings us one more story, okay? And that is pretty close to pharmacology of factor 11, isn't it? But I agree that some good basic stuff as part is good. And the clinical trial protocol discussion, I agree with Stavros. Now we had this workshop, and I agree that
we will develop it further, of course, right?
But that can be changed, and then instead of that, it's maybe more on the theoretical. Just 2 examples. And Hypito, I mentioned it. That was a lot of work and preparation, but as a model for how you prepare such a route can be very instructive. That I think is what you mean. Okay. Other points? Now's the chance to change. Yes, Sarah.
Thank you. Having both workshops in a small room, I think, worked better. I think the discussion was better upstairs than in the bigger, if COVID permits, hopefully.
Yeah.
That's a no-brainer. Of course, we prepared, but it was impossible this year because we had to stick to the regular. And this was all the mess, you know. I mean, you are here, no, you are there, because we had to have many people here. So we are very happy we were at least able to be all of us here, and until now no one has fever or chills or anything, right? But so if all goes well, in 2 years from now, most definitely we will do it that way. It is not our intention to have big rooms. Yes.
Okay. Other points? Cracking your brains? You always can give us feedback after. Of course. Good, but the experience is now it's warm. Now it's in your head. So please think a bit. There was an idea of, I'll tell you myself, of presentation by Andrew Sharp. He sent it to Stavros me. He has a video installed in his, cath lab. And he was thinking of bringing cases including this video. Now, of course, we do not want a movie here, but you can think of different presentations connected to your remark of clinical cases. And then, of course, this kind of interventions are as an example, attractive. Yeah. I don't know.
But we don't want to have a TCT or Euro PCR.
No.
We cannot make competition to these people, and they
have
tons of money.
Yeah, agreed. Other points? Are you thinking already of drinks and dinner?
Probably, right?
I do, but let's give it 1 or 2 minutes to think. Okay. The big question is, of course, where I started. Will there be, and how will be, another spring,
maybe
Euro spring school?
Maybe one question. Yes. So first of all, we do. I will be very honest on this. So we most definitely, every time, I have said 4 times, probably this will be the last spring school, and we have made it. So that is good. I mean, so, you know, it's like the big singers, right? I mean, you write your first song, you have a huge success, then the second song is usually not so good, and most of them disappear. So we managed it to the 5th album, but now, so we hope that this also depends on sponsoring. And as I said today, and it should be kept in mind, I mean, the revolution is over, and the revolution means also the investment in, but of course, the anticoagulation and thrombosis, but of course, the topic remains highly relevant, as we saw. So let's hope, and we strongly believe that we'll be able to do it. One question may be organizational. Would you, if we did it, would you like to have it in Crete? Would you like to have it again somewhere else in Greece, or would you like to have it? I'm not doing it in Italy or Spain or south of France. I'm sorry, I love them all very much, but I mean, somehow that's the deal, right? I mean, if we do it. But the question is, would you like to have it here, or would you like, or do you think that's enough of doing it in Greece?
Who's in favor of, if it's there again in 2023, do it here in Crete?
Okay. So that's a little over 50%. Okay.
Who wants it in Germany?
Who wants it in Leiden?
Low. Okay. That's a clear answer.
I think that's a good answer. That's
okay.
Yeah. Okay. So
switch off.
We will do
and see each other at 8 sharp at the restaurant, which is very close to the beach. So before you walk into the beach, you have the restaurant.
So some
You can't
people,
miss it.
some people with a doctoral thesis asked me how you get to the beach. I said, just look where the sea is and go down somehow. So don't... See you later.
And even nicer is just close your eyes and hear where the sea is, but that's another.